Hey guys, am I audible, visible? Very good morning. I hope I'm audible and visible. If everything is good to go, let me know and let's start discussing pathology. Good morning, Prem Shuk Chakar. Good morning, everyone. Hope you're doing good. All set for your big date. Just maybe 2 weeks left. Good morning, Munir. How was today's class? Good? Tiring and exhaustive class? So I'm Dr. Ranjith. I'll be taking pathology for you. There are going to be 3 subjects discussed today. One is path, second is orthopedics, third is community medicine. So today path will have close to 20-25 questions in your exam. Community medicine has close to 30 questions in your exam, and orthopedics maybe 6 or 7 questions in the exam, right? So maybe 50 plus questions can definitely come from today's lecture. So let's stay till the end. As usual, 6 days, let's do a sprint. After that, take the copy which is with you, annotated. We also will give the annotated PDF, but I'll be happy if you can self-write it, and then let's go forward from there. Fine. Okay. Good evening all. Good evening all. Let's start. Perfect. Amazing. Super. Happy for that. So let's start. I'll be asking simple questions. I want you to be more interactive here, make mistakes here so that you don't make mistakes in the main exam, right? That's the whole concept here. Let's learn here and let's implement in the main exam. Fine. Let's start with general pathology. Quite a few questions from FMG comes from general pathology, hemat, and a little bit of systemic pathology also, right? So these are very simple things, right? So necrosis, we'll start with the basic common thing about necrosis. Can anyone tell me necrosis pathological or physiological or both? Necrosis is definitely the type of cell death what we see. Is it pathological, is it physiological, or both? Necrosis is undoubtedly only pathological. It's not physiological. The physiological form of cell death is apoptosis, like you guys already know, right? I want you guys to interact. I want you guys to comment. Put N or A or one word. That should be more than enough, but I want you to definitely comment it, right? Perfect. Great cell learning, right? It's pathological form of cell death. Apoptosis is a physiological form of cell death. This is pathological. Apoptosis can be both physiological as well as pathological. Necrosis is only pathological form of cell death, right? We have different types of necrosis. We have coagulative, hello Nathan. We have liquefactive, we have caseous, we have fibrinoid, and we have fat, right? So what is the most common type of necrosis? Generally, we see that whatever comes on the top, we say it's the most common, right? Can anyone tell me what's the most common type of necrosis? Undoubtedly, it is. Perfect. The most common type of necrosis is undoubtedly coagulative necrosis. Coagulative necrosis, by default, will be seen in any solid organ infarct. So you can have an infarct of the heart, you can have the infarct of the kidney, you can have the infarct of the liver, whatever it is, spleen, whatever it is. Any solid organ infarct, you will undoubtedly have coagulative necrosis, right? And the most important thing in coagulative necrosis, the architecture will be very well maintained, right? So architecture being maintained is a microscopic finding where you will see, okay, it's a kidney, it's a glomeruli. You can see the glomeruli, and also you can see the tubules, but it will be dead tubules. I can exactly see how the tubules look. It's a dead tubules. Perfect, Ashwin. Except brain infarct, we'll have coagulative necrosis. Can anyone comment on what is a brain infarct? That's the next question for me, right? And the mechanism of action of coagulative necrosis is undoubtedly your protein degradation. Protein degradation is the mechanism of action of coagulative necrosis. Okay, you have perfect, great, right? So mechanism of action of coagulative necrosis undoubtedly a protein degradation, and liquefactive necrosis, like you guys said, will be seen in case of brain infarct. Fine, great. So necrosis or any type of necrosis in the biopsy, can anyone tell me what will be the color? Will it be pink? Will it be blue? Or will it be clear? Not just coagulative necrosis. This HNA is for every subtype of necrosis will have the same color in microscopy. Microscopy necrosis undoubtedly be only pink in color. I won't have any blue color because blue color is for nucleus. Nucleus will be gone in case of necrosis, right? Again, this for every necrosis. Can anyone tell me the nuclear changes which can happen in necrosis? There are 3 changes. I am sure you guys know that. What are the 3 changes? That's amazing. What are the 3 changes what we see in case of a necrosis, nucleus wise? First, the nucleus becomes very small. We call it an pycnotic nuclei. Perfect, Hemant. Next, the nucleus becomes bracken. We call it karyorrhexis. The next nucleus becomes lysed. We call it karyolysis, right? Amazing, right? So we have pycnosis. We have karyorrhexis. Rhexis is breaking. Then we have karyolysis. Karyo means nucleus. I'm sure I must have heard about karyotyping, right? So pycnosis, karyolysis, and karyolysis, right? Perfect. Since there is karyolysis, the nucleus undergoes lysis. That's why there is no blue color. There's a reason there'll be no blue color in necrosis. That's what is generally only pink in color, right? Just one more question before we move to liquefaction necrosis. Will there be inflammation in necrosis? Yes, no, maybe. A simple question. Will we see inflammation in necrosis? Obviously. So which means if at all, is there any blue color in the biopsy, which is nothing but inflammatory cells, not the necrotic tissue, right? You will see inflammation. Inflammation will undoubtedly be present in necrosis. And apoptosis will not have inflammation, right? Perfect. Hemant, you will see inflammation in necrosis. Apoptosis will not have inflammation, right? Perfect. Let's then go to liquefaction necrosis, okay? Like you guys said, I'm not going to start that. I didn't even write that liquefaction necrosis is going to be seen in brain infarct, right? We don't want brain infarct because no one takes a biopsy for a brain infarct, right? So brain infarct by default will have liquefaction necrosis. Why it's becoming liquid? It's very, very simple to remember it. When you heat a butter, will it become liquid? It becomes ghee, right? Which means butter becoming ghee is due to a lipase activation. So the mechanism of action in case of a liquefaction necrosis, enzyme activation. Okay, it's enzyme activation is the one which is going to cause the liquefaction necrosis. That's simple. Brain is like a ghee, like a butter. It's full of fat. The parenchyma is full of fat. That's why it gets liquefied. We have liquefaction necrosis, right? Perfect. Okay. So now there are two other conditions where you have to remember liquefaction necrosis. One is any abscess cavity, be it a lung abscess, be it an abscess in the tip of the finger, toes, anywhere. Abscess cavity, I'll have more WBC, you'll end up in having liquefaction necrosis. Same with wet gangrene, you'll have liquefaction necrosis, right? Perfect. Hemant and Nitin told pancreas. It's very, very important. So we have two things in case of an acute pancreatitis. Especially in exam, I want you to be very, very careful in writing what's the right answer. Okay, there are two things. In acute pancreatitis, if the question is saying what is the type of necrosis in pancreas, the answer will be different. If the question is saying what will be type of necrosis in omentum, the answer will be different. Can anyone tell me what will be the type of necrosis in omentum? Omentum, it's simple. You guys know it. Omentum is made of fat. There I'll have fat necrosis, right? You end up in having a fat necrosis in omentum and perfectly liquefaction necrosis in case of an pancreas. Okay, it's important. You have to know the difference. Please read the question. Everyone will answer here correctly, but in the exam, no, the stress and all those things will make you divert. So read the question slowly. 10-second rule. Don't write any answer in the first 10 seconds. Read it, take it inside, write it. You guys have been amazing so far. Yesterday I was also live. You guys have been amazing yesterday also. So you know stuff. Just make sure you get 150 plus and let's see what to do next. Fine. Then let's come to caseous. Caseous means grossly it's a chalky white color. Okay. It's chalky white color or cheese-like. It's a cheese-like necrosis. Fine. It's a chalky white color in case of a necrosis. That's mostly a gross finding, right? So what do you think about caseous necrosis? What is one? Can anyone name me one more disease apart from this guy? Obviously, the thing is tuberculosis, right? Apart from TBRG. Once a while, we'll see something apart from tuberculosis. TB by default, you'll have caseous necrosis. TB, be it a lymph node, be it a lung, be it a liver, spleen, anywhere you'll have caseous necrosis, right? Perfect, Rahul. There are few more organisms. Histoplasma can have. Ashwin, sarcoidosis will have non-caseating granulomas, right? It will not have caseous necrosis. Histoplasmosis, cocci-D-diomycosis will have, okay? And leprosy. See, leprosy is very tricky. I want you guys to please observe a little bit more if a question on leprosy comes. If it's a pure neuritic variant of leprosy, I'm sure you must have read about the Ridley-Jopling's classification of leprosy. If it's involving only nerves, then yes, I will see caseous necrosis. Otherwise, you won't see caseous necrosis. It will be non-caseating only. Only when it's in pure neuritic leprosy, you'll see caseous necrosis. Other types of leprosy, it'll be a non-caseating necrosis, right? These are few things which I want you to remember in terms of caseous necrosis, fine? Okay, it's very simple. Grossly, it'll be the whitish color. Microscopy, like any other necrosis, fine? Perfect. Let's go to oid. Oid means like fibrin. Fibrin is seen in blood vessel clot. Clot is fibrin clot, a fibrin clot, right? So fibrinoid necrosis means it's equivalent to an blood vessels necrosis. As simple as that, right? So blood vessel necrosis. So can I say PAN is an PYQ? You are absolutely right, Hemant. No doubts in that. Is it only PAN or any vasculitis? It has to be any vasculitis, right? Why to restrict with PAN? Any vasculitis will have it, right? Any vasculitis, PAN was an MCQ, PYQ by default, right? Again, RG, hypertension is right, but not any hypertension, only one hypertension. Let's rephrase the question. Which hypertension in the kidney will have flea-bitten appearance? Which hypertension in the kidney will have flea-bitten appearance? Everyone, I want you guys to comment. Let's be interactive because three and a half hour session, you will get bored over a period of time. Malignant hypertension, right? So not any hypertension, only malignant hypertension where the BP is going to be like 200 millimeters of mercury, right? Only then the blood vessel rupture. Normal hypertension, blood vessel will not rupture, right? So malignant hypertension will have fibrinoid necrosis, and also this also remember the flea-bitten appearance of the kidney. The flea-bitten appearance is nothing but the petty K which came due to the rupture, right? Good morning, Vasan. Fine. So both are PYQs for you. Never forget it. Malignant hypertension, flea-bitten kidney, both will have fibrinoid necrosis in microscopy, right? And like Simon said, SLE. SLE is also a type of vasculitis, right? So can anyone tell me what type of hypersensitivity is SLE? 1, 2, 3, or 4? It is type 3 hypersensitivity, right? So I can twist the question a little bit. Which type of hypersensitive reaction will have fibrinoid necrosis? It's SLE only. I'm indirectly calling it a type 3 hypersensitivity. That's all, right? A type 3 hypersensitive reaction or an SLE will have fibrinoid necrosis, right? And someone said Aschoff body is perfectly right. Rheumatic heart disease. In rheumatic heart disease, we have a condition called an Aschoff body. So Aschoff body also will show fibrinoid necrosis because heart is considered to be the largest vessel, right? So all these places will have fibrinoid necrosis. Fibrinoid is your fibrin-like. And one important new information for you. If I want to do a special stain for fibrinoid necrosis, it will be positive for PAS. Okay. We'll maybe every once in 10 minutes we'll read a new information so that if at all something is useful, new question comes, it will be helpful for us, right? PAS is positive in case of fibrinoid necrosis. Okay, what's the next necrosis? We're done with fibrinoid, we're done with fat, we're done with coagulative, we're done with caseous. Last but not the least is your fat necrosis, right? We're not completed fat necrosis. So fat necrosis, any fat-rich parenchyma will have fat necrosis. If there's fat, it will die via fat necrosis. I'm going to divide fat necrosis into two major parts. One is trauma-induced fat necrosis, traumatic. Other one is your enzymatic fat necrosis. Okay. Can anyone give me one example of traumatic fat necrosis? All of you must have got an injection in the gluteal region. Breast trauma, obviously. Injection in the gluteal region, obviously. Insulin injection. Everywhere, right? Any trauma to fat-rich structure will have traumatic necrosis. It can be the breast parenchyma because it's rich in fat. It can be the gluteal region because again it's rich in fat. Any trauma to any fat-rich structure will have traumatic necrosis. Enzymatic, we already know. In case of an acute pancreatitis, the enzymes go away. The lipase seeks away. The lipase will leak and it will destroy the omental fat. It will go and destroy the omental fat or the peripancreatic fat, right? Since we know already lipase, we'll just go and link to one important PYQ in case of your surgery. What is the other enzyme which is useful or diagnostic in case of an acute pancreatitis? It starts with the alphabet A. It is perfect, amylase, right? Can anyone give me two commonest cause for acute pancreatitis? I'll tell you the one common cause, that's alcohol. Apart from alcohol, can anyone tell me one more common cause for acute pancreatitis? Alcohol by default, everyone knows that. The second common, or maybe in few areas, the first common cause also is gallbladder calculi, right? Gallbladder calculi and alcohol, these are the two major cause for case of an acute pancreatitis, right? Perfect, great. NASH is for liver, okay? For pancreatitis, NASH is non-alcoholic steatohepatitis, right? Perfect, okay? Nice. So we know about a few different types of fat necrosis as well, right? Just a few difference between necrosis and apoptosis. Like we already read, necrosis is pathological only. This is both physiological plus pathological. Necrosis will have inflammation. Will there be inflammation in apoptosis? No. There'll be no inflammation in case of an apoptosis. Perfect. Okay. Necrosis by default will have pain involved. Because of the inflammation will have pain. There'll be no pain in case of an apoptosis. There'll be cell membrane damage in case of a necrosis. And apoptosis, the cell membrane will be intact. That's why there's no leak outside, right? And the most important question, okay, Hemant said one thing, we'll add that also. Caspase dependent is apoptosis. Necrosis has multiple other enzymes, proteases, nucleases, and everything, right? Most important thing, just now you answered amylase. If I'm going to ask you a reasoning based question, what is the reason for amylase being secreted outside is the cell membrane damage. Once a cell membrane is damaged, the intracellular contents leak outside. So once the intracellular contents leak outside, we use it for diagnosis. Be it an amylase, what's a marker which is used for MI? I'm sure you know the marker. Dr. Santosh will definitely come and cover that. Troponin I, troponin T, 𝐶𝐾MB, everything, right? All these are examples of cell membrane damage. Myocardial infarction is a type of coagulated necrosis. Hepatitis, what's the marker? AST, ALT, the same concept. Hepatitis, I'm having a damage to the membrane. AST, ALT comes outside, I'm measuring that, I'm doing it that, right? Apoptosis, there is no blood test. There is no leak of enzymes. There's no blood test by which I can identify, okay, it's apoptosis, right? Perfect, right? That's about necrosis and a little bit different between apoptosis, fine. Wasn't no controversy. I'll leave to Dr. Santosh. Whatever he says, whatever any medicine faculty says, that will be the right answer, fine. I'm not going to say I'm going to be involved pathologically in that. I'll ignore it, fine. CD marker is a tumor marker, right? It's I'm going to use them on a biopsy, so that will not be helpful here, Ashwin. It's all blood markers is based on this only. CD marker is a tissue biopsy marker. I won't use that because of necrosis concept, fine. Okay, now let's quickly recap about apoptosis. Apoptosis is programmed cell death, okay? It's both physiological and pathological, like we said. Apoptosis, it's like Hemant said, it's a caspase dependent type of cell death. Okay, it's a caspase dependent cell death. That's apoptosis. Okay, just give me a second. Okay, it's a caspase dependent type of cell death. Fine, understood? Great. So now apoptosis has two types of pathway: an intrinsic pathway of apoptosis, and I have an extrinsic pathway of apoptosis. The extrinsic pathway is also what is there outside the cell? It is cell membrane mediated. Intrinsic pathway is mitochondrial mediated, right? There came a question, where do we find all this BCL2 back and everything? Where do we find them? We find them in the mitochondria. It's involved in the intrinsic pathway of apoptosis, right? So we have backs and back. These both are pro-apoptotic pathway. BCL-XS is also a pro-apoptotic pathway. So just a way to remember, whichever has L in it has a longer life, and we call it an anti-apoptotic gene or an anti-apoptotic protein. It's pro-apoptotic as anti-apoptotic. S for us shorter, remember it's in pro-apoptotic as well, fine. So this is how we define anti and pro-apoptotic. And in case of an extrinsic pathway of cell death, there's one important protein which I'll tell you one name. I want you to tell the other name. The most important protein for us, FAS and FAS ligand interaction. What is the other name? What is the CD marker name for it? Ashwin, you asked about CD marker. Can anyone tell me what's a CD marker name for this? It is CD95. Okay, CD95 or FAS ligand or a death receptor. Okay, that is what is going to cause this. Fine. So that's what is the one which is going to trigger the extrinsic pathway of cell death, and the intrinsic pathway of cell death is triggered by apoptosis and the BCL2 genes. This is the most common pathway. If something is most common as intrinsic pathway is by default the most common, extrinsic pathway is a little bit rare compared to the intrinsic pathway, fine. Ultimately, whatever it is, caspases are very, very important for me here, right? Let's go with the numbers. Ready? So Hemant will guide us because Hemant has already told the numbers. What is the number for the extrinsic pathway of apoptosis? What's the number for the intrinsic pathway of apoptosis? What's the number for the common pathway of apoptosis? All are based on caspases. Extrinsic pathway, what numbers? Extrinsic pathway, we have an extrinsic pathway. Come on. We have either 8 or 10. In this, human caspase is 10, right? Human caspase is 10 here. Intrinsic pathway is in between, it's 9. Common pathway is 3, 6, yeah, 7 also we can add it to it, right? So 8 and 10 for the extrinsic pathway, 9 for the intrinsic pathway, 3, 6 and little bits of 7 also for the common pathway of apoptosis, right? And one more way where your apoptosis caspase involved is pyroptosis. Okay, we have one more special type of cell death caused in pyroptosis. In pyroptosis also, it is also a caspase dependent pathway. The only thing is you'll have fever along with this, right? In pyroptosis, you'll have caspase 1, 4 and 5 being involved in case of an pyroptosis, right? Since we are in gas phase, we also discuss about pyroptosis. The only difference is you'll have fever and inflammation along with your apoptosis. That's how it's going to be: fever, inflammation, and this is going to be seen in apoptosis. Fine, pyroptosis. Great. So we know a little bit about necrosis and apoptosis. Now let's go to stains. Okay, I'm going to add stains, and I also write few clinical scenarios where we see stains, right? Great, RG, interleukin 1 is also involved in pyroptosis. That's the one which is going to cause fever. Fine. Melanin, someone in the last discussion told me M for M, Masson Fontana. And Schmorell stain is also something which is used, not commonly used, but is there. Okay. Melanin, what is the normal color in H&E? Can anyone tell me the normal color of melanin in H&E? It'll be perfect. It's brown in color. Melanin is not a black color pigment. In microscopy, melanin is brown, right? So where do I use this Masson Fontana, or where do I use this Schmorell stain for melanin, right? Uses are very simple. I can use them for benign tumors of melanocytes. Can anyone tell me benign tumors of melanocytes? I can obviously use it for melanoma, which is a malignancy, right? Hair, skin, and eye is a normal thing, right, Chiku? It's not an abnormal thing. Benign tumor of melanocyte, which is nevus, where I use them. Melanoma by default, it will be positive because the melanin secreting tumor will be positive, and also a case of hyperpigmentation. If at all I want to demonstrate hyperpigmentation clinically and in the microscope I have to demonstrate, I will help. I definitely help. And in case of an depigmentation, negative melanin stain, negative Masson Fontana also will help. In case of a vitiligo or in case of an albinism, it will help, right? So all these cases will be positive, and it will be negative in case of an vitiligo or in case of an albinism, where's a depigmented patch, right? Though it's not very concrete use, but these are the places where it will be positive and negative with respect to melanin and Masson Fontana, right? Next stain. Okay, I'll just give you this color. And let's say this is a liver biopsy of a patient who also has bronze diabetes. Can anyone tell me what's the answer? I know you have the PDF, but still, liver biopsy, this patient also has bronze diabetes. What do you think? Perfect, right? Hemosiderin, right? So hemosiderin, it's actually a pathological iron deposit. It's not a physiological iron deposit. Physiological is always your ferritin, and hemosiderin is positive for Pearl's Prussian blue. Hemosiderin or iron will be stained by blue in color, right? Liver biopsy plus bronze diabetes, I think of an hemochromatosis or hemosiderosis. There's a classical information for diagnosis. Bronze diabetes, skin will become a little bit brownish in color, and the patient will have diabetes along with that liver failure. These three combinations classical for hemochromatosis, positive, right? Next place where I can use this is positivity, fine? Okay. So let's say I'm having a patient with a lung issue, a lung problem. Along with the lung problem, you're right, Hemant, the patient also had a history of working in a cement industry, okay? The patient worked in a cement industry, and the patient had a lung problem. In the microscopy, I'm having brown color fibers. Can anyone tell me the answer? Brown fibers in microscopy, lung problem, cement industry, that's a classical, and also this increases the specific cancer of mesothelioma. Asbestosis, right? Perfect. So this is how we solve clinical scenario based question. Keywords. Asbestosis. Now tell me what's a microscopic finding which will be iron positive? Your ferruginous body, right? Perfect. Okay, so ferruginous body in asbestosis will be positive. Again, that is an iron positive thing. So I have multiple scenarios. Introduce a fact which is iron and Pearl's Prussian blue. Automatically you come to a scenario based question, right? Let's go with one more thing. Just last one for iron. Let's see if you guys can answer. Is dumbbell shape is the right answer, RG, the shape of it, fine? So now I'm having a patient who's an elderly person, okay, having dyspnea, tachypnea, okay, and in lung biopsy, so what we have is an brown color macrophages. Can anyone tell me what's the name of this and what's the condition? Dyspnea, tachypnea, pedal edema, what do you think is the diagnosis? It's a simple case of heart failure, right? So this brown color macrophages will be positive of Pearl's Prussian blue, and we call it an heart failure cell. Okay, so heart failure cell, the most important mistake quite a few people do, because in very old PYQ you might have known about it. Heart failure cell is not seen in heart, it is seen in lungs. These are nothing but hemocytin-laden macrophages seen in case of a lung, in case of a heart failure. Again, like I said, we'll read new information once in every 10 minutes, so it's a bit easy for us to assimilate that as well, right? So heart failure cells positive for perspiration blue, asbestosis positive for perspiration blue, and your hemochromatosis positive for perspiration blue, right? Perfect. Now let's go to lipid. Actually, this is a lipid stain. It's been wrongly placed here. It's fine. Okay. It is seen in lungs, not in heart. Please do remember that. It's just spinal response, right? Okay, heart failure cells seen in hearts. You go directly and mark that. Okay, perfect. Now lipid. Lipid, what's the normal microscopic color? Normal microscopic color of lipid? It is clear. It's clear or white. If you want to call it white, you can call it white. It's clear. It doesn't have any color, right? So there are two stains where I can use for lipid. One is oil red O and the other one is Sudan black, right? So this is the stain for oil red O of lipid. Okay, sorry, this is Sudan black, obviously, right? So black in color, right? Sudan black for lipid. And the below one, it's the oil red O, reddish orange in color. We call it a red O. RG, microscopy, it's clear. Gross color of lipid is yellow in color. I think both RG and Heyman told about the gross. Gross is yellowish orange in color. Microscopy is clear. And we have two stains. One is oil red O. The red color deposits for an oil red O. And the other one which we showed was Sudan black color deposit. Fine. Okay. Now, just few ways for us to diagnose lipids. Since we are in fat, we'll look at few classical examples of fat. Obviously, you'll have in liver is the most common organ where you can have fatty change, right? What's the most common cause of fatty change? Anyone? Someone was telling about NASH few minutes back. NASH is by default the most common cause of fatty change. Then comes alcohol. Alcohol is not these days common. Non-alcoholic steatohepatitis has become a little bit more common cause of fatty liver than your alcohol, right? After that, why atrophy? Okay, after that, we have in pediatrics. If a patient is a pediatric patient and if the pediatric patient is having a fatty liver, the first common cause I want you to think of is PEM. Protein energy malnutrition is the most common cause of fatty liver in children, or maybe a drug-induced hepatitis that also can cause fatty change, but predominantly protein energy malnutrition. The Kwashiorkor marasmus, you must have read in biochemistry, all the peripheral fat will come to the body in the liver and it will get accumulated, right? Again, the most important thing is in microscopy, fat is clear for a reason because processing clears the fat. This came in an MCQ. When you process the tissue, it will dissolve or it will clear the fat. That's why fat is clear in microscopy in case of a fatty, in case of the H&E stain, right? So this led to second question. So where do we find or where do we use oil red O or Sudan black? Can we use that on a light microscopy? I cannot use that on a light microscopy. What is required to do oil red O Sudan black? It's a question which came 2 years back in FMGE. I don't want a normal H&E. I don't want a formalin fixation. We can do oil red O Sudan black only on frozen section. Remember this is very, very important. I can do only on a frozen section. We cannot do it on a normal light microscopy. A frozen section is required for us to do an oil red O or a Sudan black, right? That's a second stain what you study, right? Let's go to the third one. Glycogen. Okay. Glycogen, what's the stain? They are PAS positive, right? Glycogen is PAS positive and they are diastase sensitive. Okay. They are PAS positive and they are diastase sensitive. That's what glycogen is going to be. Fine. Perfect. Glycogen can be lightly pink in color in microscopy or lightly clear in appearance as well, right? Now, I'll give you a few examples. I want you guys to correlate them and tell me the most appropriate answer, right? What's the normal storage organ of glycogen? Which organ do you see normally glycogen being stored? Normally, I can see glycogen in liver and a little bit in muscles as well. Normally, liver also has glycogen, muscle also have glycogen, right? Now, I'll give you an example. A young 3-year-old kid with hepatosplenomegaly, I'm writing HSM for hepatosplenomegaly, failure to thrive. Not able to grow properly, failure to thrive. Liver biopsy has a classical appearance of many clear hepatocytes. We call it a plant cell-like appearance, right? Very clear or an pale pink inclusions in the liver biopsy. Microscopy is perfect, PAS positive. Diagnosis, glycogen storage disease. I can be very specific. I can call it a von Ginck's disease. I can apply glycogen, right? So I can apply glycogen for every glycogen storage disorder we know. Von Ginck's, Pompey's, I can use it for heart involvement, right? McArdle syndrome, I can use it for muscle involvement, the normal skeletal muscle involvement, right? So based on the organ system involvement and based on the symptom, my diagnosis changes, right? You can add that lot, tall leg phase and everything. Just few words to correlate to solve a scenario-based question also. Learning pathology gives a little bit of insights to other subjects sometimes, right? Next. A patient who is a 45-year-old patient, a diabetic patient, okay? This diabetic patient, in the kidney biopsy, in the proximal columnar tubule cells, there's kind of a clear vacuolations in the proximal columnar tubule cells, and these vacuoles are PAS positive. So these are nothing but as a name finding question, Armani-Epstein lesion. This might come in an exam. Again, maybe a new finding. I am sure you must have known one more lesion in case of diabetic nephropathy. That's called an Clemensstein-Wilson nodule. That happens in glomerulus. This Armani-Epstein lesion happens in proximal convoluted tubule. It's nothing but your, glycogen deposit in case of diabetic nephropathy. And the classical findings in KW nodule. KW nodule is also seen in diabetic nephropathy, which is seen in glomerulus. Okay. So these are few use cases for me for glycogen-induced clinical scenarios. But glycogen is PAS positive, glycogen is diastase sensitive. It can be digested by diastase, right? What is PAS positive and diastase resistant? That's your protein, right? That's your protein. Protein is PAS positive and protein is diastase resistant. This is not a right image. We'll look into it very soon. Protein is definitely PAS positive and it is diastase resistant. Okay, that's what protein is, right? Perfect. So proteins, PAS positive diastase resistant, I can use in multiple places. Again, a liver damage or a liver failure in an 45-year-old person. I'll do it him and just give me a second. Fine. Liver failure with emphysema in this patient. And the liver biopsy shows extremely pink color nodules. Okay. Pink globules in the liver, and these globules are positive for PAS and diastase resistant. What is the diagnosis? Liver emphysema is a classical clue. It's positive for PAS and it is diastase resistant. That's a classical example for your alpha-1 antitrypsin deficiency. Okay. That's a very classical example for alpha-1 antitrypsin deficiency. Alpha-1 antitrypsin deficiency will be PAS positive, diastase resistant, protein deposit, clue of emphysema, lung involvement, and the liver failure. That's a very classical clue, right? Okay. Hemant, what I was saying is, KW nodule, let's say this is an glomerulus. Okay. Let's assume these are tiny capillaries here. KW nodule will be like this. It will be a big nodule in the glomerulus. It's a finding seen in glomerulus. It's an Clemensstein-Wilson nodule, the person who diagnosed it. Glomerular sclerosis, completely pink in color, right? Nodular glomerular sclerosis, right? When I take a tubule, let's assume this is a tubule, the proximal convoluted tubule, which is seen next to the glomerulus. Here, if you have clear vacuoles, that is your Armani-Epstein lesion, right? Armani-Epstein lesion is a finding seen in the proximal convoluted tubule, and KW nodule is a finding seen in the glomerulus. Both are seen in diabetic nephropathy, fine? Okay, let's come back to this. One more classical example. This is actually not a protein, it's an organism. Let's see how many of you can answer this, fine? I'll give you classical clues, one by one clue. Let's see if you can identify. Patient present with diarrhea. Patient also had joint pain. Patient also had a heart issue. Maybe a skipped arrhythmia like COVID and a heart problem, okay? And in the biopsy of the intestine, okay? In the biopsy of intestine, we have classical macrophages which are PAS positive, diastase resistant macrophages in the lamina propria. Diagnosis, the organism or the disease starts with W. Can anyone tell that? In lamina propria. It's a very classical question. Anyone? This organism is Whipple's disease. Fine. We see them. This is Whipple's disease, Triforma whippeli. So Whipple's disease also is PAS positive and diastase resistant, right? Perfect, right? So this is also a PYQ. Again, I can combine informations and solve a scenario-based question, okay? Next. So calcium, KAL, right? K for your COSA, AL for alizarin, right? One COSA is undoubtedly most commonly done stain, and this red in color is alizarin red. Alizarin red is very specific. 𝐼_COSA is not that specific. Alisonetide any day is better. 𝐼_COSA is cheaper and it's most commonly used. That's all, right? 𝐼_COSA in microscopy will be blackish in color. Okay, I'll go up. This is actually the picture of 𝐼_COSAs. This is the blood vessel where it's getting deposited. This is a 𝐼_COSA image, right? It's no longer placed in the PDF, so ignore that for now. Fine. So 𝐼_COSA and alisonetide both are calcium stains. So how can I use calcium stain? I'll give you one classical finding. You're going to tell me it's a patient with meningioma, and I'm having a structure which is like this, as the entire structure is positive for 𝐼_COSA. Can anyone name what the structure is? It's a very classical structure. Starts with P in case of a meningioma. Calcification, we call it Samoma bodies, right? Samoma does calcification or Samoma bodies is a classical finding seen in case of a meningioma. I can see him in leiomyoma. I can see in serous tumors, right? Again, maybe a little bit difficult, not much. I have a microscopy vessel. In the wall of the vessel, I have calcification in the wall of the vessel. Can anyone tell me what is the diagnosis here? Calcification in the wall of the vessel, and this is obviously going to be 𝐼_COSA or your alisonetide positive. What's the diagnosis? Malignant hypertension will not have calcification. That's your 𝐒𝐿𝐻 arteriosclerosis. Chico, it's possible to be atherosclerotic plaque also, but atherosclerotic will have intimal calcification. This, as I said, the wall, it's more of medial calcification, right? Perfect. It can be 𝐒𝐿𝐻. 𝐒𝐿𝐻, it should be in medial calcification. If it's intimal calcification, like what Chiku said, it's possible it's an atherosclerosis, because atherosclerosis also will have calcification. One is in the intima, one is in the media. Fine. It's 𝐒𝐿𝐻 medial calcification, right? Amazing. Perfect. Then copper. Copper, I have rhodamine, I have rubionic acid, I have orcine. All these three are copper stains. Personally, I prefer orcine because in the microscopy in the lab, it's much easier to do and easy to see, right? Copper is useful in only one disease. I'll tell all the classical features involved here. I want you to tell the diagnosis, right? First, a young patient will have tremors or involuntary movement as a classical symptom. In addition, you already told the diagnosis, right? In addition, you'll have your KF ring in the eyes. That's classical Wilson's disease. The reason why it's youngest, it's an autosomal recessive inheritance. That's why it's important. Shubham, no, see, ceruloplasmin, copper-bound ceruloplasmin is what I'm looking at. And for Wilson's, my primary target is to look at ceruloplasmin, right? If ceruloplasmin is not there, I am very, very confident in calling Wilson's. I don't use copper stain for any other disease apart from Wilson's. That's why I said orcine is much more confident for me than the elemental copper. I look at ceruloplasmin bound copper. That's where it is used for, right? Perfect. The ATP7B is the mutation, right? And the test, what I do for Wilson, there are two tests here. One, serum ceruloplasmin level, and the other one is urinary excretion of copper. So tell me, what is important here? Which is the most important test? Urinary excretion copper or ceruloplasmin level? The best test for me is urinary copper excretion. This is better than the ceruloplasmin level by default. Liver biopsy is diagnostic, but no one does a liver biopsy in recent date. I'm going to go with serum ceruloplasmin level and urine copper excretion, right? ATP7A mutation is definitely Menkes-Kinke's heart disease, and ATP7B mutation is Wilson's disease. Fine, perfect, great. Okay, just let's complete Wilson's. Word about treatment. Anyone? Two things: ATP7A and 7B. 7A mutation is your Menkes-Kinke's heart disease. 7B mutation is your Wilson's. Zinc, D-penicillamine, one more thing, trientine, right? Zinc can be used, D-penicillamine, a chelating agent, can be used because zinc will interfere with the copper absorption. D-penicillamine is a copper chelator, right? And one more drug is trientine. Okay, trientine is a cheaper drug and it's not easily available. D-penicillamine and zinc is something which is commonly used. That's in case of Wilson's disease, right? Perfect, great. Next, mucin. Mucin has multiple stains. I have three stains here. Mucin is PA is positive. Mucin is ancient blue positive. Remember A for A. Ancient blue is positive for acidic mucin. Right? PA is positive for neutral mucin and sometimes acidic mucin also. Mucicarmine. Okay. Carmine is red color. Mucicarmine is, if mucin is stained red in color, which is actually useful in case of a salivary gland mucins. That's where I commonly use them. Salivary gland, you have mucoepidermoid carcinomas and everything, right? In case of mucoepidermoid carcinomas, This mucocarbamate is very, very important. It will be positive in mucocarbamate customers, but in every other acidic mucin, alkaline blue will be positive, and your PAS will be positive in case of acidic and neutral mucin, right? In this image, there are two colors. This is PAS positivity, the magenta color. This is alkaline blue positivity. Fine. So alkaline blue positive, PAS positive, both of us are diagnostic for it. Fine. Hello, Assalamu alaikum, Sarji. Thank you. Hope you're doing good as well. Okay. Fine. So we know about this. So I'll just give you a scenario. Let's see if you can diagnose. A 35-year-old patient, this came in an INACT and AIMS. Let's see if you can answer that. FMG is considered inferior, right? You can answer INACT also with the same content what you read, right? 35-year-old person, long-standing GERD, Barrett's esophagus. I told the answer. Biopsy was taken, right? Let's assume it's Barrett's esophagus. And this Barrett's esophagus, will it be positive for mucin or not? If positive, which mucin you would prefer? Alkaline blue or PAS? It will be positive for both alkaline blue as well as PAS, right? It will be both alkaline blue and PAS positive. Fine. It's goblet cells, right? Perfect. The goblet cells will be secreting mucin. It will be positive. I wanted to come to the diagnosis. Slip of a tongue, I told the diagnosis. Sometimes in exam also, you might have the diagnosis in the question. Don't worry. It's a mistake. Don't overthink and write the wrong answer. It come, right? It's both alkaline blue and PAS will be positive. It's just mucin which is there, but we prefer alkaline blue and more than PAS, right? So it's a classical kind of Barrett's esophagus, right? Since I told Barrett's esophagus, I have to ask some other question to make you answer, right? So tell me, what type of cancer will Barrett's esophagus cause? If it's untreated, what type of cancer do you think it will cause? It will cause a classical type of adenocarcinoma, because columnar epithelium, gland forming tumor, adenocarcinoma. That's why adenocarcinoma is the most common in the lower end of esophagus, because lower end of esophagus is where you have the Barrett's esophagus, right? Since you are in Barrett's, can anyone tell me the endoscopic finding of Barrett's? The cancer is by default adenocarcinoma. If untreated, it's not squamous or transitional. Fine. Endoscopic finding of Barrett's, you have a classical red velvet-like mucosa. Okay, you'll have a classical red velvet-like mucosa. That's how it looks in endoscopy. Microscopy is very, very simple. You will have an epithelium which will be stratified. Stratified epithelium is always squamous. At the same time, you will have glands. The glandular epithelium is where you have the goblet cells. So you have glandular columnar epithelium and stratified epithelium. We call it a Barrett's esophagus. Fine. Red color mucosa, red velvety appearance is an endoscopic finding. You take a biopsy, you see this, and you do the marker, which will be highlighting the mucin. I will be more than happy to call it Barrett's esophagus, right? Perfect. Last one. Amyloid. Amyloid have multiple stains. I'm just using congorate. Congorate is a commonly done stain. Thioflavin is a stain for amyloid. PA is also positive for amyloid, but not very good. PA is positive for any protein. Amyloid is also a protein deposit. It will be positive by default, right? Crystal violet is positive. All these are amyloid stains, but the most important done stain is congorate, right? Once you do congorate, there are two questions in congorate which can come. What's the color of congorate in light microscopy? And what's the color of congorate in polarizing light? What's the color of congorate in light microscopy? What does it take? Shubham, not negative birefringence. Negative birefringence we do use in a different place. Salmon pink, perfect in case of an light microscopy. Amazing. Shubham, the answer is here, no. Apple green. Okay. The apple green birefringence is what I'm going to look at. Okay. Negative birefringence, needle-shaped crystals are more useful in case of an 𝐒𝐄𝐝 crystals. Positive birefringence is more useful in case of your silica crystals. Fine. Perfect. So negative birefringence is also a thing which is a PYQ, which is useful in gouty arthritis, your needle-shaped sodium urate crystals. It's completely fine, Shubham. Positive birefringence is useful for silica nodules, the silicosis. Fine. So do remember 3 places I can use birefringence: polarized apple green for amyloid, negative for your gout, and your positive for your silica nodules. Fine. Okay. Perfect. Let's go to the next. So a few words about these are things what we read in the first chapter, right? The cell injury chapter. We have compiled cell injury actually and converted into solely a scenario based question. Fine. Okay. So can we do one thing? Can we quickly go through whatever we read till now? Because I am 100% sure you won't have any day more time to revise whatever we read now. Can we go ahead and quickly revise from first? maybe in the next 5 minutes. Then we go to inflammation. If you guys say yes, I'll do it. Perfect, done. So we read here, we complete it here, we don't go and look again. I want you to look at there just before the day before the exam, fine? So we start with the necrosis, coagulative, the most common type. You have heart, kidney, every solid organ in fact. Microscopy, you'll have the microscopy will have the classical maintained architecture. Protein degradation is the pathogenesis. H&E will have pink in color, pycnosis, karyorrhexis, karyolysis, and inflammation will be present in every necrosis, right? In case of liquefactive, brain infarct, abscess cavity, and wet gangrene, please remember pancreatitis can be both liquefactive. If it's in pancreas, momentum will have fat necrosis. Mechanism of action is enzyme activation. Case is by default chalky white, clear white appearance. It's classically TB. Histoplasmosis, coccidium, microscopic. Also, I can see them. Leprosy, only the pure neuritic variant of leprosy will have caseous necrosis. Others will not. Fine. Then fibrinoid. Oid means like anything involving vessel wall will have fibrinoid necrosis. PAN is a PYQ, but any vasculitis can have that. Malignant hypertension, which is flea and kidney, can have that. SLE or type 3 hepatitis can be the question, which can have that. And also in RHD, the rheumatic heart disease, the Asher body can have it, right? And PAS is positive in case of fibrinoid necrosis also, fine. Fat, traumatic, any structure rich in fat will be traumatic positive. And pancreatitis, the lipase leaks outside, and momentum fat can have fat necrosis, right? Necrosis is always pathological. Inflammation is present. Cell membrane is damaged. That's why the intracellular contents leak outside. The troponins, the AST, ALT levels, or your amylase, lipase in pancreatitis, everything is based on this concept, fine. Physiological apoptosis can be pathological also. No pain, no leak of enzymes at all, fine. Apoptosis, programmed cell death, can be both physiological and pathological. Two pathways, extrinsic and intrinsic. Extrinsic is cell membrane mediated, where you have the FAS ligand interaction, death receptor, CD95. Intrinsic, you have all these pro and anti-apoptotic. Anything with L, longer life, anti-apoptotic. Exceptions, BCL, XS. S small, pro-apoptotic. But backs and back are the most important thing here. Extrinsic pathway, caspase are 8 and 10. 10 is a human caspase. 9 is your intrinsic pathway caspase. 3, 6, and 7 are execution caspases. And pyroptosis also is caspase dependent. 1, 4, and 5. Pyroptosis in addition will have fever, which is due to interleukin 1, like RG said. Fine. Then it came to stains. Melanin, Masson-Fontana, and Schmorell stain. I can use it for tumors with melanin, which is nevus or a melanoma, or a hyperpigmented, depigmented condition, right? Pearl Prussian blue is positive in case of iron. I can use it for an hemocytosis, hemochromatosis. Can be a lung biopsy where you have a heart failure cells. Can be a lung biopsy, occupational lung disease for an ferruginous body. Fine. Lipid always requires frozen section for staining. Lipid normally is clear. Grossly is yellow in color. It's clear because of being washed out there. That's why I need the frozen section. The most common cause of fatty liver is NASH. Then comes your alcoholic fatty liver. Oil Redo, Sudan black. Both are classical lipid stains. Fine. Glycogen is PA is positive and is diastase sensitive because it will be digested by diastase. Glycogen can be used for glycogen storage disorder. I can use it for case of diabetic nephropathy for an Armani-Epstein lesion. One more finding in diabetic nephropathy is KW lesion, right? PA is positive diastase resistant is protein. I can use it in alpha-1 antitrypsin deficiency. One organism which can be PA is positive diastase resistant is Whipple's disease, which can be in intestine, right? Then it came to calcium. Cal for COSA and alizarandride. COSA is commonly done, alizarandride is rarely done. I can use it for Monkey-Burks or can use it for intimal calcification and atherosclerosis and also in tumors of some more bodies, fine. Then copper, rhodamine, rubionic acid, and orcine. I prefer primarily orcine, but rhodamine, rubionic acid also is completely fine. Okay. Rhodanine, oramine, rhodanine is for use for TB. Rhodamine is for your copper stain, fine. Wilson's, we use copper. We read about all the features of Wilson's. Right, and we lastly came for mucin. Mucin deposit, I have normal, neutral, and acidic mucin. Acidic mucin we use an algin blue A for A, neutral mucin PS. Mucicarbamide is red color for salivary gland mucin, which is for your mucoepidermoid tumors, right? And this is a clinical scenario which came in the previous INACT. 35-year-old GRD positive for mucin in the esophageal biopsy. You think of Barrett's esophagus. And endoscopy, you have red velvety appearance, and you have adenocarcinoma here. And last was amyloid, where you had Congo red and apple green birefringence. Fine, let's go to inflammation now. Clear? Any doubts, do let me know. If not, let's quickly jump to inflammation. Done? Perfect. Now let's go to inflammation. See, very simple things in inflammation. Inflammation, I want you to remember few proteins enrolling margination and all those things, and few things in your inflammatory diseases. Apart from that, inflammation is going to be primarily useful for understanding and not primarily for an MCQ, right? Inflammation acute is something from minute to hours. Neutrophils, eosinophils can also be a part of acute inflammation if the causes allergy. The cell of chronic inflammation is macrophages. Lymphocytes can be a cell of chronic inflammation if it's an autoimmune disorder or a viral disorder. Chronic is by default long-standing. The classical hallmark of acute inflammation is vasodilatation, increased vascular permeability. The best example is mosquito bite. When you have a mosquito bite, will you have a wheal reaction? It will be swollen, right? Tiny. That's vasodilatation, increased vascular permeability. Simplest example. TDHF is by default the classical clue for chronic inflammation, tuberculosis. X-ray finding, you have tissue destruction, healing by fibrosis. That's a classical finding seen in case of tuberculosis. That's for every chronic inflammation by default, right? That's just acute and chronic, that's all. With this information itself, we can solve multiple questions. So I said lymphocytes is primarily for autoimmune disorder. Lymphocytes, plasma cells, primarily for an autoimmune disorder. This I never want you to forget because I can use solve multiple questions by just one information, right? Why to go and read 10 information? One is more than enough for me, right? I'll tell you how to solve this. Okay, a patient came with a thyroid swelling. Let's assume a goiter. In a microscopy or an FNAC, the patient had lots and lots of lymphocytes. Okay, two patients, lots and lots of lymphocytes. The first patient clinically was hypothyroid, reduced thyroid hormones. Can anyone tell me the diagnosis here? Goiter, hypothyroid, lymphocytes. That's all, Shubham. Hashimoto's. Autoimmune thyroiditis. Second patient also had microscopically lymphocytes, but this patient was hyperthyroid. Can anyone guess the disease? Hyperthyroid state, autoimmune disorder in thyroid. That's Graves' disease. That's all? Perfect. So just with lymphocytes, I can diagnose them, right? Next information. This patient, again an elderly female patient, had salivary gland swelling and lacrimal gland swelling. The patient also had dry eyes. And this patient, the salivary gland biopsy or in microscopy shows lots and lots of lymphocytes. Microscopy, we did a lip biopsy here to look for minor salivary glands here, and it showed lots and lots of lymphocytes. Can anyone tell me the diagnosis? The other name for this is keratoconjunctivitis sicca. Great, Sjogren's syndrome, right? So it's simple. So with one information of lymphocytes being the primary cell in autoimmune disorder, I can use them in multiple case scenarios, right? Don't worry about solving case scenarios. That's the easiest one. Solving one-liner is difficult. And you guys are amazing in solving one-liners, which means scenario-based question must be easier for you, not difficult for you, right? Just apply them. You'll be able to easily answer them, fine? Now let's go to the events in case of inflammation, right? So we have margination. That's the first event. Then we have rolling, we have addition, we have diapedesis, fine. So margination, what happens here is we have a normal blood vessel here. This normal blood vessel gets dilated. I'm writing VD for vasodilatation. Once there's dilatation, there'll be a turbulent flows. The turbulent flow will make sure all the WBC comes to the corner, right? The WBC going to the corner of the blood vessels is margination. Margination is primarily a vascular phenomenon, right? One liners are very hard. Okay, they are a vascular phenomenon, and for margination, a molecule called as selectin helps in margination. Okay, that's a molecule that's going to help in margination, right? So once it marginated, then it'll slowly roll till the place there's a gap. It'll adhere there. Once I find a gap, I'll exit the gap and I'll go outside and go and destroy the tissue. That's what inflammation is primarily about, right? So once the margination is done, then I have rolling phenomenon, right? So rolling is due to two molecules, one on the WBC, one on the endothelium. Can anyone tell me what molecule is on the endothelium for rolling? What's the molecule for endothelium? Rolling in endothelium? We have selectins, right? We have selectins in the endothelium. We have multiple types of selectin. E-selectin, it's endothelium named selectin. PCAM is for 1 milligram is for clotting. PCAM is for diapedesis, right? So we have E-selectin, we have P-selectin. P-selectin has one important MCQ. P-selectin is seen in a place called as Weibel palade bodies. It's seen in the endothelium only, Weibel palade bodies, where I have the selectin and whatever Balak said, the von Willebrand factor will be seen in the Weibel palade bodies. L-selectin is not primarily useful in inflammation. It has different role called as homing. For inflammation, E and P are the primary things, right? And in WBC, we have your Cialal-Lewis X. So in Cialal-Lewis X will be in the WBC and selectin will be here, and this bond is a very weak bond, so it rolls. Then it will adhere. It will adhere at the site of exit, at the site of endothelial gap. This endothelial gap would have been brought by the histamine. Wherever endothelium is formed a gap, it will go and adhere there. For adhesion, again I need guys from WBC and also from your endothelium. So in WBC, in case of adhesion, we have a molecule called as integrin. We have two types of integrin, beta 1 and beta 2. We'll just remember for now integrin, that's enough, right? And in endothelium, we have molecules called as CAM, right? Cell adhesion molecules. We have two types of CAM, ICAM and VCAM, right? There are two types, ICAM and VCAM. Both are cell adhesion molecules which will be bound here, right? Okay, let's erase this a little bit. Fine. And this bond is a very strong bond. That's why it adheres. After adhesion, we have the next step called as diapedesis. Diapedesis is also called as transmigration. It's going to be transmigration across the endothelium. That's what diapedesis is, right? Shubham, transmigration is what PCAM helps, right? So you have PECAM1. The other name for this is CD31. Okay. If at all they ask the other name for selectin, selectin's other name is the double of CD31, that is CD62. Okay, that's for selectin if at all it comes, but CD31 has been asked before, and based on this, the WBCs will exit the blood vessel. Slowly it comes outside and it exits. Once it exits, it has to go to the site of infarction. This site of infarction going is due to a process called as chemotaxis, chemical mediated movement called as chemotaxis, and there are very important chemotactic factors. Can anyone tell me any important chemotactic factors? Any one important chemotactic factors? Any one important chemotactic factors? We have chemotactic factors, we call them endogenous, and we have exogenous chemotactic factors. Exogenous is something coming from outside, endogenous obviously is coming from inside, right? Interleukin is definitely chemotactic. Interleukin 8 is chemotactic fried Korean noodles. 2 is chemotactic for lymphocytes. Since you're talking about acute inflammation, we'll stick to interleukin 8, right? Perfect. I have leukotriene B4, a very superb chemotactic factor. Complement protein 5A, amazing chemotactic factor. And interleukin 8, an amazing chemotactic factors. Fine. Exogenous, bacterial products. The bacterial products, the lipopolysaccharide of the cell wall, the flagella proteins, the flagellin, all the virulence factor, everything is a chemotactic factor. Fine. All the bacterial products of a chemotactic factor, or be it anything which coming inside, those are the chemotactic, exogenous chemotactic factors. Fine. Perfect. Based on chemotactic factor, automatically the organism will come to the site of inflammation. That's where a concept called a respiratory burst happens. Fine. So in respiratory burst, what happens here is, we already know that it's oxygen dependent. Okay, that's why we call it respiratory burst. Fine. So first, it's oxygen. What's the first enzyme? We have an enzyme called as an NADPH oxidase, which acts on the oxygen. Once I have NADPH oxidase, automatically I have O2 minus, that is superoxide. So once we have superoxide, we have one more guy called as superoxide dismutase, SOD, which will convert them into H2O2. H2O2 has two outcomes. Based on whether it's MPO and chlorine, it forms HOCl. Based on iodine and major basic protein, it forms HOI, right? So HOCl is extremely bactericidal. It will destroy bacteria, they're extremely bactericidal. HOI will destroy parasites. That's why I have two things in acute inflammation. Both parasites and bacteria, classical things of acute inflammation, that will end the inflammation cascade, right? Rolling, margination, rolling, your adhesion, diapedesis, outside, chemotaxis, goes, engulfs and destroys the bacteria. These are all normal. You can get questions in normal. But what is more important is the abnormality. The leukocyte defects, LAD1, LAD2 and others, right? So LAD1 is leukocyte adhesion deficiency 1, right? Few important things, what I want you to talk about everything here is, one is inheritance. Next, what's the defect? Okay, right? Yeah, it's halogen or a halide system. Next, a classical clinical symptom. Okay, tell me what's the defect in case of an LAD1. Inheritance is autosomal recessive inheritance. What's the defect for LAD1? LAD1, it's an integrin or Cialal-Lewis X? It's integrin. Remember, like I for 1 looks like 1, so it's an integrin defect. See, these are all defects in your WBCs. It's not a defect in your endothelium, it's a defect in WBC. Clinically, obviously you'll have recurrent infections, recurrent pustular infections, like pus, abscess, recurrent of them will be there, fine. Integrin, beta 2 integrin to be very specific, fine. And the most classical finding here is the patient will have neutrophilia. Never ever forget that. Both LAD1 as well as LAD2 will have neutrophilia, right? Umbilical cord bleeding or delayed separation of umbilical cord, RG. That's a clue point, right? So I have a clue point for LAD1. Classical is recurrent infection. If you have a delayed separation of umbilical cord, that's also a very, very classical clue. Okay, it's not called umbilical cord bleeding. Delayed bleeding from umbilical cord will be seen in case of your Glanzmann thrombocythemia factor 13 deficiency, right? So you'll have delayed separation or shedding, like Hemant said, shedding of umbilical cord will be delayed. That's a clue for LAD1. Like that, I have a clue for LAD2 also, same thing. Inheritance, you have autosomal recessive inheritance, right? So your defect here, please don't write it is selectin, it is Ciala-Lewis X defect. They are all WBC defects, the Ciala-Lewis X defect. And again, you have the clinical features, same like LAD1, you'll have recurrent infections. This also will have neutrophilia, that's also classical. And here, this patients might have a clue. What's a clue in LAD2? Like LAD1, I have a clue in LAD2. Perfect, like Chiku said, I have the H group or the Bombay blood group. Okay, that's a classical clue for LAD2, fine. H or a Bombay blood group, fine, perfect. The next, CGD, chronic granulomatous disease. Okay, inheritance in chronic granulomatous disease. There are two inheritance in chronic granulomatous disease, both autosomal recessive and X-linked recessive. There are two components of NADPH oxidase, both can be defective, right? And the defect is an, like we said, it's an NADPH oxidase defect. There are two components, one is cytosolic form and one is membrane-bound form. Membrane-bound form will be defective in case of X-linked recessive and cytosolic form will be defective in case of autosomal recessive, fine. So NADPH oxidase defect, a classical clinical symptom of NADPH oxidase defect is, what is that? What's a classical clinical symptom? The patients will have catalase positive organism defect. This came in last INICT also. If it's catalase positive organism defect, I think of a classical chronic granulomatous disease, fine. And in chronic granulomatous disease, in addition to this, I can have multiple investigation of choices. Anyone, do you know any test which can help us pick up chronic granulomatous disease? Any one test. I'm sure you must have heard about that. What's a test? Anyone? What's a test which comes to your mind when you think of a chronic granulomatous disease? Come on, we have been become a little bit lethargic. Just 1 hour down the road, right? Just quick. What's the test which comes to your mind? Please give options. Okay. Can anyone tell without options? See, 𝐼𝐀𝐿𝐿 is not positive in case of chronic granulomatous disease. Okay, let me give options. NBT, right? We have a test called an NBT test. Nitro blue tetrazolium. We have that, right? Not no test. We have an NBT test, nitro blue tetrazolium test will be useful, and also DHR. Okay, DHR assay and NBT test are the classical ones. Or I can do an enzyme assay, worst case scenario, right? I can have both DHR and NBT test. DHR is a little bit better than NBT, but if it's a very advanced hospital, I can just do an enzyme assay and I can diagnose them. Because an enzyme deficiency, not every hospital have enzyme assay, but enzyme will definitely help you, right? 𝐼𝐀𝐿 vaginous and your microscopic polyangiitis, right? NBT and DHR assay are useful for your chronic granulomatous disease, right? Chidiac-Hashey syndrome, again an autosomal recessive inheritance, where I have mutation LYST gene. So LYST gene mutation or defect will result in reduced formation of phagolysosome. When there's a reduced phagolysosome formation, you will not be able to form the phagolysosome. Once the phagolysosome is not formed, I will not be able to destroy the organism by default, right? So this patient's symptoms, clinical symptoms, like any other disease, recurrent bacterial infection, there are very classical clues here. The patient, in addition with infections, will have albinism. In addition to infections, the patient might have peripheral neuropathy. In addition to infections, the patient might also have thrombocythemia. The platelets will not start functioning proper. Okay, all these are classical symptoms of 𝐒𝐿 syndrome and LY gene mutation. The way to diagnose is mutation analysis or clinical symptoms itself. But there's a very classical microscopic appearance also here, which is giant granules in WBC. This is diagnostic. This is a very specific finding. Giant granules in WBC is diagnostic of an 𝐒𝐿 syndrome. Fine. Okay. These are classical symptoms of 𝐒𝐿 syndrome. Okay. Perfect. Great. Decreased immunity is by default the symptom for almost every deficiency disorders what you're reading, right, Hemant? Okay. MPV deficiency, I won't discuss much about this. It's very rare autosomal recessive disorder, and the way to diagnose is just look at the enzyme analysis and diagnose it. It's almost non-existent, so it's just for the namesake. Since we have the enzyme, we have to remember this, and there'll be an excess amount of recurrent bacterial infection in this. Okay. Apart from that, is not required. Ignore that part. Okay. Now let's go to chronic inflammation. So chronic inflammation, like we already know, TDHF is a classical finding. What's a microscopic finding of chronic inflammation? Anyone? Let's get back into momentum. What is the microscopic finding of any chronic inflammation? What you're seeing? TB microscopic finding undoubtedly is granuloma formation, right? So microscopic finding of a chronic inflammation is granuloma formation. There are few terms which are very important for granuloma. I want you guys to tell one by one. What's the principal cell of granuloma? The most important or the principal cell of granuloma? What's the principal cell of granuloma? It's epithelioid macrophages. Epithelioid cells or an M1 type of an activated macrophages is the most important principal cell of granuloma. Okay, not giant cell, right? I wanted to specifically say this, Yogam, it's not giant cell. Actually, giant cell is formed from epithelioid macrophages. So epithelioid macrophage is the most important cell. Giant cell may be there, may not be there. I have purposefully put an image. This is an image of a granuloma without a giant cell. But I do have this elongated epithelioid cell. There's a classical cell for granuloma. Fine. Okay, let's go back to this. Okay. What is the interleukin which comes to your mind which makes this epithelioid cell form? Normal macrophage will be converted to epithelioid macrophages, right? What's the interleukin which converts them? That's also very important. The interleukin which converts a normal macrophage into an activated or an epithelioid macrophages, interferon gamma. This is very important, right? Interferon gamma. Fine. So interferon gamma is the base for your quantiferon gold assay in tuberculosis, right? I look at tuberculosis, I assay the interferon gamma, I can indirectly tell this patient is having granuloma formation, right? Interferon gamma is the most important interleukin which converts normal macrophage to epithelioid macrophage, right? Like Shubham said, it's definitely a type 4 hypersensitive reaction, right? There are two types of granuloma, caseating and non-caseating or non-necrotizing. Okay. So let's assume it's both caseating and non-caseating granuloma. What's the first diagnosis which should come to your mind in case of caseating or a non-caseating granuloma? Whatever comes to your mind, tell. What's the first thing which has to come to your mind in case of caseating or a non-caseating granuloma? The first thing undoubtedly is tuberculosis. If you see granuloma, both necrotizing, both non-necrotizing granuloma has to be tuberculosis, right? I'll use the abbreviation what Shubham used, CG and NCG. Both the first diagnosis and the only diagnosis TB. Fine. Please do remember that. Without TB, only when you rule out TB, I can think of sarcoid. Don't make a mistake when you see non-caseating granuloma. Don't call it sarcoid. It's always tuberculosis. Fine. Okay. I'll definitely talk about sarcoid granuloma soon. Center part of the granuloma is where you have all the epithelioid cells. The peripheral part of the granuloma is where you see the lymphocytes. That's how granuloma will be. This is a non-necrotizing granuloma. So in the center of the granuloma, if at all I'll have the necrosis. So necrosis will be in center, surrounded by epithelioid cells, surrounded by your maybe giant cell or your lymphocytes. Is a classical appearance of granuloma, right? Okay, perfect. Now we are getting confused between sarcoid and Crohn's disease, also non-necrotizing granuloma. You are absolutely right, Shubham, right? I'll tell you a very easy way to remember it, right? So we have to ideally remember necrotizing and non-necrotizing granuloma. That's all, right? I just want you to remember only one thing. That's enough. If you can kill something, necrosis, cell death, that's all. If you can kill, it's necrotizing. If you can't kill, it's non-necrotizing. Just remember this, right? I'll give you questions. Now you are going to tell if you can kill it or you cannot kill it. TB, can you kill it? Just tell K or NK, whatever you want to say. TB, can I kill it? Yes. Necrotizing. Leprosy, can I kill it? Obviously. Pure neuritic leprosy, I can. Necrotizing. Histoplasma, can I kill it? Obviously I can kill it. Necrotizing. Coccidiomycosis, can I kill it? Obviously I can kill it. Necrotizing. Sarcoidosis, can I kill it? Sarcoid. Sarcoid, I cannot kill. If I cannot kill sarcoid, it becomes non-necrotizing. I'll write sarcoid last. I'll tell you why I'm writing it last as well. I cannot kill a sarcoid. Can I kill a foreign body like a coal or an silica or a suture material? Can I kill it? I cannot kill it. Foreign body granuloma is non-necrotizing. Can I kill an Hodgkin's lymphoma? I cannot kill it. Hodgkin's lymphoma, non-necrotizing. Can I kill a Crohn's disease? I cannot kill it. Crohn's disease, non-necrotizing. Tuberculosis. If my immunity is not good, can I kill a tuberculosis? I cannot kill. Non-necrotizing. By default, the first guy is by default TB. Whatever it's granuloma, the first guy is TB. And the way to remember this is, if I can kill, I cause necrosis, I cause necrotizing. If I cannot kill, I cannot kill, I don't cause necrosis, I cause non-necrotizing. As simple as that, right? Sarcoid is a diagnosis of exclusion. Please remember this, right? It's a diagnosis of exclusion. That's what is sarcoid. It's always by excluding it. If it is not anything else, I think of sarcoid. For me to tell sarcoid, I need few very classical findings. One, I'll just write the classical findings here. The patient might have hypercalcemia. Apart from the symptoms and everything, patient will have hypercalcemia. Second, patient will have classical X-ray findings of sarcoid. I'm sure Dr. Rishabh will talk to you about X-ray findings. Classical X-ray findings of sarcoid will be there. Third, you'll have elevated ACE enzyme, angiotensin converting enzyme for classical for sarcoid. Then last, I'll have non-caseating granulomas. Thank you, Shubham. It's a good short form, NCG. Non-caseating granulomas. Last, sarcoid granulomas is also called as naked granulomas. The reason for calling it a naked granulomas is someone said there'll be a lymphocyte cuffing, right? I won't have that here. Okay, so lymphocyte cuffing will not be there in sarcoid, so we call it a naked granuloma, right? There'll be no lymphocyte in the surrounding, there'll be no lymphocyte in the periphery, so we call it a naked granuloma. That's classical for sarcoid, right? Only when I have all this, please think of sarcoid, otherwise only TB, right? I'll give you a scenario which came a couple of years before in NEET PG. 13-year-old male presenting with fever, loss of weight, lymphadenopathy, lymph node showed a non-caseating granuloma. What's your diagnosis? Everyone. 13-year-old, fever, loss of weight, appetite, having lymphadenopathy. What's the diagnosis? It's undoubtedly TB. It should never be anything other than TB. It's undoubtedly TB. Okay? Just give me a second. Perfect. It's always TB. It should be nothing other than TB. Don't write up sarcoid. If it's non-necrotizing granuloma, fever, loss of weight, loss of appetite, cough, by default is TB. Please don't jump and diagnose sarcoid. I know sarcoid is exciting, right? It makes you feel superior, but it'll take you 1 mark away. Please do remember that, right? So we know about granuloma, necrotizing, non-necrotizing. We'll just go with few classical findings and few classical images with respect to granulomas, right? I'm sure you know most of the images. You just tell me what these are. The classical giant cell. Can you name the giant cell? It will be Anshad. The classical giant cell, that's your Langhans type of giant cell. Okay. Classical Langhans type of giant cell is seen in tuberculosis. In Langhans type of giant cell, we have a horseshoe arrangement of organism. Sorry, horseshoe arrangement of nuclei. If the nuclei is in the form of an horseshoe or like a U, we call it a Langhans type of giant cell. That's classically seen in case of tuberculosis, right? Now here, there's actually a pap smear image. Since it's having giant cells, I'm just going to talk about it. A giant cell is nothing but multiple nuclei. We call it a giant cell, right? It's a pap smear. The patient history is in the external genitalia, painful vesicles or ulcers? Can anyone tell me what will be the answer? Painful ulcers, vesicles, herpes, right? So multinucleation in case of your pap smear, okay, molding, that's also a classical finding for pap smear, and margination of chromatin, this 3M, right? So what do you mean by molding is, this is multiple nucleus, this is non-molded. One nucleus is here, the other nucleus is just pressing it, the other nucleus is just pressing it, altering the shape, that is molding. Margination, this is non-marginated, a uniform chromatin, non-marginated, fine. Margination means all the chromatin will go towards the corner, okay? So that's classical 3M. 3M along with pain, painful blisters, vesicles as diagnostic of herpes simplex virus, right? We might use them as in the microbiology. You must read about Cowdery type A, type B. I am not going primarily into that because it's very difficult to differentiate on a biopsy for an undergraduate with that, fine? Okay, next. What is the arrangement of nucleus? Round or horseshoe or haphazard? That's a classical circular, right? So when you have a circular arrangement of nucleus, we call this type of Jain cell two-tone variant of Jain cell. Where do you see two-tone variant of Jain cell? Is it lagging? I don't think it's lagging. Can you guys please help me with that? It's circular arrangement of nucleus, round, or we call it wreath-like arrangement, right? Wreath is something which you keep for the dead bodies, right? That's wreath-like arrangement or a round thing, fine. That's two-tone variant of Jain cell. It is classically seen in xanthomas, xanthelasmas. Xanthomas can be seen in the eyelid or in the tendon or in the subcutaneous tissue. There's a classical finding of xanthomas, xanthelasmas. Xanthoma is nothing but accumulation of lipid, right? So here you can see actually in this Jain cell, in the periphery, if you can see, you can appreciate the lipid deposits here. Lipid is clear. Tiny lipid deposits surrounding that. That's a classical finding called a two-tone Jain cell, right? Perfect. Does it look like an outside? Obviously, it looks like an outside, right? It does look like an outside, fine. This also looks like an outside. Maybe kind of. Maybe three-eyed owl, right? It also looks like an outside. There are two guys in outside, right? One is Shivam. Yeah, one is CMV, one is Hodgkin's lymphoma, RSL, right? You guys have to say which is CMV, which is Hodgkin's lymphoma. Obviously, this outside, you must have seen this outside multiple times. When you see a blue inclusion or a basophilic inclusion, it is CMV. CMV's inclusion actually will be both the cytoplasm also as inclusion, and the nucleus also as inclusion, right? CMV's inclusion will be basophilic, and that's a classical cytomegalovirus inclusion, classic outside appearance, right? Second thing here, this nucleoli will be a pink nucleoli. In case of an Hodgkin's lymphoma, the Reed-Sternberg cell, in case of a Hodgkin's lymphoma, it is also outside, but it'll have a pink nucleoli, right? But this is how I differentiate them on a microscopy. But honestly speaking, you need not remember this. Can I say both of them will have a classical different clinical symptom? Most of your questions are scenario based. FMG, NEET, INSD, whatever it is, scenario based. I don't think no one ever will give you a spotter of an RS cell or a CMV and ask the diagnosis. If they're asking, no, don't worry. The examiner has gone crack. No one any point of time is going to diagnose based on microscopy. Symptom of a lymphadenopathy, I think of Hodgkin's lymphoma. CMV retinitis or CMV in the congenital transformation or the liver failure or hepatitis, I think of a cytomegalovirus. That's all. I need a history, I can think of cytomegalovirus. Otherwise, I think of Hodgkin's lymphoma. Even someone is going to ask you only image, blue for CMV and your pink for a Hodgkin's lymphoma. Fine. Okay. So this also is a multinucleated virus. Again, it's a very, it's also a virus disorder where it's seen in measles. A multinucleated Jain cell in measles called as Warthin-Finkelday Jain cell. Measles has reduced lots because of vaccination, but still measles pneumonia is coming back in foreign countries where they're not vaccinating them because of the agenda and everything. So Warthin-Finkelday Jain cell, measles pneumonia is very, very classical. It's also multinucleated and have pink color, both intracytoplasmic and intranuclear inclusion bodies. Pink intranuclear intracytoplasmic is measles, Warthin-Finkelday Jain cells. Blue intranuclear intracytoplasmic is your CMV, and the ulcer or cytomegalovirus. Fine. Okay, perfect. Okay, next, shape diagnosis. This very unique or a specific type of granuloma. What's the diagnosis? It looks like a donut, right? It's donut shaped granuloma. Fine. If you want to call it donut or duff nut, whatever it is, it's a donut shaped granuloma. Donut shaped granuloma can be seen in very particular conditions. It can be seen in liver. It can be seen in bone marrow as well. Fine. Perfect. It can be seen in Q fever. That's one. And also it's seen in allopurinol toxicity. In case of allopurinol toxicity also, you can see a donut-shaped granuloma. Not very common, but yes, it can be seen. But liver and bone marrow is where you can see this type of granuloma very classically, right? It's kind of a vasculitis. Though it's not much useful for us these days, we call it drugs granuloma. Where you see drugs granuloma? It's classically seen in case of an cerebral malaria, right? So in case of cerebral malaria, we see drugs granuloma. That's a classical finding in case of cerebral malaria. That's drugs granuloma. Okay, though we don't use it anymore, we see them in cerebral malaria, right? So we have something called microgranuloma. If you have less than 25 epithelioid cells, it's small. I call it microgranuloma. Microgranuloma is classically seen in Toxoplasma lymphadenitis. And what is the vector or organism which is going to spread Toxoplasma? Which is cats, right? So cat related Toxoplasma lymphadenitis, classically you see microgranulomas. Fine, perfect. Okay, this granuloma, actually it's not regular. I can actually use the term irregular, or if you want, I can use the term star shaped or a stellate shape, right? So where do you see stellate granuloma? Stellate granulomas are seen classically in your, this is what we see in cat scratch disease, right? I think Selva has answered a little bit far-fetched thought, right? We see them in cat scratch disease. What's the organism? Bartonella henselae, right? Okay, Bartonella henselae, we have cat scratch disease, right? Perfect. I can also see in lymphogranuloma venereum. You are absolutely right, Hemant. LGV, I can see them, and classically in cat scratch disease, right? The unique thing about stellate granuloma is not the shape. This granuloma will have both all the classical features of granuloma. In addition to that, I will also have neutrophils. That's what makes the granuloma very, very unique, right? I want you to remember this. The reason you are going to have neutrophils is here in the pathogenesis, Th17 pathway will be activated. Generally, granuloma is due to Th1 pathway. If you're going to activate a Th1 pathway, I see granuloma. Th2 causes what? All these are T cells pathway. T cell has three pathways. One is granuloma for Th1. If it is Th17, we call something as an acute on chronic inflammation. If it's acute on chronic inflammation, it's Th17. That's why I have granuloma plus neutrophils classically seen in stellate granuloma. Where do we see Th2 response? Th2 response is generally seen in allergic conditions, right? In case of an allergy, type 1 hypersensitivity have a Th2. That's three types of T cells reaction. In case of stellate granuloma, you have Th17 response, acute on chronic, and Th2 for allergy, and Th1 for granuloma formation, right? Perfect, great. Okay, can we add a little bit more examples for Th17? Acute on chronic inflammation. I'll give you clues. I want you to tell the answer. You have a condition in the skin where it's an kind of a grayish patch which is completely itchy. What diagnosis comes to your mind? What diagnosis comes to your mind? Any diagnosis comes to your mind? Very common diagnosis, chronically patched there, silvery white patch to be very specific. It's completely itchy. You peel them, you have tiny deposits of blood. Psoriasis? Perfect. Psoriasis is a chronic condition or acute condition? Psoriasis. Obviously chronic, right? It's definitely chronic. But have you also read that in psoriasis, you will have an abscess? Can anyone name the abscess? Microscopic finding, I'm sure you must have read that in dermatology. What's the abscess name? Monroe's microabscess. That's an example. So psoriasis also I have mostly Th17 pathway. So it's a chronic disease. At the same time, I'll have Monroe's microabscess, an acute condition, right? That's classical for Th17 pathway. One example. One more example. You must have heard about ulcerative colitis, Crohn's disease, right? Acute or chronic? Obviously chronic, right? Especially in case of ulcerative colitis, you must have definitely heard this finding also. It's a chronic inflammatory bowel disease. You must have also read about cryptapsis. It's a chronic condition, but I'm having an abscess. Abscess is a collection of neutrophils, right? So all these conditions, I'll have Th17 pathway. Whenever Th17 is activated, I'll have an acute problem and a chronic problem. Same like this. I'll have a granuloma plus neutrophils. I have psoriasis plus Monroe's abscess. I'll have ulcerative colitis plus cryptapsis, fine? That's for the celiac granuloma and the extrapolation of that, fine? Okay. So we have done with inflammation chapter. Can we quickly go through like before? I want you guys to open your mouth and say yes. If you open your mouth and say yes, we'll definitely go and have a quick look at it. Yes, no, maybe. Shall we? Only Harsh wants it. Others, come on. Let's be more enthusiastic. Go along with the mobile phone or tablet, whatever you're seeing. Go have a cup of coffee. Along with that, keep sipping and let's do it. Fine. It's okay, Shubham. You'll remember it. Okay, let's start. Fine. So we start with acute inflammation. Acute inflammation, the hallmark is going to be your vasodilation, increase in vascular permeability, and it's going to be neutrophils, eosinophils if it's allergy. Chronic inflammation, the cell of chronic inflammation is macrophages. You'll have lymphocytes if it's an autoimmune disorder or viruses. Classical hallmark is tissue destruction, healing by fibrosis. Just by knowing that lymphocyte is seen in autoimmune disorder, we can apply that in multiple places. Lymphocyte, hypothyroid, Hashimoto. Lymphocyte, hyperthyroid, Graves. Lymphocyte, and swollen salivary gland, lacrimal gland, I can say it is an lip biopsy, Sjogren syndrome. Just lymphocyte is an autoimmune disorder. I can apply in multiple places, right? Then we came with different events. Margination is primarily a vascular phenomenon. Because of dilatation, they'll go and deposit that. Not sure about the answer. It's a vascular phenomenon. Selectin helps. Then it'll start rolling. Rolling is with Cialis and your selectin. Selectin E-selectin is present in endothelium. P-selectin is also present in endothelium and platelets. In endothelium, they have in a structure called as weevil palate bodies. This binding is very weak, so it keeps on rolling. It'll stop at some point where integrin binds with CAM molecules. We have beta 1, beta 2, two types of integrin, and CCAM and ICAM and VCAM, two types of CAM, right? Once they bind, it's more strong and they adhere there. Once they adhere, then they will escape or transmigrate. For transmigration, we need CD31 or your PCAM1 along with an MMP or collagenases. I need the collagenase, then it'll automatically go outside. It'll go to site of infection. Site of infection movement is based on chemotaxis. Chemotaxis is unidirectional. Chemotaxis is based on actin polymerization only, right? So you have leukotriene B4, C5A, and your interleukin 8 for endogenous. Exogenous, any bacterial products can attract me. I go to site of infection, you engulf the organism, and then respiratory burst happens inside the phagolysosome of the WBC. It's oxygen dependent. NADPH oxide converts them to O2 minus superoxide dismutase. With the help of superoxide dismutase, it becomes H2O2. H2O2 has two outcomes. Either an MPO related HOCl destroys bacteria. HOI related with the MBP destroys the parasite, right? Automatically it'll kill them. And the anti-inflammatory cytokines will start and reduce the inflammation, right? So we have diseases based on the inflammation. If the Cialis is not present, or the integrin is not present, I have LADs. Integrin LAD1, I looks like 1 for integrin defect. We have recurrent pustular infections, neutrophilia, and the classical clue here is delayed separation of umbilical cord, not bleeding. Bleeding is in bleeding disorder, right? It happens as a factor 13 deficiency or Glanzmann thrombasthenia. Here, delayed separation or delayed falling of umbilical cord, right? 2 looks like an S for Cialis, also an autosomal recessive. A classical clue is here, Bombay breadfruit. Both will have neutrophilia in spite of being an immunodeficiency disorder, right? Next, CGD, chronic glandular disease, 2 isoforms of NADPH oxidase. So 2 inheritance, autosomal recessive and X-linked recessive. Catalase positive organism infection is very, very classical. NBT, nitroblue tetrasolium test, and DHR assay is used for diagnosis. Enzyme assay can be used if it's a very high functioning setup, right? Chidiac-Hashi, autosomal recessive, LYST gene defect. So there's no phagolysosome formation. Because of the no phagolysosome formation, all the granules become big. There's very, very specific gene granules. And other findings are albinism, peripheral neuropathy, and thrombasthenia, in addition to recurrent infections by default, right? Then we came to MPO deficiency just to complete autosomal recessive, very, very rare things, right? Chronic microscopy, you'll have granuloma. The principal cell is only your epithelial cell, not the giant cell. And to form the epithelial cell, I need interferon gamma. That's what we use in TB assay as quantiferon gold assay. We assay the interferon gamma and use it, right? There are 2 types, K-shading, non-K-shading. Whatever it is, the first diagnosis is TB. Center there'll be necrosis, center there'll be epithelial cells, surrounding there'll be cuff of lymphocytes, fine? Okay, so how to differentiate K-shading or non-K-shading? Kills, not kill. If my body can kill any organism, TB, pure neurotic leprosy, histoplasma coccidio, my body can never kill Crohn's, Hodgkin's, or your foreign bodies or your sarcoidosis, I go for non-necrotizing. My body, if there's not good immunity, cannot kill TB also, there also I go for non-necrotizing granuloma, right? Sarcoid is always and diagnosed by exclusion. If you have an elevated ACE levels, hypercalcemia, classical X-ray finding, and a naked granuloma and non-necrotizing granuloma, think of sarcoid. Only when you have ruled out TB. If you're not ruled out TB, you cannot think of sarcoid by default. Few images. Giant cell is multiple nucleus. In a cell is giant cell. If the nucleus is form of a U, Langerhans type of giant cell seen in tuberculosis. If the nucleus is form of a circle, two-tone type of giant cell seen in case of xanthoma, xanthelisma. Sometimes a multinucleation can be like marginated chromatin and molded nuclei seen in pap smear. Again in giant cell seen in herpes simplex virus, right? And I have two types of owlsi. Blue intracytoplasmic internuclear, CMV, pink nucleoli, RSL, Hodgkin's lymphoma. Sometimes I do have pink intranuclear inclusions in multiple seen measles, cause and Warthin-Finkelday giant cells as well. Fine. Okay. Few unique varieties of giant cells. Donut-shaped giant cells seen in liver and bone marrow in Q fever, Coxiella brunetti organism, and allopinotoxicity. Drugs granuloma seen in cerebral malaria. Again, not much useful, just for historic purposes. Microgranuloma. When there's less than 25 epithelial cells, we have tiny granuloma seen in cat. Also tiny toxoplasma lymphadenitis, right? Stellate granulomas is irregular granuloma with neutrophils, LGV obviously seen, and also cascade disease, your lymphogranuloma venereum and your Bartonella insulae infection. The uniqueness is neutrophil. The reason why there is neutrophil is TH17. So whenever TH17 is activated, automatically ends up in having this. Fine, clear? Let's go to the next one. Just give me a second. Okay, let's start. So we have to go to genetics. Little bit about genetics. The primary focus for genetics is your pedigrees, right? We'll just quickly go through pedigrees and we'll finish them, fine? So there are rules of pedigree. The first one I want you to rule out is rule out a mitochondrial inheritance. You have to rule that out. Then you have a flowchart for autosomal recessive. I have a flowchart for autosomal dominant pedigree. You go with that. That's much more easy. All of you guys have the PDF? Yes, no, maybe? Do you have? I think you should have, right? So if you have the PDF with you, I want you to just go through this two flowcharts. Then we'll definitely go ahead and apply the flowcharts. First, always rule out mitochondrial. If mom is affected, all 100% of the children is affected is mitochondrial. If dad is affected, none of them is affected is mitochondrial. That's a classical thing for mitochondrial inheritance, right? So once that is done, if you have any pedigree given to you, I want you to ask this question, whether all generations affected or not, right? I'll just show you a pedigree. In this pedigree, all generation affected, yes or no? No, because the first generation, no one is affected. When I say all generation being affected, at least one in every generation should be affected, right? So here it's not affected. Perfect, right? Let's go back to this. If all generations not affected, the answer is no. I think of a recessive disorder. There are only two recessive disorders. If only men is affected, this is only for men, X-linked recessive. If both the genders are affected, I think of an autosomal recessive disorder. Very simple. All generation affected, answer is no. Only men, both men and women. If it's both men and women, autosomal recessive, only men, X-linked recessive. If it's not fitting into this, go for the next one. All generation affected, if the answer is yes, I go for the next question. Dad to son transmission. Is the dad transferring the disease to the son? If the answer is yes, definitely autosomal dominant. If the answer is no, X-linked dominant. And then if it's X-linked dominant, ask one more question to confirm. If the dad is affected, is 100% daughters being affected? All the daughters of the dad are affected. If the answer is yes, X-linked dominant. If the answer is no, goes back to autosomal dominant, right? There's a very two important flowcharts. I want you to read this flowcharts a day before the exam. If you do it right, amazing. Let's go, skip it, that's all. Don't ever look at pedigree again. If you're either taking medicine or pathology or pediatrics in future, we'll learn more about pedigree. Otherwise, for an undergraduate, this should be more than enough, right? I'll repeat this pedigree once again, flowchart once again. All generation affected, answer is yes, dominant disorder. Then dad to son transmission. If dad is giving the disease to his son, yes, and it is autosomal dominant. No, maybe X-linked dominant. Then if the dad is affected and all 100% daughters are affected, the answer is yes, definitely an X-linked dominant. If the answer is no, goes back to autosomal dominant, right? So now what we're going to do is, I want you to just apply these three rules. Always the first rule is rule out mitochondrial. That's the first rule. Mom affected, 100% daughter affected, 100% of the children affected, dad affected, none affected. That's the first rule. If not, let's look at this flowchart, right? So now what I'm going to do is, I will show you the pedigree. You look at the flowchart, you apply, tell me the diagnosis. I'll definitely help you here. Is it mitochondrial? Let's quickly answer. Just put Y or N for yes or no. Is it mitochondrial? Definitely no. Because mom affected, not 100% the kids are affected. So definitely not mitochondrial. So I go with the flowcharts. All generation are affected or no? Definitely all generations are not affected, right? The first generation not affected. So what do I go for? The recessive flowcharts, right? So in the recessive flowchart, what's the next question? All generation not affected, I think of a recessive. If I think of a recessive, next question is only men or both men and women. Here it is, both men and women, autosomal recessive. That's it. You need 5 seconds to solve a pedigree. That's all. If you cannot solve a pedigree in 5 seconds, be confident the pedigree is wrong. That's how confident it should be, because these rules are not my rules. These are Gregor Mendel's rules, the father of genetics. He cannot go wrong, right? As simple as that. Okay. Is it mitochondrial? Yes, no, maybe. Definitely no, right? I cannot say it's mitochondrial with this information because there's no mom affected in the pedigree, right? Okay. Now let's go to the flow charts. All generation affected? No. All generation not affected because the first generation is not affected. So dominant or recessive? Recessive, right? If it's recessive, only men, both men and women. Only men, so it's only men. Shubham, so it is X-linked recessive. It's as simple as that. It has to be X-linked recessive by default, right? Okay, that's all. It's as simple as that. Anshat and Shubham, if it's both men and women, I think of autosomal. If not, I think of X-linked recessive, right? Perfect, amazing. That's all. Okay, next. Is it mitochondrial or not? If it's mitochondrial, the rule is simple. Mom affected, all kids affected, dad affected, no one affected. Is it mitochondrial or not? Absolutely, it's mitochondrial. It's mitochondrial, right? This is where I don't want you to do a mistake. Mom affected, all kids affected. Mom affected, all kids affected. Dad affected, no kids affected, right? Don't miss this. If you miss this, what you'll do is, okay, all generation not affected, so I think of recessive. Both men and women affected, autosomal recessive. Fine. Shubham, no carrier will be there in pedigree. Carrier means it's like this or like this. Have you seen any pedigree like this? In reality, no pedigree comes like this. Because if I put as carrier, by default, I'm saying it's a recessive inheritance. That's why we don't put carrier in pedigrees. It's generally be affected normal. That's all. Carrier is a different symbol in pedigree, which is not seen in this pedigree at all. Fine. Okay. I'm talking about affected, not about carrier state at all, right? So it's mitochondrial. First, always look at mitochondrial. The flow chart, like I said, is based on Gregor Mendel. Mitochondria is a non-Mendelian inheritance. That's why it doesn't fit into this. Fine. Okay. So it's very simple for you to apply this pedigree. Any pedigree you see, apply these 3 rules. That's more than enough. You will solve a pedigree. And please don't forget, the day before the exam, I want you to use this. Fine. Yes, absolutely right, Anshat. Females are generally carriers in X-linked recessive, and men are generally affected in case of an X-linked recessive. That's why I said if it's affected only men, think of an X-linked recessive disorder. Very simple. Fine. Okay. Now, the second biggest concern for us is I need to memorize which is dominant disorder, which is recessive disorder, right? And there are lots of mnemonic. There's a mnemonic for recessive disorder called A, B, C, D, E, F, G, H. Right? That's alphabet, not a mnemonic, right? We'll go with concepts. We'll go with pure logic and understanding. It's very, very simple to remember dominant disorders and recessive disorders. Fine. Okay. For dominant disorders, I just want you to remember this. Cancer syndromes are almost always dominant. If the structural protein error, when I say structural protein, spectrin or an ankyrin is a structural protein, it is. Collagen, structural protein, it is, right? Structural protein error is dominant by default. If it presents later in life or in adults, it's dominant by default, right? So these are the 3 things what I want you to remember for dominant disorders. If something is not fitting into this, those let's memorize. If I memorize everything, tiny brain particle, right, to memorize. I cannot memorize everything. Just 3 things. Cancer syndromes, errors in structural protein, later in life presentation, it's dominant disorder. This is a table from Robbins. The table from Robbins will be taken care of. Neurofibromatosis, cancer syndrome, tuberous sclerosis, cancer syndrome, yes. ADPKD, what's the presentation? Later in life. FAP, cancer syndrome. Hereditary spherocytosis, structural protein. Von Willebrand disease, later in life presentation. Marfan syndrome, structural protein. Ehlers-Danlos, structural protein. Osteogenesis, structural protein. It will fit into that. If it's not fitting into this, let's memorize. Dominant disorders present later in life. Dominant disorders are always mostly mutated structural protein mutation. Dominant disorders, every cancer syndrome is a dominant disorder, right? These three can help me extrapolate anything. Whatever you read going forward in any subject, use the rules. If it's fitting into it, it's dominant. X-linked dominant is very rare. So we'll think of autosomal dominant only, right? Same way, I have few simple rules for recessive. It's very, very simple. Unfortunately, we are memorizing many things. In recessive, if it's presenting early in life, if it's an congenital disease, generally it is recessive. There's a rule of recessive. Enzyme deficiencies are recessive. Inborn errors of metabolism. Biochemistry has huge table, right? Everything is recessive. And someone said carrier state. Carrier state will be seen only in recessive. Can never be seen in dominant. That's all. These three are enough for me to identify inheritance of any disease. Right? Carrier state, inborn errors of metabolism or an enzyme deficiency, right? Or early life presentation and your congenital, right? Anshad, no mnemonic here. These are the only three things I want to remember. Early in life presentation, enzyme errors, inborns and carrier state. Let's apply this to the table. You can easily remember everything. Cystic fibrosis, presents early in life, meconium is a symptom, right? I'll come to that, Shubham. Phenylketonuria, enzyme, enzyme, alpha-1 antitrypsin, early in life, enzyme. Sickle and thal will have trait or carrier state. Congenital adrenal hyperplasia, enzyme deficiency. Alkaptonuria, enzyme deficiency, right? So that's enough. Almost every disease which is recessive in condition will have this. Hunter is X-linked recessive, not autosomal recessive, right? In the mucopolysaccharidosis table, Hunter is X-linked recessive, rest everything is autosomal recessive, right? So these are rules of recessive disorder. Hunter will also fit into the rule. It's X-linked recessive. Can I say G6PD deficiency is a recessive disorder? Is it enzyme deficiency? G6PD, glucose-6-phosphate dehydrogenase, enzyme deficiency. This also is X-linked recessive. It will be recessive, that's all, right? The rules of dominant and recessive are very simple. Just remember the three ones. Dominant is cancer syndrome, later in life, and structural protein. Recessive is early in life, carrier state, and enzymes or inborn errors. That's all, right? So these are all exceptions. We'll leave the exceptions alone. Rest everything will automatically fall in place, right? 3 points for dominant, 3 points for recessive. In an exam, a question will come. Use these rules and you will definitely be able to say what disease, what inheritance it is. It's not difficult at all, right? Anshad, the only reason for not going for mnemonic is it's very difficult to remember. I'll give you a random question. You tell me the inheritance. There's a disease called as achondroplasia. How many of you have heard the disease? Achondroplasia. Let's leave achondroplasia. Have you known the person in Game of Thrones called as Tyrion Lannister? Have you seen the patient? Have you seen him? The tiny short form, Tyrion Lannister? You must have, right? So achondroplasia, can I say it's a problem in the bone or structural protein defect? Yes. Achondroplasia, short person, structural protein defect, yes or no? Yes. So inheritance, dominant disorder. That's all. Again, I don't want to memorize. You know a disease, you know what is the problem of the disease, you can tell the inheritance. Marfan's, long, dominant disorder. Structural protein, that's all. Okay. Albinism. Can albinism be due to an enzyme deficiency? Tyrosine pathway enzyme deficiency, yes? So what do you think will be the albinism's inheritance? Recessive inheritance. So if I know a disease, I know what pathway it is, I know what is the problem, I can definitely tell the inheritance by default, right? It's just these three things, remember, you can automatically tell what is the issue, fine? Okay. Let's go to the next one. So we'll have a quick recall on genetic diagnosis. Genetic diagnosis can come in an exam, maybe not restricted primarily to pathology. You might have an correlation to your medicine, surgery also. What I am going to use, what is the investigation, what I'm going to use. That's the basics what you're going to read here, right? So I'm going to divide genetic disorder and genetic diagnosis into two major things. One is called as cytogenetics. Under cytogenetics, I have two things, fish and karyotyping. Next is molecular genetics Under molecular genetics, we have all of the rest, PCR, the real-time PCR, the qPCR, everything. PCR and its variants and your sequencing and its variants comes under molecular genetics, fine, and cytogenetics, fine. So we have different groups of genetic disease. A mutation. What is Down syndrome? What is Down syndrome? Down syndrome is trisomy 21. That comes under aneuploidy. BCR-ABL translocation, Philadelphia chromosome and CML translocation, right? So if a problem is in the chromosomal level, it's very big defect. Mutation is a tiny one nucleotide defect. Chromosome level is a very big defect, right? So if a problem is a chromosomal level, aneuploidy or a translocation, the best for me is fish. Then I go for karyotyping. This I can use for anything. You had a PYQ where there's a translocation in case of an Ewing sarcoma. What's the best test? It's fish. CML, what's the best test? It's fish. Any aneuploidy, trisomy, what's the best test? It's fish. Any aneuploidy, any translocation, fish is the best test. If not, do a karyotyping. If I have a chromosomal arm or an exon deletion, there's a test called an MLPA. Just remember the name. MLPA, there's an abbreviation like fish. That's a test where it's used. There's only one use which I want an undergraduate to remember here. We have a disease called as DMD. Have you heard them? Duchenne's muscular dystrophy, Grover's sign positivity. But I've definitely heard, right? DMD, the classical thing is MLPA. Right? MLPA is a classical thing done for Duchenne's muscular dystrophy. You stand up on yourself, right? Classical thing, and your Becker's muscular dystrophy. That's the only thing which an undergraduate you have to know about it. Grover's sign, right? Perfect. Then point mutation. Point mutation, the best example I can give is sickle cell anemia. You know for a fact, right? Beta globin 6 chain glutamic acid to valine, sickle cell anemia. It's a point mutation. For any point mutation, the investigation of choice by default has to be PCR. PCR will be the investigation of choice for every point mutation. Okay, I've written here only. Okay, for every point mutation, PCR is the investigation of choice. For every point mutation, gold standard is sequencing. Even for my sickle cell anemia, the gold standard is sequencing by default. Flow will not come under genetic test. I'll definitely talk about flow also here. Flow is not useful for sickle cell anemia. Flow is useful for leukemias and lymphomas, right? Okay. We have something called an hemoglobin electrophoresis, HPLC. We can use that as well. I gave an example of sickle cell anemia for you to understand point mutation. I'm not saying only sickle. Any point mutation, I'm going to use this only to diagnose, right? Quantitative. If you have to measure something, like we said, COVID, so many viral particles there. HIV virus, so many viral particles. I need to measure, right? Because that's useful for starting an ART management, right? If you have to quantitate or measure, I have qPCR. qPCR is quantitative PCR, or the other name is real-time PCR. Okay. Please do remember, RT-PCR is not real-time PCR. Most often it's been mistaken. qPCR is real-time PCR. I will tell you what is RT-PCR stands for. RT-PCR, where do we use? RT-PCR first stands for reverse transcriptase PCR. How many of you thought RT-PCR was real-time PCR till now? If you thought till now you know what is RT-PCR, it's reverse transcriptase, you are much greater than me. Till my starting of MD, I thought RT-PCR means real-time PCR, right? RT-PCR is reverse transcriptase PCR. Reverse transcription means converting an RNA to a DNA. That's what RT-PCR stands for, right? Reverse transcription, RNA to a DNA, right? So RT-PCR means it is useful for every RNA virus. That's all. Or if you have to estimate any protein. If you have to estimate a protein product or an RNA virus, I use RT-PCR. RNA to DNA, then I amplify the DNA with PCR. So COVID, RNA virus, RT-PCR. HIV, RNA virus, RT-PCR. Any RNA virus, any protein product, I want to quantify it. I use real-time reverse transcriptase PCR, but reverse transcriptase is for RNA virus, qPCR is for quantification, sequencing is gold standard, PCR for diagnosis, MLPA for DMD, and anything chromosomal is FISH or your karyotyping, right? So this should be enough for you to apply in multiple things, right? I'll come to flow cytometry also, since you guys asked about flow cytometry. Flow cytometry is the investigation choice for every leukemia, except one leukemia. There are only 4 leukemias for you. Acute myeloid, acute lymphoid, chronic myeloid, chronic lymphoid. There are only 4 leukemias primarily, right? For an undergraduate, as such, I have only 4 leukemias. For all these 4 leukemias, my investigative choice is your flow cytometry, except for CML. What's the investigative choice for CML? We don't do flow. What do we do? FISH, BCR-ABL, right? We use FISH, BCR-ABL for CML because CML, I don't want flow cytometry. Acute myeloid, acute lymphoid, chronic lymphoid, I use flow cytometry, fine. For AML, for ALL, for CLL, I use flow cytometry. For CML, we use FISH, fine. Okay, that's in short about genetic diagnosis, fine. Let's quickly go to few things in amyloid. Say I'm ignoring hypersensitive reaction here for the only reason. Just give me a second. Okay, I'm ignoring hypersensitivity reaction for the only reason that it will be covered in microbiology also. That's why I'm ignoring it. We'll just go to amyloid. Quickly see few things, important things amyloid. Amyloid, what is it is? It's a deposition of a non-branching beta platelet sheet. It's an extracellular protein deposit. That's what amyloid is. It's not inside the cell. It's an extracellular protein deposit. In multiple conditions, we call it amyloid. We name multiple amyloid with the names. A in everything here stands for amyloid. AL for amyloid light chain. You're going to tell me which all diseases you will see here. Amyloid light chain, which disease? You know the answer. Come on, quick. Where do you see amyloid light chain? You see amyloid light chain in? Perfect. You see amyloid light chain in myelomas. Multiple myelomas, right? Perfect. AA and chronic inflammation related amyloid. You can see them in any case of chronic inflammation. And there's actually one more condition called as familial Mediterranean fever. It's an inherited condition, familial Mediterranean fever, and in any chronic inflammation, TB, rheumatoid arthritis, you'll see them, right? Where do you see A, beta to M? Beta to M is in case of hemodialysis. Everything here is going to be chronic. Even if I'm not saying chronic, it's chronic hemodialysis only, fine? ATTR. Now, Alzheimer's is A beta, fine? Okay. ATTR is seen in two conditions. One is senile, age-related senile systemic amyloidosis, and one inherited familial amyloidotic polyneuropathy. Okay, in both these conditions, you will see this. The only difference is in senile amyloidosis, it will be normal ATTR. In familial amyloidotic polyneuropathy, it will be a mutated ATTR. It's inherited, right? It has to be a mutated ATTR. Here, it's a normal ATTR, right? ACAL, where do you see? CAL stands for calcitonin. We see them in medullary carcinoma thyroid. In medullary carcinoma thyroid, we see ACAL or calcitonin. A beta, where do you see A beta? This is where you see them in Alzheimer's, right? A beta or A beta 42, whatever it is, right? There are two things, either A beta or A beta 42. I see them in Alzheimer's disease. Okay, we see classic in Alzheimer's disease. AIPPP. IAPP stands for islet amyloid polypeptide. It's islet amyloid polypeptide. Where do you see islet amyloid polypeptide? In islets of Langerhans, it's in pancreas, and classically seen in case of type 2 diabetes mellitus. It's never seen in type 1 diabetes mellitus. It's seen in type 2 diabetes mellitus. Remember that. Don't make a mistake because type 1 excites you. Type 2 never gives excitement because we all will be patients in future, right? So type 2 diabetes mellitus, pancreas, we see AIPP, fine. The most common organ affected by amyloid is kidney, renal. The most common cause of death in amyloid is cardiac amyloid deposit. Okay. And the preferred site of biopsy. Which site do you prefer for biopsy? It's always your abdomen fat pad is preferred, or your rectal mucosa, or your epithelium, fine. Okay. Perfect. Abdomen fat pad is definitely preferred than anything. And by default, in a normal routine HNE, amyloid will be pink in color because any protein will be pink in color. But when you do a stain, the special stain here is Congo red. We just now saw during the image-based discussion, the stains is actually Congo red. In a normal finding, this is the stain of Congo red, where you have the salmon pink color. It's kind of an orangish pink color, the salmon pink color. And in case of polarized light, Shubham, what's the color in polarized light in amyloid? It's apple green birefringence, not a negative birefringence, right? Okay, you'll see apple green birefringence in case of polarized light. That's a classical finding seen in amyloid, right? There's a normal HNE for amyloid. There is a pink deposit here of amyloid, and there's a salmon pink color in Congo red in light microscopy, And in apple green birefringence, we already saw how it looked like. Fine. That's about simple short term discussion on amyloid deposits. Fine. Okay, this is the apple green birefringence. Okay. So now, neoplasia is a very big topic. Let's kind of quickly read or recollect few important genes in cancer, maybe few important points which has been asked in PYQ, and about paraneoplastic syndrome and tumor markers, because there's a very high possibility these might come as alone as a question or a part of a scenario based question. Fine. Okay, this is your apple green birefringence in case of an amyloid. Okay, perfect. Okay, let's go to few important tumors and to few important genes. Okay, let's go. Yeah. So see, there are there is a group of genes called as proto-oncogenes, and there's a group of genes called as tumor suppressor genes. Okay, tumor suppressor genes is different, proto-oncogenes is different. Proto-oncogenes normal functions to promote division, right? That's proto-oncogenes. Normally, it will increase cell division. Tumor suppressor genes normally, as the name says, tumor suppressor, normal functions to reduce cell division. Okay. So when a proto-oncogene is mutated, we call it oncogene. Oncogene is nothing but a mutated proto-oncogene. And this mutation should always be gain of function mutation. Normal functions to increase cell division. So when there's more gain, obviously you'll have more cell division, more things, right? Obviously you'll have more division, more cells, more cancer, right? Good evening, Aniket. Fine. So that's for oncogene. Fine. So these are few classical oncogenes which can come in an MCQ. Perfect. EGFR receptor family. I have included EGFR receptor family. There are two things in EGFR receptor family. One is your EGFR, that is your ERBB1. That is EGFR. Like Shubham said, I can see them in lung adenocarcinoma. And there's one more thing called as ERBB2. ERBB2 is HER2/neu. Where do you see HER2/neu? You see them in breast cancer, right? Please remember, because last NEET or INSJ, I think some question has come on ERBB1. We know EGFR, we didn't know the name ERBB1. ERBB1 is the other name for your EGFR. ERBB2 is the other name for HER2/neu. Please do remember that. Fine. Okay, perfect. So EGFR, I'm going to see them in lung adenocarcinoma. Only lung adenocarcinoma, not in lung squamous or small cell. And obviously HER2/neu, like you guys said, I'm going to see them in breast cancer. Fine. BRCA is your breast cancer by default, right? ALK receptor, again I can see them in lung adenocarcinoma. That's one place you can see them. And also you can see them in a lymphoma called as ALCL. Anaplastic large cell lymphoma, ALCL. KRAS, you have to know must in 3 cancers. Can anyone tell me at least one cancer where you see KRAS? KRAS is like diagnostic in quite a few cancers, but in a few cancers it's like must to know. Must for pancreas, must for colon, and must for lung. All adenocarcinomas. Colonic adenocarcinoma, pancreatic adenocarcinoma, lung adenocarcinoma is must. It said that you will not have one single pancreatic adenocarcinoma without KRAS mutation. That much is important. All these 3 places is important, right? Copal looks good, right? Colon, lung, and pancreas, right? I'll use that silver. Thank you for it, right? ABL. ABL is the BCR ABL. Where do you see? CML. In the BCR ABL, ABL is the oncogene. BCR is just a translocating part, and we see them in CML, right? JAK2 is a classical thing seen in polycythemia vera, but it can also be seen in myelofibrosis and other chronic myeloproliferative disorder, but classically seen in case of polycythemia rubra vera or polycythemia vera, right? 𝐒𝐾𝐝. There are multiple tumors where you can see 𝐒𝐾𝐝. At least I want you to remember a couple of them. Any tumor you know in 𝐒𝐾𝐝? 𝐒𝐾𝐝 mutation? Just amazing. Any other thing? Obviously, just will have 𝐒𝐾𝐝 mutation. Mastocytosis has 𝐒𝐾𝐝 mutation. Systemic mastocytosis, which is a mast cell disorder, right? Perfect. And also one more thing, great. Seminomas, dysgerminomas also will have 𝐒𝐾𝐝 mutation, fine. Seminoma, dysgerminoma, you'll have 𝐒𝐾𝐝. Just you'll have 𝐒𝐾𝐝, and also systemic mastocytosis. Remember them, they also have 𝐒𝐾𝐝 mutations, right? Perfect. And one more important addition to 𝐒𝐾𝐝, whenever 𝐒𝐾𝐝 is positive, always remember I can treat the tumor with imatinib. 𝐒𝐾𝐝 is also a tyrosine kinase. I can use imatinib to inhibit them, right? Melanoma, I won't think of a 𝐒𝐾𝐝. I have one more guy for melanoma, which is more important for me, called as BRAF. BRAF, I think of melanoma. I can think of hairy cell leukemia. And I can think of LCH, Langerhans cell histiocytosis. All these three you'll have BRAF mutation. Melanoma is more of BRAF than c-KIT mutations. Fine. Okay. Great. So a few, if it's hematology resistant, you can use sunitinib, obviously. Fine. I don't go into pharmacology. I restrict to myself. Few things which is related, I'll definitely talk about that. Fine. Okay. So these are classical things which are groups for oncogenes. PTC also will have BRAF. You are right, Shubham. But see, whatever I'm saying here, are practically applicable. Have you ever seen any surgeon doing genetics for thyroid cancer? They don't. So whatever is being done in real life, I'll tell you. Few things are very theoretical. If you remember, amazing. But I don't know it will be whether useful for you in real life or in a real exam as well. Fine. Okay, let's go to the next one. So all these things are tumor suppressor genes. Whatever we're seeing here, all of them are tumor suppressor genes. There are few unique things for tumor suppressor genes. Okay, one, it is loss of function mutation only. Every tumor suppressor gene will be loss of function mutation, right? Second and the most important clue, do you know cancer syndromes? You know cancer syndromes, right? Can anyone name any cancer syndrome which comes to your mind? Retinoblastoma is a cancer syndrome, right? All cancer syndromes are tumor suppressor genes only. So you need not memorize which is tumor suppressor. Von Hippel-Lindau syndrome, tumor suppressor. Tuberous sclerosis syndrome, tumor suppressor. Right? Retinoblastoma syndrome, tumor suppressor. FAP syndrome, tumor suppressor. HNPC syndrome, tumor suppressor. BRCA syndrome, tumor suppressor. Everything is tumor suppressor, right? Almost every cancer syndrome are tumor suppressor. So it's easy for me to remember which is tumor suppressor. There are few exceptions. I'll tell you the exceptions very soon, right? Third, you will need to have two mutations, two allele loss for tumor suppressor, right? That's your classical Knudsen's two-hit hypothesis. Only when both the allele is lost, loss of function, I'll have a problem here, right? So there are exceptions for this cancer syndrome. Exceptions become MCQs, remember them. One is RET. Can anyone tell me where is RET gene mutated? RET is a proto-oncogene. I'm sure you remember that RET gene mutation. MEN2A and MEN2B. Definitely worthwhile for an MCQ. Not RET, R-E-T, right? Not RB, R-E-T. Medullary carcinoma thyroid and the pheochromocytoma, multiple endocrine neoplasia, MEN2A and 2B. That's very, very classical for RET. Fine. Okay. One more thing. You have, I'll tell you the disease first. Let's see if it's possible for you to relate and identify the tumor. The disease here is Beckwith-Wiedemann syndrome. Any guesses? Which gene and which tumor? Beckwith-Wiedemann syndrome. Sure, you must have read about that. It's WT2 gene. WT2 gene is a proto-oncogene. It's insulin-like growth factor. You see them in Wilms tumor. Okay. So these are two proto-oncogenes which can cause inherited syndrome. Rest almost everything is a tumor suppressor gene, right? They're not anything. It's a tumor suppressor gene. Only these two proto-oncogenes will have this. Rest everything is undoubtedly a tumor suppressor gene. Fine. Do remember them. Don't forget them. Exceptions are always MCQs. Fine. Let's go back to this. Few other tumor suppressor genes. I want you to remember one or two tumors maximum. Retinoblastoma. Obviously, retinoblastoma is a cancer. Another tumor is osteosarcoma. Osteosarcoma, one of the commonest mutations is RB by default. P53, Lee-Fromney is a syndrome's name, whereas I have an inherited mutation P53. P53 and Lee-Fromney, if you have a combination of breast, if you have a combination of sarcoma, if you have a combination of CNS tumor and leukemia, this combination, I'll think of a Lee-Fromney syndrome. Fine. Leukemias, sarcomas, breast cancer, and your CNS tumors. Combinations are very, very important. Breast ovary, breast prostate, you think of BRCA1, BRCA2, right? Like that. Colonic polyps, you think of an APC and FAP. These combinations are very, very important for us to diagnose, right? CDH1 codes for E-cadherin. It codes for a protein called an E-cadherin. Two tumors. Can anyone tell me what are the tumors where you have CDH1? VHL, classical and renal cell carcinoma, RCC, especially the clear cell type, right? The clear cell RCC, classically you'll have VHL, right? Perfect. You'll have diffuse gastric, amazing, Shubham. and lobular carcinoma of breast. Both of them will classically have the CDH mutation, right? APC is your familial adenomatous polyposis, right? You'll have multiple polyps in the descent and it will be classically involved in colonic adenocarcinomas. STK11 or other name for this is LKB1. STK11 LKB1, what disease? What syndrome? Hemangioblastomas, cerebellar hemangioblastomas is for VHL. There's an additional thing. This is your Peutz-Jeghers syndrome. Okay, Peutz-Jeghers syndrome, Peutz-Jeghers polyp, you have a mutation of STK11 and your LKB1, right? Perfect. SMAT4, it's also a tumor suppressor gene. SMAT4 is mutated in case of an juvenile polyposis syndrome. Okay, as a classical for a tumor suppressor gene. It also a few classical tumor suppressor genes which is common in exams. Perioral melanosis, hyperpigmentation is again a very classical finding seen in case of Peutz-Jeghers syndrome, right? So the perioral pigmentation is definitely classical for your Peutz-Jeghers syndrome, in addition to your colonic polyps and others, fine? So few classical proto-oncogenes, few classical tumor suppressor genes. This has been asked before, can be asked again as well, fine? Okay. Now let's go to few paraneoplastic syndrome, right? Like I said, I'm going to selectively talk about a few topics in case of cancer because it's very, very vast. We cannot complete in the last day. Fine. Cancer paraneoplastic syndromes can be useful for diagnosis and can be useful for follow-up. That's the function of paraneoplastic syndrome, diagnosis and follow-up. There are a few classical paraneoplastic syndrome. The most common paraneoplastic syndrome by default is hypercalcemia. Hypercalcemia is the most common paraneoplastic syndrome and the most common endocrinopathy in paraneoplastic syndrome. Anyone? It is Cushing's. Cushing is the most common endocrinopathy and hypercalcemia is the most common paraneoplastic syndrome by default. Fine. Okay. I'm going to talk about few paraneoplastic syndrome. Let's see if you can answer anything related to that. Any one tumor related to that, that's more than enough, right? Cushing syndrome, whatever comes to your mind. Which cancer will have Cushing's? Cushing's can be seen in case of, classically seen in case of small cell lung carcinoma. See, like I said, there are many cancers. I'm talking about one which might come in the exam. RCC also by default, small cell lung cancer. Small cell lung cancer can also have one more paraneoplastic syndrome, SIADH. That also will be a syndrome of inappropriate AGH secretion and Cushing syndrome, classically seen for small cell carcinoma of lung, right? Hypercalcemia is a finding classically seen in case of your squamous cell carcinoma of lung. Okay, in your squamous cell lung cancer, you can see hypercalcemia. You can also see hypercalcemia in case of your breast cancer also. Okay. In case of, why do we see hypercalcemia here is you have something called an PTH related peptide that will be secreted by the tumor cells called as PTH-RP. That is the person which is reason for the hypercalcemia. And this obviously in small cell carcinoma you will secrete ACTH like peptide and ADH which causes the classical symptoms, right? Polycythemia vera, it's actually related to VHL. So same, clear cell RCC and your cerebellar hemangioblastomas. Okay, so that will secrete more of erythropoietin that results in polycythemia rubra vera. Acanthosis nigricans, GI cancers, uterine cancers, obviously your other thing non-neoplastic, your diabetes and insulin resistance, you think you have hypercalcemia, your acanthosis nigricans, fine. Trossius phenomena is nothing but superficial thrombus. Superficial thrombus is Trossius phenomena. And where do you see superficial thrombosis? Remember mucin secreting tumor. Gastric, colonic, pancreas. If it's a mucin secreting tumor, there's a chance of us having Trossius phenomenon, right? That's classically mostly pancreatic. That's where we discovered Trossius phenomenon, but gastric, colonic, ovarian also will have Trossius phenomenon, right? Red cell aplasia and one more classical finding, that's myasthenia gravis. Any queries? Any tumor, Myasthenia gravis and red cell aplasia, both are immunological mediated symptoms. You see them, both of them are classically seen in thymoma. Perfect. See, whatever we have discussed, all of these have been asked in MCQs. It's like a compilation of all the MCQs. Paraneoplastic syndrome is a very rich source for PYQs. So is your tumor suppressor genes, proto-oncogenes. And the next one, what you're going to read? The tumor markers. Tumor markers also very, very important for an exam point of view, right? You might be asked as a one-liner or given a scenario and asked like, what is the most common marker which is elevated here? or an ovarian tumor with an elevated CA-125, what's the cause? They can definitely ask this. Please do remember all the tumor markers. Again, tumor marker and different from a immunohistochemical marker is tumor marker is a blood test. Immunohistochemical marker is a microscopic slide based test, right? Okay, tumor marker is a blood test. Tumor marker is not primarily diagnostic, it's an adjunct to diagnosis. I cannot diagnose anything with tumor marker, and also it can help in follow-up of the patient, like your paraneoplastic syndrome. Fine. Okay. One by one, human chorionic gonadotrophin. Where do you see them? I can see them in molar pregnancy. Though it's not a cancer, molar pregnancy you can see them. You can see them in choriocarcinoma. See, I'm not writing GCT or non-seminomatous germ cell tumor. I'm just writing specifically choriocarcinoma. That's much more comfortable than calling it non-seminomatous germ cell tumor, right? Choriocarcinoma, trophoblastic tumor, I'll see them. Calcitonin, obviously you see them in medullary carcinoma of thyroid. That's where you see them, right? Catecholamines and its metabolites, be it in metanephrine, where do you see them? Any variants of catecholamines, you see them in pheochromocytoma, right? You're going to see them in pheochromocytoma. You see catecholamines and its metabolites. Metanephrines, everything metabolite, you can see them in pheochromocytoma, right? Ectopic hormones, we'll ignore them for now, right? So alpha fetoprotein, it's AFP. Few conditions, it's must to remember. Alpha fetoprotein definitely will be seen in case of liver cancer, hepatocellular carcinoma, and one more classical tumor, we see them in 𝐒𝐿 tumor. Again, non-seminomatous germ cell tumor. I am specifying them rather than calling it a non-seminomatous germ cell tumor. 𝐒𝐿 tumor is one place. See, 𝐒𝐿, alpha fetoprotein. 𝐒𝐿 secretes fetoprotein, so it will be elevated here. Fine. Again, carcinoembryonic antigen, the CEA, is like your Trossius phenomenon. Wherever you see mucin, you will see them. That's why it can be seen in colon, it can be seen in pancreas, it can be seen in your lung, it can be seen in your ovaries, anywhere, right? It's equivalent to mucin, that's why. Okay, colon can have mucin, pancreas can have mucin, lung can have mucin, gastric can have mucin. So wherever I have mucin secretion, you'll have more of CEA. It's a byproduct of mucin, right? PSA, it's not rocket science, it's prostatic cancer. It's by default. BPH also will have elevated PSA, but prostatic carcinoma is for carcinoma per se, right? CA proteins, CA-125, primarily for epithelial ovarian tumor. Okay, so epithelial tumor of ovary, it will be elevated. When I say epithelial tumor of ovary, mucinous cystadenocarcinoma, serous cystadenocarcinoma. Dysgeminoma also will be elevated, not very high. Fibroma also will be elevated, not very high. But classically in epithelial tumors of ovary, you'll see them very high, right? So this is, I am sure you must have known the mnemonic. This is from an Instagram guy called as Med School Bro. 99 looks like this. Pancreas looks like that. Okay? Kind of a goal, like a pancreatic carcinoma. I am sure you must have known this also. This also he said. 3 looks like a breast, so it's seen in breast cancer. Okay? Again, these are markers which have been repeatedly asked, right? You have to remember them, right? And wherever I have good mnemonics, I use them and I'll give credit. If you guys have amazing mnemonics, let me know, because I'll be very blunt with you. I'm not very creative to make mnemonics. I can make very logical assumptions, but mnemonics, half of the brain is fried, right? So I steal mnemonics from other people. So whenever I find that good, I give them credits as well. If you give me good mnemonic answer, maybe in next class I'll tell you, Dr. Anshed told me this. Fine. Okay. There are a few tumor markers which I want you to remember. Fine. Okay. So tumor markers, paraneoplastic syndrome, tumor suppressor genes, proto-oncogenes. At least one should come in your your FMGE exam, right? Hopefully more than one should come in this 4 tables. Fine. Okay. Let's go to RBC disorders. You guys want to break for 5 minutes? So we're done with general pathology. General pathology is a chunk. RBC and WBC are also important for us, and a little bit of systemic pathology also will cover. 5 minutes break. Okay, I'll start. It's now 11:13. I'll just, I won't shut this down completely. We'll start back again by 1:13, right? We'll start back by 1:20. Is it fine? That's all general. We are done with general. We'll go with hematology only, fine? If 5 minutes is 1:18, right? Okay, we'll start by 1:18. I'll just have a little bit of water, and I'll come back. You also get something, get refreshed and come back. Fine. 118. Right. Start sharp at 118. We'll come back. Fine. I'm just closing the thing. I'm just covering the camera. I'm not doing anything else. Bye bye. அது வேணா பூஸ்ட் இருக்குல்ல தெளிச்சிடும் தின்னுடா டேய். Ready? Okay, yes. Let's start. So you're back on time. Let's complete hematology and systemic pathology also. Fine. Great, 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 guys. Going. So hemat, what I'm going to do is I'm going to show you an image because entire hematology is based on images and few classical pointers, which is with respect to the image, relate to the image, which can come in an exam. That's it. Fine. Okay. Let's go one by one. Can anyone tell me what are these cells? Whatever comes to your mind, what are these cells? How do they look like? First, we'll go to RBC disorder, then we'll go to WBC and disorders. Fine. What are these cells? These are your classical spherocytes. So how do I identify a spherocyte? They are not sickle, they are spherocytes, right? How do I identify a spherocyte? They are smaller, they are darker, and no central pallor. That's how spherocytes are. Right? That's a way to identify spherocytes. Smaller cells, darker cells, no central pillar, diagnostic of a spherocyte, right? Second, whenever you see spherocytes in the spear, the most common cause is AIHA, nothing else. Autoimmune hemolytic anemia, not hereditary spherocytosis. That's the most common cause, right? So next, one more question has been repeatedly asked. So whenever you see spherocytes in blood, what's the next step? So the next step for spherocyte is not to diagnose hereditary spherocytosis, to rule out autoimmune hemolytic anemia. So can anyone tell me what's the next step? In any case of an spherocytic anemia, what will be the next step? Whatever may be the age, in any case of a spherocytic anemia, the next step by default is perfect. We have to do 𝐒𝐿's test, because 𝐒𝐿's test will help out me to rule out the most common cause of an autoimmune hemolytic anemia. Then only I will think of hereditary spherocytosis, right? So most common cause is autoimmune hemolytic anemia. Autoimmune hemolytic anemia is warm subtype and cold subtype, the common ones. Warm is the most common, right? Someone said, one of the students said, I forgot the name, sorry for it. Warm, I'm sure you must have remembered garam, right? So G for garam, warm, right? IgG, and cold is for IgM autoantibodies. Warm, the antibodies against Rh antigen, right? And cold, the antibodies against an minor blood group antigen called an I antigen. Okay, it'll be against I antigen, a minor blood group antigen. That's what autoimmune hemolytic anemia is for. Fine, perfect. Now let's come to HS. H is your hereditary spherocytosis. It's a mutation in spectrin, ankyrin, and multiple other proteins. Can I say it's a structural protein? Can I say it's a dominant inheritance? Yes, it's an autosomal dominant inheritance by default. Since it's the most common mutation is undoubtedly in ankyrin. Every autosomal dominant disorder will present only in later age group. It will be present only in adults, right? So the triad of hereditary spherocytosis is an adult with a splenomegaly, and the classical symptom of HS is gallstones. Pigmented gallstones, adult splenomegaly, I think of HS. That's all, right? And have a screening test for HS. It's not diagnostic test and it's not much used also. The screening test is your osmotic fragility test. It's not diagnostic, no one does it. Perfect, Hemant. Spectrin is the most severe thing, and in it's a severe HS, but most of the time spectrin is a bit rare. It's a recessive disorder. Fine, okay. It's most screening test is osmotic fragility test, and investigation of choice undoubtedly is flow cytometry. Okay, and there's one more important thing which you have to remember in terms of your RBC, MCH, MCHC, and MCV, those indices. One classical finding for any spherocytic anemias, for any spherocyte, the RBC indices, this is common for spherocytes, which means it will be common for autoimmune hemolytic anemia also. I'll have elevated MCHC. There's no other condition where I'll have elevated MCHC, only this condition will have elevated MCHC. Fine, perfect. Small, darker, no paler is spherocytes. The most common is AIHA. The next step is 𝐒𝐿's test. Genetics is different. Acquired is different. Acquired is definitely most common. MCHC will be elevated in any spherocyte. Ankyrin is most common in your spherocytosis. Adult splenomegaly and gallstone. Pigmented gallstone is a triad of spherocytosis. Flow cytometry is definitely the investigational choice. Fine. Okay. Now let's go to the next image. You have to tell me what is the diagnosis and what is the structure here. It's very, very simple. You have to tell it. How does it look? It looks like a bite, right? That's a classical bite cell, right? I'm sure you must have seen bite cell. So this finding here is a classical bite cell. So you have two cells, bite cell and blister cell. Both are diagnostic of apple's bite. Both are diagnostic of G6PD deficiency. Perfect. Glucose 6-phosphate dehydrogenase deficiency. Fine. Again, few classical pointers for me. G6PD is a pathway involved is HMP pathway. It's not involved in the glycolysis pathway, it's in the HMP pathway. So because of the defect in HMP pathway, I'll have reduced NADPH oxidase. Because of this reduced NADPH oxidase, there'll be reduced glutathione recycling. The glutathione peroxidase will not be recycled here properly. Normally I need to recycle, I cannot recycle here. That's the reason. The main pathogenesis in case of G6PD deficiency is an elevated reactive oxygen species induced damage. The reactive oxygen species what is going to cause damage in DHPD deficiency because I am not able to recycle the antioxidant. Very simple. So which means, can I say when I have more fever, I'll have more reactive oxygen species? That's why G6PD is always a trigger-induced deficiency, right? G6PD is an X-linked recessive disorder, like we read previously. So clinical symptoms are very classical here. Men are more commonly involved because of the deficiency, and there should be a trigger-induced hemolysis. This has to be there. G6PD hemolysis will not happen normally, right? I should either have an infection, that's the commonest trigger, or I should have drugs. There are few drugs which has been repeatedly asked. One is primaquine, the anti-malaria drug, dapsone, the anti-leprosy drug. There are two classical things which can cause it. And obviously the useless one which we never forget is fava beans. We don't consume fava beans in India commonly, right? So fava beans, infection or drug in the same order, that's a trigger. Once there's a trigger, the patient will have hemolysis. The most common hemolysis in case of G6PD deficiency is intravascular hemolysis. That's why the patient might have hematuria. Fine. So that's what happens in G6PD deficiency. The way to diagnose, one is obviously in the peripheral smear bite cells, and one more structure, some of you said, Heinz body. Heinz body is a denatured hemoglobin. That's an PYQ for you. Okay, it's denatured hemoglobin, which is seen in case of a new methylene blue stain. Right. All these are classical for G6PD deficiency. Again, I'll repeat: HMP pathway defect, X-linked recessive disorder, reduce NADPH, NADPH oxidase. So I will not have a recycling effect of your glutathione peroxidase. Since I'm not having recycling effect, more reactive oxygen species induced damage. So there's infection, drugs of fava beans, I will cause an intravascular hemolysis. Like Hemant said that it's an intravascular hemolysis predominantly, so spleen is not involved. Spleen is only involved when there's an extravascular hemolysis like in spherocytosis, fine. And obviously I'll look at bite cells. It's a very classical finding. Heinz body is a finding like a dot, which is nothing but a denatured hemoglobin seen on new methylene blue stain. Treatment is supportive treatment. Wait for the infection to settle. Automatically everything will be settled, right? The next image. Spotter. Diagnosis. Come on, this you guys have to say. Sickle, right? Spotter. This classical spotters. What are they? Target cells, right? Perfect. Okay. So I have two images here. We'll read the same way with the image, two classical findings, right? So I have here sickle cells. The other name for sickle cell is drepanocytes. Drepano means boat. It looks like a boat-shaped RBCs. We call it drepanocytes, right? Perfect. When you see thalassemia, always you think of a target cells, always you think of thalassemia. Sickle can also have target, but sickle is the most diagnostic thing here, right? Sickle is autosomal recessive disorder. I'm not going to repeat the mutation. You know that beta globin 6 position, glutamine to valine, right? In 6 position, when glutamic acid becomes valine, it is HBS, sickle. If the 6 position glutamic acid becomes lysine, it is HBC, different hemoglobinopathy. Fine. Sickle, there will be reduced solubility in hemoglobin. So it will not be soluble. That's a problem in sickle. In HBC, it becomes a crystal. C for crystal and sickle, S for reduced solubility. That's a problem in sickle cell anemia. So sickle cell anemia, the primary problem here for me is vaso-occlusion. Vaso-occlusive crisis is how mostly sickle cell anemia presents. So the presentation of almost every sickle cell anemia is pain, unexplained abdomen pain, or a dactylitis, priapism. It's painful condition more than anemia, right? So the most common presenting feature is dactylitis, the vaso-occlusive crisis. Dactylitis is the finger or the fingertips being pain, right? Your priapism, which is an painful engorgement of penis, is also a symptom mostly presenting in men. 40 to 50% of men present with your priapism only, right? And also I can have an very unexplained abdomen pain, which can result in splenectomy, and autosplenectomy, which can cause due to multiple splenic infarcts, which can also be to your vaso-occlusive crisis only. Fine. Okay. Then obviously I'm going to diagnose. Microscopy, I will see the sickle cells. That's diagnostic. If I'm not able to see a sickle cell, I go for a screening test called as a sickling test. So what I do in sickling test is we add something called as sodium metabisulfate. So this sodium metabisulfate is a person which is going to just remove the oxygen, because when you remove oxygen, normal cell also becomes a sickle, right? So it becomes a sickle like this because it removes oxygen. It's a screening test, that's all. Investigation of choice for sickle, I have two things. Obviously the better one is HPLC, or I can have an hemoglobin electrophoresis. Remember, sickle cell anemia is the first disease to be cured by CRISPR. CRISPR is a new genetic treatment methodology, like a gene transplant or something. I have CRISPR. This is the first test which disease has been cured by CRISPR. Fine. Okay. Perfect. So all these are important points for your sickle cell anemia, right? Just before the exam, quickly go through this one sheet, one most important thing. See, whenever you go through this, automatically, like you guys said, the fish mouth vertebra, crooked vertebra, automatically will come to your mind, right? Just in one place, we have all the collected thing. Please go through the day before the exam, right? Now let's go to TAL. So thalassemia. So the most common is obviously beta thalassemia. Alpha thalassemia is a bit rare by default, right? So when I take beta thalassemia, please remember, in case of a beta thalassemia, I'll have reduced beta chains or the beta globin chains and excess of alpha chains. And this excess alpha chain is the problem and not the reduced beta chain. This excess alpha is the reason for the symptoms. Because of the excess alpha, it goes and destroys everything in the membrane, destroys the blast, destroys the RBC, destroys everything here. Fine. Okay. HbA2. See, HbA2 is something which I'm going to look for beta thalassemia only. I'm not going to look for your sickle cell anemia, because in sickle cell anemia I'll have HbS. That's more diagnostic than HbA2 for me, primarily speaking. Fine. Okay. So the most of the symptoms are due to excess alpha and not to reduced beta. Fine. Sickle cell anemia trait is there, and also have major. Trait is similar to IDA. So the way for me to differentiate an IDA versus a trait, one, I can use the test called as a Nestorf test. Nestorf is a screening test. Again, Nestorf helps me to screen patients of sickle cell anemia, especially a trait. And the way to differentiate it from an IDA, we have two parameters. I want you guys to tell about the two parameters. What's the first parameter? We have something called an RDW. RDW in case of a thalassemia will be normal or narrow, right? Second is perfect, Menster's index. Okay, so Menster's index, TAL is an hemolytic anemia, so the RBC level will go up. RBC number is in denominator of Menster's, so the numerator will be less than 13. Fine. So if the Menster's index is less than 13, I think of that, right? That's the expansion of Nestorf, whatever Hemant said. Fine. Nestorf is a screening test for TAL trait, and to differentiate from an iron deficiency anemia, this is a symbol which I wrote for differentiation. Okay. RDW will be normal here and will be less than 13 Menster's index. I lean towards thalassemia. RDW, if it's elevated or more than 13 Menster's index, we think of your iron deficiency anemia. Fine. Perfect. Now, TAL major. TAL major is mostly diagnosed clinically. Obviously, I need a confirmation on HPLC or your hemoglobin electrophoresis. Any severe hemolytic anemia, which is classically transfusion dependent, it is undoubtedly transfusion dependent. And it happens more than 6 months of age. All these are classical for thalassemia major. That's all. Fine. Transfusion dependent, extremely severe. Maybe there'll be symptoms of secondary hemosiderosis or hemochromatosis. Because of lipidal blood transfusion, I can have symptoms of that. And someone said about your crooked appearance. Crooked appearance is more specific for thalassemia major compared to your sickle cell anemia. Sickle can also have, but I'm not saying it's more in favor of thalassemia than your sickle cell anemia. Okay, that's an amazing thing, Ranjith. I will use that. Thalassemia, less for your Menster's index, right? Okay, perfect. Okay, that's for major, fine. So microscopy, what I'll have is, you will have definitely your microcytic hypochromic anemia. Classical appearance of target cells will be there. Okay, that's classical. In case of a major, in case of a TAL major, I have one more interesting finding called an NRBC. Nucleated RBC, NRBC stands for nucleated RBC, and your you'll see only in TAL major. In TAL minor, I won't see them, right? Perfect. Investigation of choice, like before, I'm going to go for HPLC than for your hemoglobin electrophoresis. See, this is an investigation choice for beta thalassemia. I am not talking about alpha thalassemia now, but if it's alpha thalassemia, the best test for me than HPLC is globin gene study. This came once in a NEET PG exam. Okay, because alpha thalassemia only one variant can be easily picked up on HPLC, but there are 4 variants of alpha thalassemia. So if I'm suspecting alpha thalassemia, the best test is entire assay the globin gene genetic study. That's the best test for alpha thal. But for beta thal, whatever it is, beta thal major minor, I can easily pick up on HPLC by default. Fine. Okay, that's with respect to thalassemia. Most important findings, everything which has been asked has been here. Now, right? Let's go to a few other things. Okay, then we divide your anemia based on the micro and macro and normal, right? Microcytic, I'm sure you know Sitama. I'm not going to go to Sitama. I want you to maybe change this mnemonic into ISTA. I'll tell you the reason for it. Actually, ISTA should be more than enough, but fine. Let it make as ISTA, because the first thing I want you to remember is iron deficiency anemia. In Sitama, the first is sideroblastic. Sideroblastic is, you will never see sideroblastic in your life. Then why should I study that? First is obviously iron deficiency anemia. That's a first. The second I want you to remember is thalassemia, because these are the commonest differential diagnosis of microcytic anemia, right? Microcytic is anything less than 80 femtoliters, I call it microcytic. Anything more than 100 femtoliters, I call it macrocytic. Anything in between is normocytic, right? And obviously I can also have sideroblastic anemia. Okay, sideroblastic anemia is classically seen in lead poisoning or in case of pyridoxine deficiencies and others. Fine. Okay, normocytic, the first thing I want to remember is anemia due to a chronic disease and also anemia in renal failure. In renal failure, you'll have anemia because there's no erythropoietin, no one to stimulate the bone marrow. You'll have that by default, right? Okay. Macrocytic, one subtype is megaloblastic, which is your B12 or your folate deficiency. That's your megaloblastic anemia. The other guy by default is your alcohol can cause macrocytic anemia. Your hypothyroidism can cause macrocytic anemia, which is not megaloblastic, but still macrocytic anemia, right? So you have difference for your microcytic, normocytic, and macrocytic anemias. Fine. A very simple thing to differentiate them, right? So a few more information before we go into the iron deficiency. Okay. So how do I call it an RBC microcytic? In a smear, you call an RBC microcytic if it's smaller than the small lymphocyte. If it's smaller than nucleus of small lymphocyte, we call it an microcytic RBC. Normally, it should be equal to the size of it, right? Pincer-shaped cell is a unique finding seen in case of one type of hemolytic anemia. We don't want to learn much about that as of now. Pencil-shaped cell is seen in iron deficiency anemia. Pincer-shaped RBC will be like this, okay, which is seen in band 3 defect of your hereditary spherocytosis. Fine, okay. I'll call something as an hypochromic anemia. Hypochromic RBC if the central pallor is more than 1/3 of the RBC. I call it an hypochromic RBC, right? That's how we know as a microcytic and hypochromic. By default, the most common cause of microcytic anemia is iron deficiency anemia. There's no doubt in that, fine. So now, iron deficiency anemia, the way to diagnose IDA is iron studies. Iron studies is the only one thing which is important to diagnose IDA. I want you to remember these 4 iron studies and just one correlation. That's more easy for me to memorize which is elevated, which is reduced. Just let's go with the correlation. Serum iron, it's there in my body. Transferrin is the person who will take the serum iron and go surrounding. So let's assume the room you are staying has 4 chairs. All the 4 chairs are iron binding sites of transferrin. So iron can bind with 4 transferrin. Let's say only 1 iron has come. Can I say transferrin is not saturated? Obviously. 5 iron has come. Only 4 chairs. Transferrin is oversaturated. In other words, serum iron and transferrin saturation, these both, the first one, iron and transferrin saturation is directly proportional, which means if one gets elevated, other will elevate by default. More iron, more saturation, less iron, less saturation, right? TIBC, I'm going to, for our ease and convenience, I'm going to convert them into affinity of binding iron, right? Serum ferritin is what? Available iron or stored iron? Serum ferritin is storage form of iron, right? Now you have not had your lunch. You'll be definitely hungry. I give you whatever you will eat because nothing in the stores. Affinity for the food is very, very high. If you have had your lunch, even if I give you good food, you won't eat. In other words, whenever ferritin storage form is more, affinity will be less. Whenever ferritin storage form is less, affinity will be more, right? In other words, ferritin is and your TIBCR Perfect. Like Anshat said, inversely proportional. They are inverse relation. These both never forget. Iron studies is very easy. This is concept. No need to memorize up, down, nothing required, right? Now let's go to IDA. There are few things you will definitely know. What will happen to iron in IDA? Everyone. Iron in IDA, more or less. By default, iron in IDA is iron is less. That's what iron deficiency, right? By default, what will happen to TSAT? Will be less. What will happen to ferritin in IDA? Ferritin is the most sensitive test for IDA, right? It's the most sensitive test, the first one to become low. What will happen to TABC? Obviously will be elevated because TABC and ferritin is inversely proportional. You know by default few parameters, serum iron and ferritin. I can automatically write the other two parameters, no need to memorize, right? Anemia of chronic disease. I will start with ferritin. Why I'm starting with ferritin is chronic inflammation, ferritin is an acute phase reactant. In COVID, ferritin was elevated, right? So any chronic inflammation, ferritin becomes more. What happens to TABC? Put a start here, you have to start with this. Because right here also, if you want, ferritin is an acute phase reactant. Obviously, an acute phase reactant will be elevated in patient with inflammation, right? If it's elevated, by default, TABC will be low. If storage form of ferritin is elevated, this will be less. This also will be less. Clear? That's all. Okay, fine. Okay, so ferritin will be elevated, rest everything will be reduced, like what Shubham said, right? That's how you I want you to remember iron deficiency anemia. If you remember by mnemonic, it's okay, but you remember by logic, not just FMG. Till you practice iron deficiency anemia in your clinic, 70 years old, you'll remember this by default, right? That's the goal. FMG is a passing cloud. You guys, everyone, I will meet you by Jan 13th or maybe after your exam, after your results, you'll definitely clear your exam. Fine. Okay. Now, few more important questions with respect to IDA. Okay. IDA has been quite an important thing which comes repeatedly in your exam. So we already know about Menster's index and RDW. RDW in IDA will be wider and Menster's index in IDA will be increased, right? It'll be more than 13. 13 is a magic number. It'll be more than 13. Fine. Okay. Ferritin is a positive acute phase reactant, Arvind. That's why it's been elevated. Fine. Microscopy. In addition to my microcytic hypochromic anemia, a classical finding of pencil-shaped RBC is very, very, very important for diagnostic, right? It'll be an elongated RBC. There are two types of elongated RBC and hypochromatic. It's bigger and it has less paler, and hypochromatic. It's pencil-shaped RBC. Okay, that's diagnostic of an IDA. If it's elongated and if it's very dark, it's also elongated, but it's hyperchromatic, right? Very, very dark. So we call it an elliptocyte. Like in spherocytosis, I have something called an elliptocytosis. It's an elliptocyte. That's how we differentiate a pencil-shaped RBC versus an elliptocyte, right? Teardrop cells, I don't see it here. We'll see somewhere soon, fine? Okay. One more classical clinical information. I want you to remember this presentation. This has come quite frequently in NEET PG as well as in FMG. An elderly male, okay, with iron deficiency anemia. The next test, what will you do? Because a 70-year-old male will not have iron deficiency anemia due to worm infestation or reduced nutrition. Most likely, I want you to think of a next test called an occult stool blood. Okay, occult blood loss in the stool. To suspect colonic carcinoma. You have to suspect colonic carcinoma. So look for the occult blood loss in the stool. And if it is positive, then do a colonoscopy. This is very, very important. This has been a routine thing. This is what we do in real life also. That same scenario has come in the exam as well. Don't forget them, right? So these are few things. I'm sure rest of the iron metabolism you definitely know. What's his absorption site? Just quickly. Iron gets absorbed in the duodenum via the divalent metal ion transporter. It gets stored in the duodenal epithelial cells in the form of ferritin. It goes outside with the help of ferroportin. It will be bound to transferrin and goes to all the important place where it goes to get absorption, right? So to get used, fine. One more important thing regarding iron, I'm just going to write here. The master regulator of iron metabolism, this has been asked before, is hepcidin. Hepcidin is the master regulator of iron metabolism. Hepcidin determines what has to be done, which should be absorbed, which should be not be absorbed, when ferroportin should be keeping quiet, when ferroportin should be active. Hepcidin determines everything regarding that. Fine. Okay. Let's go to few more images. There's a classical image. Diagnosis. Diagnosis. You know that. That's hypersegmented neutrophil, right? So it's a hypersegmented neutrophil. Hypersegmented neutrophil is diagnostic of your megaloblastic anemia. No, it's diagnostic of megaloblastic anemia. Paramesamam, I'm not talking about the rouleau formation here. I'm talking about the WBC here, right? Megaloblastic anemia. It's completely fine, Paramesamam. Fine. Okay. So when you have more than 5% of them having more than 5 lobes, more than 5% of WBC having 5 lobes, I can call it hypersegmented neutrophils, or even a single WBC with 6 lobes, I can call it hypersegmented neutrophil. That's the criteria for calling it hypersegmented neutrophil. Whenever I see hypersegmented neutrophil, I'm going to think of a megaloblastic anemia. I'm not going to think just of B12 deficiency. It's megaloblastic. Can be B12 or folate. Fine. Okay. So to call it a B12 or folate, I need few information clinically or few information based on the history or my blood values. That's all, right? So I'll tell you, for a B12 deficiency, there are few important keywords. A vegan diet, not vegetarian, a vegan diet. Think of B12. Next, I want you to use all the absorptive defects, the autoimmune gastritis, or a surgical resection of ileum, right? The pernicious anemia, right? Or a resection of ileum. I can think of a B12 deficiency because it's getting absorbed in the ileum and all those things, right? And like Paramasan said, neurological deficit. If there's any neurological symptoms, I'm going to think of a B12 deficiency. Folate will not have the neurological symptoms. That's very, very important, right? So for folate deficiency, I'm going to think of lack of fruits and vegetables. Lack of fruits in the diet and lack of green vegetables in the diet. Because folate is present in milk, folate is present in meat, folate is present in many things. But unfortunately, folate will be destroyed when we cook. So when you eat fruit without cooking, good amount of folate. When you eat vegetables like greens, salad, it will have good amount of folate. Others will not have good amount of folate. Very classical thing. Methotrexate, you are right theoretically, but I would say methotrexate, I'll definitely give your folinic acid as a supplementation, right? But methotrexate will definitely reduce it, fine? So this pregnancy is a one important thing, and we'll write theoretically methotrexate involvement also will have this, fine? And by default, like I said, here there'll be no neurological symptoms. Okay, there'll be no neurological symptoms here. That's how I classically differentiate your B12 and folate deficiency. And obviously you need the blood levels of B12 and folate before treatment. That will give you exactly B12 or folate, right? But theoretically we'll differentiate by this. Hyperpigmentation of knuckles, common for both. Red beefy tongue, common for both. Intestinal problems, common for both. Increased risk of bleeding, common for both. All these are common for both, right? And do remember, megaloblastic anemia will have pancytopenia. That's very, very important. It's not only anemia, RBC will be reduced, WBC will be reduced, platelet also will be reduced, because the problem here is the nucleus. That's the problem. Blast is becoming a problem, so everything will be reduced by default, fine? Okay, now let's have a look at this. Okay, when you look at this, you look at these are cells where I'm having very, very irregular spikes. Irregular spikes on the surface of the RBC, I think of an see, fish tapeworm, you said. Fish tapeworm definitely causes B12 deficiency. Ankylostoma duodenale causes iron deficiency because of the blood loss. Okay. So this is an acanthocyte or a spur cell. When I have irregular spikes, I call it an acanthocyte or a spur cell. Acanthocytes are seen in two conditions. The first important thing which I want you to remember for real life is your liver failure. And I'm sure you know what to remember for your MCQ exam. What's the MCQ exam? We have a big disease, which I'm sure you will never see in your life, A-beta lipoproteinemia. Okay, that's a classical finding for acanthocyte. It should be irregular spikes on the surface of RBC, looking like a spur. We call it an acanthocyte, right? Sometimes, if these spikes are regular, like in this image, can I say these spikes are regular here? They are regular here, right? We call them an echinocyte. Echinocyte or an burst-shaped RBCs. It's burst cells or an echinocyte. Echinocyte is classically seen in CKD, chronic kidney disease, uremia. Fine, there's a classical finding in chronic kidney disease and uremia, right? What is this finding? Shubham said this long back. It's classical finding called teardrop cells. It looks like a teardrop. Teardrop cells are also called as dacro. I'm sure you must have read in your ENT and ophthalmology, right? Dacrocystis rhinitis. Dacro. Like a teardrop, dacrocytes. Dacrocytes is a classical finding of myelofibrosis. It's a fibrotic bone marrow. So the RBC has to squeeze and come outside of that. That's a myelofibrosis, right? So dacrocytes, echinocytes, acanthocytes, classical findings. And also we know the drepanocytes for your sickle shaped RBC. I just forgot this. I didn't write that before. Target cells, the other name are codocytes. Okay, fine. Okay, that's about few things about RBC disorder. The normal stain useful for RBC is Leishman stain. And to demonstrate reticulocytes, we have a different stain. There's been asked before in exam. What stain useful for reticulocytes? It's a variant seen in it's a poikilocyte, commonly seen in iron deficiency anemia and thalassemia. Permissible. Fine. We have a stain called an supravital stain. The common supravital stain which is used for demonstrating reticulocyte is new methylene blue. Okay, it's a new methylene blue stain. It's the commonest thing which is done for your identifying reticulocytes. Fine, perfect. Those are few things with respect to RBC disorders, right? Quickly, let's swim through few leukemias and lymphomas. See, leukemias and lymphomas, honestly speaking, clinical information might be a little bit confusing. Most of them will have lymphadenopathy or bleeding manifestation or your fever or non-specific symptoms, right? But there are few clues which I want you to take from the clinical examination for leukemia, lymphoma, microscopy, and one classical CD marker and one classical genetics. Any question which comes in lymphoma will have like a 4, 5, 6, 7 CD markers. Don't memorize all of them. Everything will have one classical. Cyclin D1, mantle cell lymphoma. That's what I want you to remember. One classical CD marker. Other things will definitely be a part of it. We look at the classical marker. We look at one classical finding and one classical image for almost every leukemia and lymphoma here. Fine. Okay. Shubham started that. Right. What is the structure? That's OR rod, right? So OR rod is nothing but an acidophilic granules. It's primary acidophilic granules of the WBC. That's all. The normal granules of WBC here are seen in the form of a rod, and OR rods are classical features of myeloid lineage. It's a diagnostic sign for myeloid lineage. Okay, it's diagnostic of an AML by default. Fine. So we have multiple subtypes of AML. AML has a very non-specific finding. AML does not have classical age group also. It can be seen in younger, it can be seen in elderly person as well. Fine. So let's say AML M3. There's a unique type of AML called as an APML or an acute promyelocytic leukemia. What are the findings which is unique to acute promyelocytic leukemia? This definitely can come in an exam. One, the translocation 1517. It's a very unique translocation. Second, they can present with DIC. It's deadly. They can present with DIC. If I can treat it before DIC sets in, amazing prognosis, right? Third, microscopy. I have few name cells called as faggot cells. Faggot cells are the OR rods in bundles, and you have a buttock-shaped nuclei. Okay, a buttock-shaped nuclei and faggot cells are classical for APML. Fourth, treatment. Treatment is ATRA. I don't give chemotherapy here. We give all trans retinoic acid here, right? All of them are unique here. They are definitely positive for MPO that I'm not discussing about it, but all these are unique here, right? So AML M4 and M5. See, M4 as well as M5 is monocytic and myelomonocytic. Whenever monocyte comes into the picture, can I say macrophage is nothing but tissue monocytes? Is the statement right? Not right. It is. So can I say this leukemia can go into tissues? Chloroma. That's all, right? So a leukemia can go into tissues by default because of monocytic leukemia, right? So classical symptom of gum hypertrophy. You might have gum hypertrophy. Again, going into the tissue, you might have leukemia cutis, can present with skin lesion. Again, going into tissues. It's not only in the blood or the bone marrow, going into tissue, right? This is a classical symptom for a chloroma. Okay. Chloroma is extramedullary blast is called as a chloroma. Outside the medulla, outside the bone marrow, right? And marker for your M4, M5 or monocytic lineages, NSC and CD14. Just two markers. CD64 also, if you want, you can remember. The three markers, at least remember NSC, right? Neuron-specific kinolase, so non-specific esterase. Let's remember that alone. It's classical for a monocytic marker, fine? Okay. Now, let's look a little bit about AML M7 also. Because AML M7 also is a little bit unique. M7 is megakaryocytic. There's an increase in risk with Down syndrome. It's classically seen in children. That's a classical finding as well, right? And it also can have myelofibrosis, right? There's a few unique findings with respect to leukemias, which I want you to remember. For all this, the investigation of choice is flow cytometry by default. Every leukemia, every subtype, except for CML, it's flow cytometry by default, fine? Okay, let's go to ALL. So this is an acute lymphoid leukemia's blast. Acute lymphoid leukemia will have lymphoid blast, right? Obviously, it's not having your or rods, no granules, right? So if I have a blast, so how do I identify it's a lymphoblast? So lymphoblast will have high NC ratio. That's for everything, right? More nuclear cytoplasmic ratio, and there'll be no granules or no or rods. There are no granules, no or rods. I think of an acute lymphoid leukemia. It's as simple as that. If I have or rods, myeloid, no or rods, lymphoid. That is not alone enough for me. There are few clues here for an acute lymphoid leukemia. Remember this, a child with lymphadenopathy. This is a very, very, very important clue. Because no lymphoma happens in children. The only one lymphoma which happens in children is Burkitt's lymphoma. They rarely present with lymphadenopathy, they present with jaw swelling, right? So child with lymphadenopathy, think of ALL. That's by default, fine? Apart from this, I have few classical markers here. So markers for lymphoblast, like someone said, PAS, dot-like positivity or block-like positivity. Very classical. Dot-like or block-like is diagnostic of ALL. In addition to that, TDT is diagnostic of an immature lymphoid. Then I can divide, see, TDT is for an immature lymphoid marker. Obviously, lymphoblast and immature lymphoid blast, right? Okay, next I have two different types. If it's CD3 positive, I think of a BALL. If it's CD3 positive, I think of a TALL. 3 is a T cell marker. CD19-20 positive, I think of an BALL. Which is the most common? BALL by default is the most common. TALL will have mediastinal involvement, thymus, right? Can have more mediastinal involvement, more testicular involvement, and they have poor prognosis. Those are all things which I want you to remember in TALL, right? BALL is decent prognosis, the most common type of AML. It will be like more than 85% of the ALLs are BALL only. TAL is bit rare, and BAL has a good prognosis also, right? Okay, this is for leukemias and lymphomas. Just one more add-on point. Every leukemia, right? Every acute leukemia by default will be CD34 positive. Because CD34 is a marker of blast. By default, be CD34 positive. The marker for myeloid is MPO. As a classical marker for myeloid, B cell, you have a CD19-20, T cell, you have CD3, marker for myeloid is MPO. Exceptions are always MCQ. A leukemia which is CD34 negative is your APML. Acute promyelocytic leukemia CD34 negative is a very, very classical theme for an APML. Rest every acute leukemia CD34 positive. Only leukemia CD34 negative is APML. Fine. Okay. One page for most important things for leukemias, acute myeloid and acute lymphoid. Right. Now let's go to the next one. Okay. Okay. What comes to your mind looking at this image? Tell me whatever comes to your mind. You may be right, you may be wrong, doesn't matter. Convent girl, college girl, convent girl appearance, right? So can I say here there's leukocytosis and lots of, I won't call it starry scare, right, Harsh? Starry scare appearance is a finding in biopsy. This is a finding in a peripheral smear, right? So this patient had, let's assume this is an elderly patient, a massively enlarged spleen. Okay, so You both of you said convent girl, right? So I think you didn't understand why did they name them convent or college, right? I'll tell you why. A massively enlarged spleen and leukocytosis. This patient, I'm going to think of a CML by default, right? So CML in my peripheral smear, I'm reading PS for peripheral smear, has the useless name of college girl appearance, right? It's named as college girl for the reason college, I don't have uniforms. I have multiple colors, right? Like that, it's not one cell. I have basophil, I have eosinophils, I have myelocyte, I have metamyelocyte, I have band forms. Multiple different colors, college girl. Convent girl is uniform. It's only one lymphocyte. CLL has only lymphocyte like this. It's only lymphocyte. I don't have any other cells. Only lymphocyte because chronic lymphoid leukemia, right? Myeloid leukemia is called as college girl or in garden party. Garden party also same logic. I have multiple things there. In other words, I can simply left shift. Left shift in the leukocytes plus the most important finding is basophilia. That's very, very important for me to call it an chronic myeloid leukemia. That's the reason we call it college girl or a garden party appearance. Left shift plus basophilia, diagnostic of a CML, and investigation of choice by default is either FISH or I can use a qPCR. Okay, I can use a PCR or a FISH. Your flow cytometry will not be of help here, right? This is classical and basophilia is very, very classical to remember then. And if at all it comes, there's a score called as a lab score. Lab score in CML will be very, 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 very low or 0. In patients with something called as a leukemioid reaction, leukemia-like reaction, we call it a leukemioid reaction, fine? So in leukemioid reaction, leukemia-like reaction, which is seen in patients with sepsis, very high blood count, also can have left shift. In here, lab score will be elevated. It's again a theoretical difference. No doctor will never confuse sepsis with a leukemia. They will not confuse. Fever will be there. Leukemia will not present the fever, right? But theoretically speaking, lab score will be very high here, and lab score will be very low in case of a CML, right? One more thing, I gave an history of elderly person with a massively enlarged spleen. Okay. Massive splenomegaly in elderly person, fine. So we always thought of CML. There's one more differential diagnosis. If the patient had pancytopenia, massively enlarged spleen, elderly person, pancytopenia, I want to think of hairy cell leukemia. Please don't forget this. Massively enlarged spleen, elderly person, leukocytosis, CLL, pancytopenia, hairy cell leukemia, right? Hairy cell leukemia, the markers, the hairy cells are positive for a marker called as TRAP positive, classical for hairy cell leukemia. Fine, it's an amazing marker. It can also be annexin positive. Okay, these are two markers which are classically positive in case of hairy cell leukemia. Fine. CD1A, I will go for Langerhans cell histiocytosis parameter. It's not here. Fine. CD1A for LCH. Since you said it's for Langerhans cell histiocytosis, I have the CD1A marker. I go for that. Annexin and TRAP are classical markers for your hairy cell leukemia. There's one more called DPP4. That's fine. But we remember this. That's more than enough for us. Fine. Again, one differentiating point. Leukocytosis, CML, pancytopenia goes with this. Fine. Okay, that's for leukemias, acute myeloid, acute lymphoid, and now let's go to chronic lymphoid, right? See, annexin VA1, both are good enough, right? But A1 is more concentrated. Doesn't matter. I don't think so. They will ask the different types of annexin. Annexin per se is a very good marker radical thinking, right? Okay, let's go to lymphomas. So lymphomas, the first thing here, what is this cell? I'm sure you'll answer that. What cell is that? CLL, right? Right? So we actually call it as CLL bar SLL. That's why I put them in lymphomas, chronic lymphoid leukemia, small lymphoid lymphomas, right? So lymphomas, there are multiple PYQs which is common CLL, starting from origin. Origin of CLL, okay, is naive B cells. The origin is from naive B cell, right? Classical symptom of CLL is an elderly patient with lymphadenopathy. As a classical symptom, may also have autoimmune hemolytic anemia, classical symptom of CLL, right? Naive B cell, classical symptom, right? Microscopy, you guys want the convent school appearance? We'll keep the convent school appearance, but extremely high lymphocytes, mature appearing lymphocytes, plus smut cell. And yes, since the lymphocytes are all uniform, we call them a convent girl appearance, right? And smut cells are also classical here, fine? Okay, perfect. By default, since it's a leukemia, my investigation choice is flow cytometry. In flow cytometry, I obviously look for CD markers. Every lymphoma leukemia, CD markers is the ultimate thing. That's all, right? So I need CD markers here. Like I said, I will tell you one CD marker. Never forget this. If it's there, great for us. Not there, let's ignore it, right? Can anyone tell me what's a CD marker which comes to your mind when you think of CLL? CLL, naive B cell, CLL is positive for two markers. Actually, CD5 positive, CD23 positive. Okay, 5 positive, 23 positive is classical marker for CLL. If you remember, actually 523 should be more than enough. 5 itself is more than enough because 5 is the one which actually is involved in the pathogenesis. Fine. So that marker alone should be more than enough for us to remember 5. 5 positive and 23 positive, I think of a CLL. Fine. Okay. Now, since we are in this place, I'll quickly discuss about mantle cell lymphomas also. So mantle cell lymphoma, the origin is in mantle zone or pre-germinal center origin. GC is for germinal center, right? Mantle cell lymphoma, the presentation, they might present extranodal, they might have polyps in the intestine. So we call it a lymphomatoid polyposis. They look like intestinal polyps, but they are lymphomas, right? Mantle cell lymphoma, microscopy, they'll have an enlarged mantle zone. That's a finding to start with. Okay. Mantle cell lymphoma diagnosis based on markers. Investigation of choice is by default biopsy and CD markers. Fine. I'm not going to tell 23 negative. Shubham is right in calling it 23 negative, but our goal is only one, cyclin D1. Cyclin D1 is positive. Fine. If cyclin D1 is positive, I'll think of a mantle cell lymphoma, right? And the genetics is important. Remember, mantle is like this. M-A-N-T. It's like this, right? Remember, it's like 11. Okay, instead of TL, it looks like 11. So it's 11, 14 chromosome. 14 is always consistent. 11, it looks like this T and L. Maybe like this, mantle. Fine. 11th chromosome is where we have cyclin D1. There's a classical finding for mantle cell lymphoma. Fine. Okay. Now tell me, what is this? I'm sure you guys will know the answer. Classical finding. Someone says starry sky. This is the starry sky, right? Superb starry sky. Perfect. That's a Burkitt's lymphoma. Fine. So we'll write Burkitt's from now onwards. We'll talk about Burkitt's as Burkitt. The reason to call it Burkitt is translocation between 8-14. 8th chromosome is the most classical, right? It can be translocated between 2-8, 8-14 or 8-22. 8 is the most classical one, and like Paramasan said, MYC is there in 8th chromosome, right? So chromosome 8 has CMYC, which is the classical mutation and the classical marker of Burkitt's lymphoma, right? Burkitt's is the only lymphoma seen in children. There's no other lymphoma which an undergraduate should know which is seen in children. Children, options are lymphoma, it has to be Burkitt's lymphoma. Child with a jaw swelling, classical African Burkitt, right? Burkitt's lymphoma has most of EBV positivity. They are mostly EBV positive. The endemic Burkitt is most common location is jaw. The sporadic Burkitt, it can happen anywhere. It can happen in the intestine also. Fine. Microscopy, as you see, it's a classical starry sky appearance. Burkitt's marker, I want you to remember two markers with Burkitt's for the CD markers. One is CMYC. By default, it will be positive. It's a marker called as Ki67. It is 100%. That's classical for Burkitt's, right? Burkitt's will have 100% Ki67, which is very, very, very highly proliferating tumor. That's one of the things you heard true. Interception should be the presenting feature because of intestinal Burkitt's. Fine. Okay. That's about Burkitt's lymphoma, Burkitt's lymphoma, right? So we know acute lymphoid, acute myeloid, chronic lymphoid, Burkitt's, mantle cell, right? Quite a few lymphomas for us, right? We'll just complete this guy as well. How does it look? How does it look? Any guesses? The problem with biopsy is if I don't have a option or something suggested of that, it's a bit difficult. It's popcorn, right? Amazing. Popcorn shaped appearance, right? Clover leaf is in a bloods, in a peripheral smear, not in a biopsy permission. Fine. Perfect. So popcorn, fine. I'll show you. I think I don't have clover leaf. Clover leaf is in a peripheral smear. I'll talk about that also. ATV also soon. Fine. Okay. Okay. Let's go with this. Fine. So let's go to Hodgkin's. Hodgkin's origin is again germinal center only. Hodgkin's can happen in a middle age group like 15 to 30 or 40 years. It's not something which happens in elderly. We divide Hodgkin's into two major groups, We call them a classical Hodgkin's lymphoma. We call them NLPHL. Under classical Hodgkin's, I am sure you know there are multiple variants like nodular sclerosis, mixed cellularity, lymphocyte rich and lymphocyte depleted. We'll see one classical finding for everything. Fine. I'm not going to repeat classical Hodgkin's as classical RSLs. The owl's eye nuclei, the pink nucleoli, that's classically seen in every Hodgkin's lymphoma. Few other things we'll see now. Fine. So nodular sclerosis Hodgkin's lymphoma. Okay, it's the most common variant in developed nations. In India also it's more common, but I don't know. There are few textbooks which say India mixed cellularity is more common, but as per the routine practice, what we see, nodular sclerosis is definitely more common than mixed cellularity, right? This is EBV negative. I have a classical type of RSLs here, cousin, lacunar variant of RSLs. That's what is classically seen in case of nodular sclerosis, in addition to classical RSLs. Fine. Okay. So mixed cellularity, I'll have to contemplate on it because most of the data in India is never updated. That's a problem, that we are still stuck that mixed cellularity is the most common variant in India. Fine. This is EBV positive, seen in developing countries. Tata Memorial is the biggest hospital in our country which deals with lots and lots of cancers. Tata Memorial's data and AIIMS, Delhi's and JIBMA and PJ data says that nodular sclerosis is more common. We'll leave it for now. Let's see later on. Fine. Here I have a classical variant of classical RSL called as a mononuclear variant of RSL, which also was called as in Hodgkin cells previously. Fine. Okay. Lymphocyte rich, nothing but increased amounts of background lymphocytes. That's classical here. That's why we call it lymphocyte rich. Lymphocyte depleted is the rarest variant of Hodgkin's. This is both HIV positive and EBV positive, which is unique, which has something called a mummified variant of RSL or a reticular variant of RSL or a very pleomorphic RSL, and is the worst prognosis of all. Okay, so all these classical Hodgkin's lymphoma, all of them, IHC wise, it's positive for CD15, CD30 and PAX5 is weak. It should be weak. If it's strong, it is wrong. Fine. PAX5 weak, CD15, CD30 positivity, everything is there. Fine. 13 and 15 positivity and PAX5 being weak is classical Hodgkin's lymphoma, right? So NLPHL, it's seen in young individual, more common in men. It rarely spreads, an excellent prognosis. And microscopy, like we saw, popcorn cell. The original name of popcorn cell is LNH cell, lymphohistiocytic cell. That's popcorn cell. And the IHC is very unique here. Here the IHC, they are CD20 positive, 45 positive, and PAX5 is strong. If it's strong, I have to think of NLPHL. If it's weak, I have to think of your classical RSLs. Fine. PAX5 has to be strong in case of an NLPHL. Perfect. That's for your Hodgkin's lymphoma, right? So we know quite a bit about Hodgkin's, few classical non-Hodgkin's lymphoma and few classical leukemias, right? This will not give you 100%. Obviously, I cannot complete 100% in 4 hours. If I complete, I'll become amazing, right? But this will give you almost the common things which have been repeated in the past few years with respect to hematology, fine? Okay, because that's the only thing what you can do a day before the exam. A day before the exam, it's literally impossible for you to go and read everything in the given in the textbook, fine? Let's go to a little bit about systemic hematology, so systemic pathology, fine? I'll talk a little bit about your vegetations, few things about CVS, so the lungs, and few things about the occupational lung disease, and few things about your nephropathology. Fine, let's go. Okay, let's start. So vegetation, what is the structure? Anyone? They become so fatigued and hypoglycemic. Let's comment. What is the structure? Elongated structure. That's your chorda tendineae, right? So vegetations are primarily irregularities on the valve surface. They are irregular valve surface is called as vegetation. That's all, fine. So you have 4 different types of vegetation. Rheumatic heart disease vegetation. The other name is called as a verrucae. Okay. They are very, very tiny vegetation. They are verrucae. They are very tiny vegetation and they are sterile. Please remember them. It's a knee-jerk response you will write by default. They are infective. Because rheumatic heart disease, no, streptococcus that comes to the head and says infective. Heart does not have the organism throat has the organism. It's a sterile vegetation, right? NBT, non-bacterial thrombotic endocarditis. They are also seen along the lines of closure. They're also very tiny vegetations. Microscopy, they're nothing but thrombus. So where do I see them? You see them in any prothrombotic state. Anything which you know which can cause DIC, it can cause NBT also. Apla syndrome can cause NBD also, right? It's also seen in lines of question. Infective endocarditis, they are the only infective ones. Like Shubham said, they are very, very, very large. They are bulky extremely, right? And they can break. They are very fragile, and they can undergo an embolic transmission, right? It can undergo an embolus, can go and deposit anywhere in the body, right? That's infective endocarditis, right? And the most useless vegetation, which all of us knows, Libman-Sachs endocarditis. Where you see them? You see them in SLE. The unique thing here is appearance. It is seen on both atrial and ventricular surface of the valve. It's on both atrial and ventricular surface of the valve, not seen in the lines of closure. It's seen in your SLE lupus carditis, and obviously this also is sterile. This also is not infective. The only person who's infective is in the name, infective endocarditis. Rest everything is sterile. Immune complex is what will be seen in SLE, and your immune complex in your rheumatic artery is also thrombus in case of an NBT. So fine, perfect, right? These are the 4 different types of vegetations which has come before, which you have to know a little bit. Fine. Next, can anyone tell me what is this? Anything which comes to your mind? Whatever which comes to your mind. That's your lung emphysema, right? So you had 2 different types of emphysema. Okay, emphysema has been asked before. Again, whatever is we are dealing in systemic pathology is always in sync with medicine. That's all, right? So we have emphysema. One is pan-acinar, one is centri-acinar. Perfect, right? So this is my acini. Okay, the simple acini, normal lung, right? So one type of acini, the center part of the acini alone will be dilated. One entire acini will be dilated, right? So we call this an centri-acinar emphysema. We call this an pan-acinar emphysema. That's what. So grossly, a centri-acinar emphysema will have both emphysematous area and normal area. Because in centri-acinar, if you look at this image, I have normal in both the front and the back. Only center part is dilated, right? That's why both normal. Here, only dilated. Okay. So only dilated acini is there. That's your pan-acinar emphysema. And this is your centri-acinar emphysema. Fine. The most common by default is centri-acinar emphysema. This is a bit rare. Centri-acinar emphysema is almost always seen secondary due to smoking. This is seen secondary due to alpha-1 antitrypsin deficiency patient. Okay. And here it's most commonly seen in the upper lobes of the lung because smoke goes to the upper lobes. It obviously will go up, right? Here it is seen mostly in the lower lobes of lung. So the basic difference of centri and pan-acinar emphysema, right? Actually, we have a little bit one more example of emphysema where the bulla, the bulge will be close to the pleura, right? We call this an distal acinar. It's a distal part of the acini, distal acinar emphysema. Actually, pan-acinar can also cause this because it's the outer part, that's all. Since pan-acinar is rare, smoking-induced distal part is distal acinar, right? Or we call it paraseptal emphysema. Okay. It's again due to young smokers, people who are very young and smoke continuously, they have this pan-acinar distal acinar emphysema. And distal acinar emphysema, as the name says, they have bullae. They are also called bullous emphysema. Perfect. The only unique thing about distal acinar emphysema is the symptom. They present, the bulla can rupture. Maybe if someone hits it hard or spontaneously it can rupture. Once it rupture, we end up having tension pneumothorax. That's why most of the systemic pathologies are a combination of medicine or emergency medicine or surgery. Obviously, you have to put an intercostal tube drainage, right? IC tube drainage should be done, okay, for us to drain this condition, right? So how do you identify tension pneumothorax? No breath sounds. Absence breath sounds is a classical finding of tension pneumothorax because the air accumulates, pushes the lung completely, compresses the lung, and there'll be no breath sounds in one half of the area wherever it's having tension pneumothorax. That's a classical way to diagnose them. Fine. Okay. Which location? You know that better than me, right? So these are few things about emphysema, right? One more important topic in lung is occupational lung disease. Fine. Okay. We look at few classical occupational lung disease. First, we'll start with CWP, coal workers pneumoconiosis. Okay. Occupational lung disease is most important is I have to know the occupation. That's all, right? So coal mining is a classical occupation where you see coal workers pneumoconiosis, right? We have a simple time cause an anthracosis. Anthracosis is actually not occupational lung disease. It can be seen in you and me. You live in a city, you'll have anthracosis. It's asymptomatic, nothing much to worry, nothing will happen for this patient, right? A simple coal workers pneumoconiosis will be less than 0.1 centimeter lesion. Okay, sorry, 0.1 to 1 centimeter lesions, and this will be a reversible condition. If I stop working in the coal mining industry, automatically come back, right? Last one is complicated coal workers pneumoconiosis, which will be more than 1 centimeter till 10 centimeter, massive fibrosis. Whenever fibrosis comes inside, obviously the patient will not come back to normal. Automatically the patient will lose their life because of interstitial lung disease and respiratory failure only, right? Microscopy is the only place in microscopy I will see black color. Nothing in my body is black. Melanin is brown. Black color in microscopy, I think of a coal workers pneumoconiosis. That's all. Fine. Okay. And this here is a classical image of a silica nodule. Silica generally presents as a nodule like this. Fine. Silica nodule is classical, which I'm sure you should know about it. Fine. So silica nodule is what we see in silicosis, right? I'll write silicosis here. So since we have space here, let's go with here, right? Silicosis is the most common occupational lung disease. It's more common than coal workers pneumoconiosis. It's more common than asbestosis because silica is used everywhere. Silica is seen in glass manufacturing. Silica is seen in hardware manufacturing, chips, all of them, because nothing in my routine life now works without hardware, right? That definitely is the most common occupational lung disease because they are loss exposed. Quartz is one of the most fibrogenic silica. It's most fibrogenic silica. Your watches have quartz. Almost everything what we have silica in it, right? Right. Perfect. Silicosis has some clues. Clues, again, it involves upper lobes. When you have an upper lobe nodule, think of silicosis. Especially in occupational lung disease, upper lobe nodule, think of silicosis. There's an increased risk of TB. And there's a very unique X-ray finding in hilar lymph node called an eggshell calcification. Eggshell calcification in a hilar lymph node is classical for silicosis. Fine. These are common things are classical for silicosis. Silicosis, definitely there's an increase in risk of lung cancer. Coal workers pneumoconiosis does not have an increased risk of lung cancer. Silicosis has that. Fine. So these are few points which I want you to remember regarding silicosis. And we read in the starting, silica particle is birefringent, positively birefringent. Don't forget that. Fine. Last but not least is asbestosis. In asbestos, the occupation, there are multiple places. Cement manufacturing, insulation industry. Again, all these are manufacturing industry, right? If you manufacture asbestos fiber, fine. But if you have on the top of your home, it's not a problem, right? Shipwreck, all these will have asbestos fibers. They can end up in having asbestosis, fine. Asbestosis have two types of fibers. One is serpentine. Serpentine is the most commonly used fiber in the industry, but they are less pathogenic, good for us. And we have amphibole. Amphibole are very sharp and straight fibers. They use them, rarely used in the industries, and they are more pathogenic. Something which is good for us. That's why we don't see much case of asbestosis, because whatever is being used is not being causing problem for me. Whatever is causing problem is very, very rarely used, right? Like Srinath said, one of the most specific finding for asbestosis is mesothelioma, right? That's the rarest finding, but one of the most specific finding, right? Asbestosis can cause pleural effusion. The most common symptom in asbestosis is an asymptomatic condition called a pleural block. It's asymptomatic. You take an X-ray, you rarely find like a thick pleura. That's all. That's the most common thing. Fine. And it can definitely cause cancers. In cancers, you already know this, right? The most common by default is lung adenocarcinoma. Please don't make a mistake in this, right? Because every lecture you attend, we say this. Still, if you make mistake, no, you must have seen in WhatsApp forwards, God will come and prick your eyes. This is what will happen. If you make a mistake in asbestos, most common and the most specific, definitely God is going to come and prick your eyes, right? The most specific thing is your mesothelioma. Fine. Mesothelioma is the most specific, and lung adenocarcinoma is by default the most common one, right? We already saw asbestosis will have a fiber called as an ferruginous body in microscopy, dumbbell shape. Someone said a dumbbell shaped body, right? So this is your Pearl's Prussian blue. It's positive as an image from Robbins. Tiny brown color. In a HNE, it'll be brown in color because of iron. So we call them a ferruginous body. And the dumbbell shaped structure in Pearl's Prussian blue, that's classical finding of an asbestos body or a ferruginous body. Fine. Okay, we are done with a little bit about lung pathology as well. Fine. We go a little bit about few things about GIT also. Few cancers. That's all. Fine. So this finding is a finding in diffuse lung carcinoma called as 𝐼𝐻𝑖tis plastica. Okay, this is due to the CDH1 loss or the 𝐒𝐻 loss seen in diffuse lung carcinoma, and this is also the finding seen in same diffuse gastric carcinoma, not lung, diffuse gastric carcinoma, which causes what is finding? This might come in an exam by default. It's 𝐼𝐻𝑖tis plastica. Yes, 𝐼𝐻𝑖tis plastica or a leather bottle appearance. You must have definitely read them in your GI surgery as well, right? That's a classical signet ring morphology, right? Both signet ring morphology and 𝐼𝐻𝑖tis plasticas are classic of diffuse gastric carcinomas because of the 𝐒𝐻 loss. There's loss of 𝐒𝐻, cells don't adhere to each other, they go surrounding all around and they destroy the entire stomach and involves like this, right? Because of their very freely moving, both diffuse gastric carcinoma and your lobular carcinoma of breast, because that also will have the same problem, right? You won't have the the adhesion, right? So they can go into retrograde lymphatic spread and they can involve the ovary. Can anyone tell me what is the ovarian secondary we get due to gastric cancer in the lobular carcinoma stomach? They go into the ovary, which causes an ovarian secondary called as Krukenberg's tumor, right? So end up having Krukenberg's tumor. That's an ovarian secondary, which is seen in case of an primary is by default diffuse gastric cancer or your lobular carcinoma of breast. Fine, perfect, amazing. Okay, few words regarding polyps. There are 4 polyps which you want to remember. Villus adenoma. When you have more than 75% villi in the microscopy, we call it a villi adenoma. They have more risk of progression to cancer. Okay, so this is an example of a villus adenoma. You have lots of well-defined villi. Okay, we have something called a tubular adenoma. Tubular adenoma will have less than 25% villi. It's going to be primarily tubules, less than 25% villi. They have very, very good prognosis. They don't become cancer. They stay as a benign, very good prognosis, right? Perfect. Okay, so this is your Christmas tree appearance or whatever you want to call it, right? So if you see, the muscle goes through the glands. As a classical huge sugar polyp. It looks like Christmas tree. Right, tomorrow's Merry Christmas if you're going to celebrate that, or if you're going to be here. Wishes for clearing the exam. Fine. Okay. So it's going to be huge sugar polyp. Huge sugar polyp. Its most common location is jejunum. The appearance looks like an appearance of a Christmas tree, and we know that STK11 has been mutated here. It's an hematomatous polyp. Okay, that's a classical appearance of huge sugar polyp where you see muscle between glands. Okay, it's a classical finding seen in case of huge sugar polyp, the appearance, right? Perioral melanosis seen in huge sugar syndrome. If it's an individual polyp, I won't have that. If you have, it's a syndrome, you'll have definitely perioral hyperpigmentation, right? Last but not least is juvenile polyp. See, juvenile polyp, again, the most important clue here is age. Juvenile. A child and location will be seen in rectum. A child presenting with bleeding in the stools. Think of a juvenile polyp most often, right? Rectum. It's also an hematomatous polyp. It's the most common hematomatous polyp by default. Pugic is also hematomatous. This is also hematomatous. Okay. The reason for this, a sporadic polyp is nothing but your constipation. Constipation is the most common cause of sporadic pugic polyp. Syndromic, like Shubham said, I can have SMAD4 or SMAD2 or a TGF-beta pathway mutation by default, fine. But sporadic pugic polyp, the reason is constipation. That's definitely most common. And in sporadic conditions, what you'll have in microscopy is you'll have both dilated glands and normal glands. Okay, that's what you see in sporadic pugic polyp. Sporadic juvenile polyp. Fine. Okay, these are the 4 different types of polyps. This can definitely come in an exam. Fine. Last few slides. Okay, we'll look at renal pathology. Okay, thank you for holding up for quite close to 3.5 hours. Hopefully, in the next 10-20 minutes, I'll complete it and give you a well-deserved amazing break. Okay, so nephrotic, simple things. You guys are going to say, I'm going to write whatever you say, which will have selective massive proteinuria. Now selective, which is purely albumin, and massive, which is going to be more than 3.5 grams per day. That's massive proteinuria, right? 3 plus proteinuria or massive proteinuria, right? Nephritic syndrome also will have proteinuria, but it's non-selective and it's not massive. Proteinuria in the range of 1 to 2 gram per day is what I see in nephritic syndrome, and not only albumin, everything goes away. In addition to albumin and protein, you will have lipiduria here. Because of lipiduria, you might end up in having an hyperlipidemia. In addition to lipiduria, you will have loss of antithrombin 3. Because of this, nephrotic syndrome patients can have increased risk of thrombosis. AT3 stands for antithrombin 3, right? You'll have increased risk of thrombosis. All this will not be seen in case of an nephritic syndrome. Nephritic syndrome has 2 classical manifestations, which is hematuria and hypertension. These both are classical manifestations of nephritic syndrome. One of the classical nephritic syndrome example, pure nephritic syndrome is PSGN. Pure nephrotic syndrome is minimal change disease. Rest everything are overlap, right? There's everything overlap. I can have both nephrotic presentation in MPGN, MGN, IgA nephropathy, but these are classical examples, fine. Hematuria and cast will be there. And there's one more, the 2 questions which is being repeated again. Hematuria can be from anything, right? Even a urinary calculi can cause hematuria. Even a urethritis, gonococcal urethritis can cause hematuria, right? So how do I know the bleeding is coming from glomerulus? So to call it as a glomerular hematuria, okay, there are 2 important things. One is dysmorphic RBCs. If the RBCs are not normal shape, it's been damaged, which means it is coming from the glomerulus. Glomerulus, tubules, your ureter, your urethra, your bladder, then comes outside. In that path, it gets damaged, dysmorphic RBCs. Second is RBC cast. This both tells me the bleeding has happened in the glomerulus. Classical clues for glomerular hematuria, that's nothing but nephritic syndrome. Fine, perfect. Okay, let's go to few classical images and few important points. Okay, so here there's a normal glomeruli. There's a disease. Can anyone tell me what is the exact difference you are seeing in the second glomeruli? Anything unique? Anything unique? Can I say the second glomeruli has a little bit of thick glomerular basement membrane? Is that statement right? Kind of looks thick, right? I don't call it an RPGN. It's not RPGN, it's just thick, right? So this is MGN. Just a thick membrane. That's all. It's a thick membrane. Membranous glomerulonephritis. That's all, right? I don't see a KW lesion. KW lesion will have lots and lots of nodules. I don't have a nodule here. It's just a thick GBM. That's all. Perfect, right? Okay. So it might be a bit difficult for you to identify the images. I'll go to the next image. This image, can I say I have lots of cells inside the image? I do have lots and lots of cells inside the image, right? This image, I'm going to call it hypercellular. Hypercellularity is there inside the capillary, right? So you call it endocapillary hypercellularity. This is a classical finding for an PSGN, fine. I'll show few more images here. This image, capillary is normal here, but here the mesangium has become big here. If mesangium is expanded, and if I have an image like this which says it is an IgA deposit, then I can think of an IgA nephropathy, right? But here the capillary is normal. The space between the capillary and mesangium has become bigger, right? Okay. This, can I call this a crescent? Everyone who told crescent? Something outside the glomeruli is compressing the glomeruli, right? That's crescent. Crescent is seen in case of an RPGN. Okay, that's crescent seen in case of an RPGN. Crescent always from outside it will come and compress. It's not from the inside. Fine. I don't know if okay, this. So this is your sclerosed FSGS. Here, one entire half of the glomeruli is completely damaged and sclerosed. Right? That's how FSGS looks like. Just for context, if it's an KW lesion, which is seen in diabetes, see here, if here entire lower part is sclerosed, right? But in KW lesion, the sclerosis will be like this. Nodules. It will not be complete. In between, I'll have completely normal glomerulus, but I might have nodules of sclerosis. All the rounds are normal glomeruli. I'll have nodules of sclerosis. If you have nodules of sclerosis, I want you to think of KW lesion seen in case of diabetic nephropathy. If it's sclerosed one entire half, I want to think of segmental sclerosis and FSGS. Fine. So that's how we identify different glomerular findings. I'll add few classical clues for you for each of the glomerular lesion here. Fine. Let's go with MGN. MGN is a nephrotic syndrome by default. Like 85% of the MGNs are nephrotic syndromes. Right. MGN, the classical etiopathogens of MGN is you have an antibodies against a protein called as PLA2R, phospholipase A2 receptor. That's the antibody, and FDA has approved that I can just use the antibody level to identify its MGN, right? In microscopy, I won't have any inflammation, only thick GBM or thick glomerular capillary loop, no inflammation at all, right? In your immunofluorescence, you will have granular positivity for IgA, so IgG, okay? There's only one disease which will have linear positivity on immunofluorescence. If you see any question which says linearly positive immunofluorescence, never forget this. It's either anti-GBM glomerulonephritis or a syndrome of that Goodpasture syndrome. No other disease will have linear positivity. Only one disease will have linear positivity is anti-GBM glomerulonephritis or Goodpasture syndrome. Perfect. Spike and dome appearance is finding seen in silver stain. In silver stain of MGN, you have a classical appearance called as spike and dome appearance. Okay. And in case of an electron microscopy, this also will have subepithelial deposits. See, all these are important points with respect to MGN, which has been asked before. Fine. Etiology might not be asked. It might come a prospective question because these days I don't take a biopsy for MGN. Just look at the antibody level and get over it. Fine. Next, come to PSGN. PSGN versus IgA nephropathy or Burgess disease. This is very important, right? A patient with an URI, okay, after 2 weeks has hematuria. I think of a PSGN. This timeline is very, very important for PSGN. I need the 2 weeks by default. URI, second day, you have hematuria. Then I think of IgA nephropathy. Okay. So IgA nephropathy is immediate. PSGN takes time. The lag time is very, very important clinically for me to differentiate IgA nephropathy and PSGN. Fine. And PSGN microscopy, like I said, you'll have an hypercellular endocapillary hypercellularity, right? It will be a big glomeruli and increase in cells in the glomeruli. Okay. And immunofluorescence for an PSGN, I'll have again granular deposit of C3 and IgG, which is very, very important. I can also have IgM also, which is very, very important for the only reason serum complement levels will be low in case of PSGN. That also is a diagnostic clue for me, will be low because everything is deposited in the kidney. Styloscope appearance is name given for the IF in case of PSGN. Fine. Okay. PSGN in electron microscopy has a classical subepithelial deposit, or we call it subepithelial hump-like deposit, right? They look like a hump a hump-like deposit, classical for an PSGN. Fine. I'll just look at this. See, these are podocytes. Okay. I'll use a different color, yellow color for your GBM. So if we continue the podocytes here, between the podocyte and the GBM, you have a deposit. This is the subepithelial hump-like deposit. Epithelium here is a podocyte. Below the epithelium, I have a hump-like. Hump is like an ox. Ox has a hump-like deposit. We call that a PSGN, right? Perfect. Okay, great. That's a classical thing for PSGN. Okay. So IgA nephropathy, like I said, there are two causes of IgA nephropathy. Primary, where I have a defective IgA. It's not a normal IgA, it's a defective IgA by default, right? That's one. Second, I have secondary causes like liver failure. In case of liver failure, I can have a IgA, circulating IgA is not removed. I can have liver failure induced IgA nephropathy as well, fine? So here, in IgA nephropathy, the deposits, everything happen in the mesangium. Everything will happen only in the mesangium. It will not happen in the epithelium at all. That's why microscopy is mesangial expansion. This IgA deposit is also in the mesangium only. And my electron microscopy is also in the mesangium. For an undergraduate, there are two clues which I want you to remember for IgA nephropathy. One, no lag time hematuria, IgA nephropathy. Second, any question says IgA deposit, go for IgA nephropathy. Because otherwise you cannot identify IgA nephropathy at all. These are the two clues: mesangial expansion, no lag time hematuria, and IgA deposit, go for IgA nephropathy. The other name is Berger's disease. Okay. Just to complete MCD, minimal chain disease, which is the most common cause of nephrotic syndrome in children. Okay. Very, very, very rare and weird etiologies we have, mostly like an URA or a steroid or a vaccination can trigger it, right? Microscopy will have completely normal glomeruli, and just for namesake, we had something called an lipoid nephrosis. You will have lipid deposit in your proximal convoluted tubule. We call it a lipoid nephrosis. Clear vacuoles in PCT, and electron microscopy will have effaced foot process. Effaced foot process is classical for a minimal chain disease diagnosis. Fine. Okay. Okay. If it's IgA, joint pain, and purpura, I don't think of an hemolytic uremic syndrome. HUS is hemolytic uremic syndrome, right? You think of Henot-Scullin purpura. Fine, Srinath. You are right. We think of an Henot-Scullin purpura, which is systemic IgA vasculitis, where IgA nephropathy is an vasculitis with respect to the kidney alone. Fine. RPGN. RPGN, the classical clue is this. The patient had a creatinine of 2 milligram percentage, which results abnormal, right? Within 48 hours, it should be less than 48 hours. It's shot to 8 milligram percentage. The rapid progression. Okay. The rapid progression is what I'm going to look for. It's progressing very rapidly. I think of a rapidly progressive glomerulonephritis. The reason for RPGN being so rapid is this part. There's an electron microscopy, and that's the etiology as well. Break in the basement membrane. When there's breaks in the basement membrane, it ruptures and everything goes outside and compresses and forms crescents like this. So the crescent will compress the entire glomeruli, will not let the glomeruli function, will have an acute renal failure, right? It's an extremely acute condition, acute renal failure. We have types of RPGN based on IF. Based on immunofluorescence finding, we have types of RPGN. If it's a linear immunofluorescence finding, my diagnosis is only one guy, Goodpasture syndrome. If it's granular, rest every glomerulonephritis will be granular. So I'm just writing rest, be it MGN, MPGN, be it an IgA nephropathy, rest everything comes here, right? And there's one more thing which comes in the exam, which is posse-immune. Posse-immune is no immunofluorescence. Posse-immune RPGN, any clues? Vaginous. These are vasculitis. Vaginous glomerulonephritis, microscopic polyangiitis. Okay, all these will be posse-immune. Fine. That's how we differentiate. And the way to treat is an acute renal failure. You give an hemodialysis and take care of that acutely. That's what we do in case of an RPGN, right? Last but not least is FSGS. FSGS is the most common cause of nephrotic syndrome in adults. it's like a terminal stage. In adults, it's the most common cause of nephrotic syndrome. Is the most common finding seen in CKD also. Most common microscopic finding in any case of chronic kidney disease. We get diabetes-induced chronic kidney disease, same thing. With hypertension, same thing. Finally, sclerosis. That's all right. So here, what I have is focal and segmental sclerosis. That's what I'm going to have. Like this, either half or completely, it's going to be gone. So that's FSGS. FSGS is like an end stage. This, if the end stage is involving like 10% of the glomeruli, no problem. 90% of the glomeruli, automatically we take care of it and we throw the kidney and we have to do the transplant, right? So microscopy, there's a classification called as Columbia classification, right, for FSGS. And one type of classification, like Shubham said, is HIV-induced FSGS. We call it a collapsing variant of FSGS. This is come in an exam before. Collapsing variant of FSGS is related with HIV virus and some poor prognosis. Okay, perfect, great. So whatever Shubham said are all inherited cause of FSGS. We do have inherited causes when I have a defect in the podocyte proteins, like a nephrin mutation or a podosin mutation, right, or a slit diaphragm proteins. There's an inherited FSGS which will be present in children, and this will be steroid resistant. These are cause of steroid resistant nephrotic syndrome. Okay, those are inherited cause of FSGS. Fine. Rest everything is acquired cause of FSGS. Inherited is not that common. Acquired is by default very common, right? So for most images, you're going to tell me the answer. This is just spotter. Nothing much to read in this. Diagnosis. It's classical onion sclerosis, right? Onion skin lesion for, this is a classical finding seen in case of an malignant hypertension. Two findings in malignant hypertension. One is flea-bitten kidney, grossly, and microscopically we have this hyperplastic arteriosclerosis or onion skinning lesion, right? Hyperplastic arteriosclerosis or an onion skin lesion, onion skin fibrosis. That's classical finding, right? And this is benign hypertension. Benign hypertension is also very important from an MCQ point of view, where the entire blood vessel is completely pink. So it's completely pink. Microscopically, you call it hyaline arteriosclerosis. It's hyaline, involving arterioles, and it's sclerosed, right? And grossly in benign hypertension, we have something called as an granular contracted kidney. It will be small and contracted kidney. That's a gross finding in case of a benign hypertension, right? These two are spotters. Flea-bitten appearance has been asked recently also in the exams, so please do remember them. Malignant hypertension, contracted small kidney, benign hypertension, and you have your hyaline arteriosclerosis. Fine. Okay. Okay. This is your KW nodules. See, I'll show you the difference. Here, I'm zooming it. I hope you can easily appreciate that. Just give me a second. You have nodule, normal glomeruli, normal, nodule, normal, surrounding it, everything here is normal, right? Again, everything here is normal. When you compare this to an FSGS, see FSGS, it's completely gone. I don't have a normal glomeruli. It's not like a nodule. It's like an entire glomeruli is gone, right? But on the other hand, KW nodule will have nodule of glomerulosclerosis, right? So that's KW nodule, which is very, very specific for diabetic nephropathy. As a classical finding seen in diabetic nephropathy, the most specific findings seen in diabetic nephropathy is in KW nodule by default, right? So KW nodule is very specific. Okay. The earliest finding seen in diabetic nephropathy is thick GBM. That's the earliest finding. The most common finding seen in diabetic nephropathy is diffuse sclerosis, because we take biopsy only when it's sclerosed. That's why for us, it's most commonly seen as diffuse sclerosis, like an FSGS, but the earliest is definitely a thick GBM, and KW lesion is very, very specific finding for diabetic nephropathy, fine? Okay, let's come to the last slide of today's discussion. Two cystic disease of kidney, right? So obviously, ADPKD versus ARPKD is based on the inheritance and also based on the presentation of the age, right? ADPKD obviously going to be in adults. This is going to be obviously in children. Okay. One important classification based on the gross. ADPKD has cyst on the outer surface. But if you look at ARPKD, it's an ARPKD, right? Outer surface is completely smooth. But here, outer surface also having a cyst, right? So if you have cyst on outer surface and cut surface, it's an ADPKD. If there's cyst only on cut surface, it's ARPKD. Outer surface is smooth in case of an ARPKD. In ADPKD, it's not smooth, right? Actually, if you carefully look, the cyst in the periphery is a bit elongated. It said that ARPKD cyst in the periphery will be perpendicular to the axis of the kidney, right? It should be perpendicular to the axis of the kidney. That's how the cysts are in ARPKD. If you want to remember, but this is how ARPKD is, right? ADPKD, the mutation is in polycystin 1 and 2. The protein is polycystin 1 and 2 is mutated. Here, it's a fibrocystin mutation. Okay. ADPKD, ARPKD, both of them can have cyst in multiple other organs. You can have cyst in the lungs, you can have cyst in the pancreas, multiple ovary, multiple places, but there'll be no cyst in brain. Brain will not have cyst in ADPKD. Instead, brain will have a very classical finding called berry aneurysm. You'll have an aneurysm in the brain and not a cyst in the brain. That's an association of an ADPKD. ARPKD, in addition with cyst in multiple other organs, one of the important and worst association is congenital hepatic fibrosis. Okay. There's a classical finding for an ARPKD, and these are two differences between ADPKD and ARPKD. And one thing called an multicystic renal dysplasia. This can also come in cystic kidney disease, and it is important for us because a very classical clinical group. So what happens in multicystic renal dysplasia is the entire kidney will be replaced by cyst. So if you have a question, it's a child with non-functioning kidney. There's no function, right? It's a non-functioning kidney in a child. I think of a multicystic renal dysplasia where the entire kidney will be replaced by cyst. I'm going to replace the entire kidney by cyst. I called it multicystic renal dysplasia. Fine. Okay. That's about few things what we have read in case of an PKD1 and PKD2. PKHD1 and PKHD2 in case of an ARPKD. Fine. Okay. Got it? Perfect. Fine. So that's all for today. So thank you for an amazing patience for you to sitting for 4 extensive hours close to. Okay. So I'll share this annotated PDF also with the team. The team will share it with you and put in the Telegram group. Please take care of this. It's a 6-day session. Everything is going to be useful here. Use this for the final revision 2 days before the exam. When you don't know what to do, just take this and quickly go through it. If you sat through the class and if you listen to us, this will definitely be useful. Fine. Thank you guys. All the very best. I think the next session will start in half an hour. It will be orthopedics. Hope you enjoy orthopedics as well as PSM today, right? Bye. Thank you.
Hello, guys. So, I'm all set to start the ortho class today for FMG aspirants. Hope you're all there. Back from your lunch. So, good afternoon, everyone. Hope you had a very great session with Dr. Ranjith for pathology. So, I am going to also try and hope to match. So, this is a very dedicated, FMG Decoded series, which we have started on YouTube, especially for the FMG who are going to appear in on Jan 12th. So, we are being straight away doing it for 6 days non-stop with high heat revision. So these are all various things which we have on the app also, the rapid revision series. You can anytime go back to the app and start your preparation with the rapid revision. So this is the workbook which we have done for the ortho. So I have come up with a couple of tables which are really very important, and you can just put these tables for your last minute revision. That is why I've put the name as last minute review, where you can just revise all these tables at a glance. This can come as a direct straight questions or one liners, not to waste much time on answering these questions. You can just it will be a cakewalk for you to just answer these questions straight away when they appear in the. Okay, now let's get started. Hello, Hemant. So I want everybody to start and be with me right from the starting, because I don't want anybody to miss any single point. Because as you know, coming to ortho, the questions would be very familiar to you, but sometimes you get confused with the options. So I want everybody to come back fast and at least start listening. If you don't write, at least start listening. So because I'm starting the first one with a very important question. In Kumar Kaushik, good evening. Happy to see you. Okay, so the first and foremost and very important one is the basic differences between Montigia and Galeazzi. This is a very important question asked usually in all the entrance exams, and especially entrance exams like these FMGE, they are usually put up, and usually what they do is they give you the X-ray. But here I'm not giving most of the X-rays because I don't want to increase the size of the ortho revision book. So we are going to just quickly revise. Okay. Good evening, Yogam, and good evening, Banu. So what is Montegia fracture dislocations? So as we all know, these two are related to the forearm, right? As we all know, these two are related to the forearm fracture dislocations. What do you mean by fracture? What do you mean by dislocations? We all very thoroughly know that what is a dislocation. Whenever the articulating surfaces are not together, it is called dislocation. So dislocation usually occurs at the joints. Fracture is the breach or break in the cortex. So discontinuity of a long bone or a short bone is called a fracture. But whenever you want to use the term dislocation, that means the joints, the articulating surface are not approximating to each other. That is dislocation. Very good, Nitin. Montigia, is that what you have answered? Or Galeazzi? Okay, as everybody are thorough in this, the Montigia and Galeazzi, not just waste our time on this. So what is Montigia? As we all know, M is for medial side. So medial side, it is usually the ulna. So there will be fracture of ulna with the which joint? Yes, with proximal radio-ulnar joint dislocation. Similarly, whenever I say Galeazzi, that means distal radio-ulnar dislocation. So that is associated with the radius fracture with the distal radio-ulnar joint dislocation. So whenever I say proximal radio-ulnar joint dislocation, that means it can be a radial head. right? So whenever you see a fracture, you should always evaluate for the joint. So always the rule in orthopedics is whenever you see something, you have to always evaluate one joint above and one joint below. So these rule of one joint above and one joint below holds very, very good for fracture dislocations, especially the Monteggia and Galeazzi. Okay, is that clear, everybody? No more confusion. Monteggia M is ulna Galeazzi radius. So whenever you say ulna fracture, it is with the proximal. So please remember ulna with radial head. So radial head is present on the proximal radio-ulnar joint. And Galeazzi is radius fracture with distal radio-ulnar joint. So the wrist joint is involved here. Done? Good, no more confusion, okay? And then dealing with, these are all from your upper limb. So we are dealing with the upper limb fractures, very, very important. What they are doing nowadays is they are giving set of fractures and trying and asking you to match the fracture. So for example, they can give a Colles fracture. So whenever you see a Colles fracture, what would be your answer? Everybody know it is an extra articular. So there is no involvement of any joint in Colles because it is an extra articular distal radius fracture. Yes, distal radius fracture, and usually seen at the metaphysis or the corticocancellous junction. Fine. Yes, radius is broke near the wrist. Very good. It is, very easy way of remembering whenever the radius you see which is broken near the wrist. But please put in your mind that Colles fracture is an extra articular. And whenever I say Colles fracture, what is the one thing which you have to tell me? See, fracture near the wrist is usually a fourth year answer. But now we are giving the entrance exam, right? So you have to talk even for the displacement. So whenever there is dorsal displacement, this is the very important term which you have to remember. So I am writing it in red color. Red color. Yes. Few things about the Colles fracture. It is usually seen in the elderly. It is usually seen in osteoporotic patients. And whenever you see a Colles fracture, you should always evaluate for other bones. That is, you have to evaluate for the osteoporosis. This patient might also present with any hip fracture or the vertebra fracture in the future. So this is a fracture insufficient. Fine. So Colles fracture is extra-articular, and three important things we have to remember is this is an extra-articular fracture, and whenever there is a fracture, there will be displacement, that is movement of the fragment. So this movement of the fragment, whenever it is towards the dorsal side, this is called the Colles fracture. So I am stressing so much about the displacement. So similarly, there is a Smith fracture, which is a sister of the Colles fracture. This is also extra-articular. This is also distal radius. But what is the difference? Here the fragment goes volar. So there is volar displacement. So this is exactly opposite to your Colles fracture. So whenever you talk about Smith's fracture, it is exactly opposite displacement to the Colles fracture. But please remember both of them are extra-articular. Why I'm so specifically mentioning about this is whenever they put up the X-ray, you have to check for the intra-articular extension. So whenever you see an intra-articular extension, that means you're dealing with the Barton's fracture. So when it comes to Barton's fracture, it is an intra-articular fracture. And now this could be a dorsal displacement or a volar displacement. Hence, we can call it as a dorsal Barton's or a volar Barton. Is that clear? Yes, very good. I really appreciate Nitin for answering that. Colles is a result. So this Colles, whenever not treated well, it results into malunion. So this malunion you see as a dinner fork deformity in case of Colles, and in case of Smith you see as a garden spade deformity. Very good. That is a very good answer. And then whenever you see an intra-articular fracture, that means there is a fracture of the distal radius. Now this is extending into the joint. That means inside the articular surfaces, and that is called as your Barton's fracture. So these three, the Colles, and the Smith and the Barton's, it is about your distal radius. Right? All three, they are talking about the distal radius. Done. Then what is Schoffer's fracture? Schoffer's fractures is It is a simple radius styloid process fracture, right? Are we good? So we are still in the radius. We have completed the forearm. Now we are in the wrist. Fine. Radius styloid process. Then we are going to the metacarpal. So here we have two metacarpal fractures. One is your Bennett's. The second one is your Box's. So Bennett's is your first metacarpal fracture. So the first metacarpal is associated with which carpal? The first metacarpal is forming a joint with which carpal? Carpal bone. It is trapezium, right? So whenever there is a fracture of the first metacarpal at its base, this is called as the Bennett's fracture. And then what is Box's fracture? Neck of fifth metacarpal, right? Yes, very good. Trapezium. Very good. Trapezium. So the Bennett's fracture dislocation is the first metacarpal, that is the base. And Box's is neck of fifth metacarpal, right? Fracture of the neck of the fifth metacarpal, right? So that is your Box's. And what is the side swipes fracture? Side swipe fracture. So usually nowadays it is not seen. This side swipe fracture is usually seen whenever we go in the car, whenever we travel in the car. Uh, that was maybe in the past. We used to open the windows and they used to put the hand outside like this. Nowadays it is all AC cars, no, so nobody's putting their hands outside on the window. But this usually had occurred if you put your elbow over the window while driving, and if somebody dashes from this side, or if you do something which is static, then that would result in a side swipe fracture, where you see, yes, whenever there is an involvement of your distal humerus plus proximal radius and ulna. So that is your side swipe fracture. You can you can tell it as elbow, right? Right? Okay. So that is about your upper limb fractures. So Bennett's fracture, be careful. It is base of the first metacarpal. Base of the first metacarpal is Bennett's fracture. And what you have to remember about Bennett's, what is that important thing which you have to remember? So this is an oblique fracture. Only two fragments. Hence it is called bi. And who is the cousin of this or sister fracture of this? Is your Rolando. Right? Rolando is also, you see, at the base of the first, but that is a comminuted fracture. Bennett's is just an oblique fracture, right? Clear? So that is about the upper limb. Yes, base of the first metacarpal. Very good, Hemant. Next, coming to the bumpers fracture. So what is bumpers fracture? Whenever you stand on the road, and this car comes and hit you, at which side it can hit with the bumper? Can it hit on the medial side or the lateral side? Which side it can hit, on the medial or the lateral? Quicker. Very good, Yogam. So lateral side. So lateral condyle fracture of tibia. So lateral condyle fracture of tibia. If you just imagine you standing on the road and a car hitting you, it is usually near the knee joint, right? At the level of the knee joint. For an adult who is standing near the knee, the bumper usually hits on the knee joint. So that is the lateral condyle. Yes, whenever you see a simple lateral condyle fracture, it could be a split, it could be a depression, but the involvement of the lateral condyle fracture, that is called your bumpers fracture. Then what is your Pott's fracture and Cotton's fracture? Again, cousins, Potts and Cottons. They rhyme, right? So Potts and Cottons. So Potts is a bimalleolar fracture. And Cotton's is your trimalleolar fracture. When I say bimalleolar, that means there are two malleoli, the medial malleolus and the lateral malleolus. Whenever I say trimalleoli, along with your medial malleolus, lateral malleolus, there is posterior malleolus. Right? So whenever there is a fracture of all these three that results in the trimalleolar fracture, whenever there is only fracture of the medial malleolus and the lateral malleolus, where are these malleolus? Ankle, right? So I'm talking about this malleolus in the ankle. So whenever you see ankle fractures, two malleoli, it's Pott's fracture. Three malleolar, it is Cotton's fracture. Then what is Pott's spine? What is Pott's spine? Faster, faster, Pott's spine. Very good, Ashwin. That is TB spine is called the Pott's spine. Right? So Pott's fracture is bimalleolar fracture. Pott's spine is TB spine. Very good, Harsh. Very good, Nitin. And what is Mesonevis fracture? Mesonevis fracture. Mesonevis fracture, you can still guess because we are still in the ankle. So Pott's, Cotton, Mesonevis. Okay, not wasting our time. Mesonevis fracture is whenever you see a fracture of the ankle, that it could be a medial malleolus fracture with the fracture of neck of. So again an example of to see one joint above, one joint below. So whenever a patient comes with an ankle fracture, so this patient has come with pain in ankle for, let us suppose, and now you have suspected that there could be a fracture and you have ordered for an x-ray, and there you have seen a medial malleolus fracture. And what is the great mistake you have done there? You have not checked for the knee joint because you have ordered only for the ankle x-rays. You get only ankle x-rays and you see medial malleolus fracture, right? But what happens is in mesonevis fracture, this is an extension. So whenever there is a huge force, this medial malleolus fracture occurs and this transfers to the interosseous membrane between the tibia and the fibula, and this force further results in fracture neck of the fibula. So whenever you see this association of medial malleolus fracture with the fracture neck of the fibula, then this is called as the mesonevis fracture. Okay? Is that clear? Mesonevis fracture. And then what is pylon fracture? Pylon fracture is? So this is an intra-articular fracture of ankle where there is complete, comminuted tibial plafond. What is tibial plafond? So there are two articulating surfaces of the ankle, right? So one is your tibial plafond. So tibia will be like this. And then you have your talus. So whenever there is a severe disruption, so whenever there is severe comminuted fracture of the ankle, especially on the tibial side, that is called as your pylon fracture. That is called as your pylon fracture. Very good. Next, what is aviatus fracture? This was asked in the exam. Aviatus fracture is? Aviatus fracture. Yes, fracture talus. So usually seen in the pilots because of excessive dorsiflexion on whenever they put their legs on the whatever gear system they have, this will result in fracture of the talus. Hence, it is called as the aviator fracture. Right? So that is about the ankle, and then we'll go to the foot. So what is Chopard's? Chopard fracture dislocation. Chopard's is mid tarsal fracture dislocation. So what is mid tarsal? So we have hind foot, midfoot and forefoot, right? And similarly, we know we have these tarsal bones. You have calcaneum and the talus on the hind foot, and your navicular and the cuboid in the midfoot. So whenever there is a damage to the calcaneocuboid or the talonavicular, this results in the mid-tarsal fracture dislocations, which is called as the Chopard fracture dislocation, right? So calcaneocuboid or talonavicular is called the Chopard fracture dislocation. What is Jones fracture? This you all know. It is the fifth, Jones's fifth metatarsal base, right? Fifth metatarsal base is your Jones fracture. Is that clear? Okay, now your Rolando fracture has come. So what is Rolando fracture? We have discussed it before also. It is also the first metacarpal base. But now in Rolando, what you see, Rolando is Cristiano Rolando, right? So CR, remember this as comminuted fracture. So whenever you see more than two pieces, what is comminution? Whenever you see more than two fragments. So there are three fragments which are present here. But for Bennett's, it is only two fragment fracture. So Bennett's by BI Bennett. So there are only two fragments which are present. In Rolando, there are three. So hence it can be in the shape of T or it can be shape of the Y. But please remember, whatever it is a comminuted fracture. Done? So we are done with the upper limb fractures, lower limb fractures. So these are the eponyms, some beautiful names which have given to the fractures. For example, pylon, aviators, cotton, spot. So different set of names has been given to this fracture. Now let us see few of the spine fractures. So from here, these are the spine. Right? So first one in spine fractures is Jefferson's fracture. So what is Jefferson's fracture? Yes, Raj, very good. It is fracture of the C1 vertebrae, C1 vertebrae, and this is a bilateral fracture on the both the sides, right? It is arch shaped, right? This is arch like, right? The C1 vertebrae is arch shaped, so you have fractures on the both sides, and this is a very unstable fracture. Remember F for first. So Jefferson's is the C1 vertebrae. The cervical, first cervical vertebrae fracture is your Jefferson. Then what is whiplash injury? So just they would put what whiplash injury is and they can give you options A, B, C, D. What is whiplash injury? So this is just an injury. As the name mentioned, there are no fractures. So here what happens is there is an injury to the ligamentous. So this is a ligamentous injury, cervical spine. And why does this occur? Back and forward movement of spine. So whenever there is any injury, yeah, this could also be due to the seat belt. It moves forward and backward like this. So there will be this ligamentous injury. This is called as the whiplash injury. So sometimes radiology can be negative and they present with severe headache and decreased spine movement. Right? So this is a whiplash injury. It is an extension injury. Right. Okay, so that is a whiplash injury. Very good, Harshat and Paramasivam. What is mesentery? Okay, so that is about the whiplash injury. I just wanted to tell that because sometimes they may just put up this question. So whiplash injury is no radiological evidence can be seen. It is just purely a ligamentous injury or it is a fracture of so-and-so or fracture of so-and-so they can give you. So that would be a question. So for that, I have put that. So we are done with the Jeffersons and whiplash. So something is related to C1 and then what is C2? C2 traumatic spondylolisthesis. is what fracture? So whenever you see a traumatic spondylolisthesis of C2 over C3, that is called as the hangman's fracture. So there are two words here, hang and man. So remember Jefferson's for C1, hangman's fracture for C2. Is that clear? And what is this? The term spondylolisthesis means? Quick. I'm waiting for your response. What is listhesis? Spondylolisthesis? Hello, Chiku. Welcome. Shortening? No. It is not shortening. So spondylolisthesis is something related to the spine. So if you see, the spine is stacked like this, right? One vertebrae over one vertebrae. So forward slipping of one vertebrae in relation to the another vertebrae which is down, right? The forward slipping of the upper vertebrae. So I've told you there are two vertebrae like this. Let me put at the same level. So whenever there are two vertebrae like this, there are two vertebrae. Whenever there is a one vertebrae slipping in relation to the down vertebrae, this is called as spondylolisthesis. Yes, vertebrae slips forward. Slip of vertebrae. Very good. So whenever you see such listhesis of C2 over C3, that means C2 is the upper vertebrae, C3 is the lower vertebrae. So this spondylolisthesis, it is because of trauma. So hence it is called traumatic spondylolisthesis, and the name given to this is hangman's fracture. But the most common fracture which is seen in C2 is, don't get confused between two. The most common fracture which is seen in C2 vertebrae is, there is a special process which is present over C2. What is that called? Projection. Faster. That is called the dens. That is called the dens. Right? So most common fracture which is in, don't get confused between the terminology. The most common fracture which is seen in C2 vertebrae is fracture of the dens or the odontoid process, right? The fracture of the dens or the odontoid process. But what is C2 traumatic spondylolisthesis? The name given is hangman's fracture. The name given is hangman's fracture. So I want to take some time to explain about the spine fractures because it is little bit confusing. So whenever you want to deal with the spine fractures, the names, just remember anytime what are the movements which you can do in spine? Flexion and extension, right? So there will be flexion injury and extension injury. So flexion injury usually results in wedge fracture, right, on the anterior aspect, and extension injury. So flexion is completely like this. So complete flexion of the spine. Extension is completely like this. Okay. This extension will result in what is called as some hip fracture. So this is also on the anterior aspect. So just part of the, like the avulsion fracture. So both of this are stable fractures. So if you see a full flexion injury, full extension injury, both are these are stable. Then what are the unstable fractures? What are we worried about? We are more worried about to know whether it is a stable fracture or unstable fracture, right? So whenever this flexion is associated with a rotation or a distraction, or if there is a complete compression of the vertebrae. So you have to understand this. So flexion is just the spine is completely flexing like that. But compression is completely the vertebra is sprayed between two vertebrae. So whenever there is absolute compression, so axial compression, that is called the burst fracture. That is called the burst fracture. Just imagine stacking of papers, 1, 2, 3, 4 papers, and you just do like this. So at least one paper, it gets crumbled, right? So that is the example of burst fracture, right? So whenever there is a flexion component associated with a rotation component or a distraction component, these two are supposed to be unstable fractures of spine. And in this, what you have to remember is this flexion distraction injury, which is called as a chance fracture or a seat belt injury. And how do you identify it on the X-ray? You see a horizontal fracture of vertebrae, right? So if this is the vertebrae like this, the fracture is seen like this. So horizontal fracture. And if you see like this, the burst fracture, you see all small pieces. So completely the vertebrae is scrambled. So that is the burst fracture, right? And if you say this is the flexion injury, you see something like this. So this is called the wedging. This is called the wedging, right? And again, for extension, you see something like this. Something like this, the chip fracture. Understood? So these are the certain fractures of the spine which you have to remember. So whenever there is a flexion extension, injuries are supposed to be stable. And if this flexion is associated with a rotational compound or a distraction compound, then that is called the unstable fractures. And if it is completely compression, then it is called the burst fracture. So unstable fractures. So these unstable fractures are supposed to be treated. That means they go for operation. What operation you do? You do this called, what is this called? Pedicle screw fixation. This is called the pedicle screw fixation. So you fix two vertebrae together, right? So this is called the pedicle screw fixation, right? No, wedge is not a compression fracture. Wedge is a flexion injury. Flexion. Right? And one more way. And one more way to tell whether this vertebrae is stable or unstable, depending upon your Dennis Brown 3-column concept. What is this 3-column concept? Dennis Brown. So you divide this into anterior, posterior, and middle. So whenever there is involvement of two, then that is an unstable. Only one is involved, then it is a stable fracture. Understood? So now if you take example of this, so this is your anterior, posterior, and middle, right? So whenever there is a fracture of this, so with this wedge compression or chip fractures on the anterior, hence they are called as your stable fractures. So whenever the posterior elements are involved, such as your horizontal fracture, so whenever there is horizontal fracture like this, the posterior component is in, right? So that becomes your unstable fracture. And burst also, so all the three components are involved in burst, so that is also your unstable fracture. Is that clear? Hemant, is that clear? Yes, good. So Hemant, what you meant is flexion compression over, right? So this could be a flexion compression, that is wedge, and this is complete axial compression. Just to make Hemant feel more comfortable. So whenever you see flexion compression, so one end, only one end is getting compressed. So that is flexion compression is called wedging, and complete axial compression is called the burst fracture. I think this has put you in more comfortable place. Hemant? Okay, done. So these are about your, where are we? Yeah. So chance fracture, now everybody answer what is chance fracture? Yes, this is again a seat belt fracture where flexion, distraction, and to be very precise, just remember whenever you see a horizontal fracture of vertebrae. Yes, seat belt injury, seat belt. Very good, Chiku. Very good, Hemant. Then what is burst fracture? Again, whenever there is flexion, compression. Sorry, axial compression. So whenever there is an axial compression, and that results in involvement of all the three components, it is an unstable, right? This is called the burst fracture. Okay, next, what is 𝐒𝐿-Chauberlet's fracture? 𝐒𝐿-Chauberlet's fracture. So this is the spinous process of C7 vertebrae. So 𝐒𝐿-Chauberlet are the persons, this has been identified probably in Australia, where they dig these, they use this, something like this, and they remove the clay from it. So right, they take that and they remove the clay, and they put the clay on the opposite side. So from the clay they dig like that and put it on the opposite side. So when they do like this, and sometimes the clay is completely getting stuck to the Chauberlet, and then they try to remove it. So that causes an unstable pressures over the C7 vertebrae. So you already know the spinous process is something like this, right? So this is the spinous process. So you can see the C7 here. So remember, if this is the vertebrae, you see the spinous process, like, right? So this C7 spinous process, whenever it is involved, the fracture of this C7 is called as 𝐒𝐿-Chauberlet's fracture. Next is, what is March fracture? March fracture. Yes, actually, Chiku, I would love to show all the fractures, but again, I was just worried whether, it will become a huge book, because a lot of x-rays I have to show. So one thing I'll do, I'll try to post all the x-rays on the Telegram group, which we are there, the Sankalp group. So by the end of the day, I'll try to post the pictures or images of these x-rays, only the spine x-rays, okay? Will that work, Chiku? Yes, Dr. Max and Dr. Nitin had moved. So they are in March fracture. Very, very good. The second metatarsal fracture, excellent. And this is example of a stress fracture. So what do you mean by a stress fracture? A stress fracture is something where there is a repetitive trauma to a normal bone. So that is stress fracture. Whenever there is a trivial trauma to an abnormal bone is a pathological fracture. You have to know the difference between the two. So stress fracture, the bone here is normal. Pathological fracture, the bone is abnormal. What is treatment? Yes, you can go for pain management and conservative. Yes, stress fracture is usually conservative. We actually tell the patients to stop that particular activity, take rest, and we treat them with NSAID. Fine. So now next move on to the pelvis fracture. So again, let's take the example pelvis fracture a little bit in detail, because these are little, you have to understand them to remember them, or else you might forget, okay? So pelvis, whenever you want to talk about the pelvis, the first thing, again, you have to tell whether this particular pelvis fracture is stable or not. So in the spine, what we have done, we have taken the example, we have taken the help of the column concept, which was given by Dennis, right? So Dennis 3-column concepts we have used. So in that, the anterior, posterior, and the middle, that we have taken the help of the Dennis 3-column concept. So here what will we do is, we will take the help of the ring. So here, if you see this pelvis, this is your ilium. So this is your ilium, right? This is your ischium, and this is your pubis, right? Clear, everybody? And now what you see is the sacrum. So now your pelvis, which is of two hemipelvises, it is a ring-like structure which is connected pubic symphysis anteriorly and sacrum posterior. Clear? Is that clear? So we are on the same path. So just remember this pelvis as the ring where there are two ilium, two ischiums connected by pubic symphysis and the sacrum. Pubic symphysis, this you'll remember on the anterior, sacrum on the posterior. So whenever you see this ring is unstable, that means you have to operate that pelvis. So when the ring becomes unstable, so if you see, if there is only fracture of this ilial wing like this, do you think the ring get disturbed? Do you get the ring gets disturbed whenever there is only fracture of the ilium? So see, this is the fracture. Ring get disturbed if there is only fracture in the ilial wing. Faster, I need the answer. Nitin, Chiku, Max. No, no, no. Very good. Exactly. So now, whenever there is an isolated iliac wing fractures, isolated ischial tuberosity fractures, isolated pubic symphysis, this pubic symphysis can be like superior and inferior. You have to remember there are two, right? Superior and inferior. So whenever all these isolated fractures are there, so there is no problem with the ring. Hence, these are called as the stable fracture, or isolated fractures are called stable fracture. Now tell me if there is a fracture of this sacroiliac joint and the fracture of the pubic symphysis. Will the ring get disturbed? Will the ring get disturbed? Fracture on the posterior aspect, fracture on the anterior aspect. Will get, yes, very good. The ring now gets disturbed, right? Yes. And whenever such fractures you see, then these are called the unstable fractures. Unstable fractures. So what is the treatment of this unstable fractures? So it is very, very important because pelvis is an important bone which protects us from various important vital organs. So whenever you see such an unstable fractures, you should always evaluate for bladder, rectum, urethra, right? And you should always evaluate for shock because there will be heavy bleeding in case of pelvic injuries. So you have to evaluate for shock. You have to look for the bladder, rectum, urethral injury, right? And what is the one thing you do immediately whenever you see a pelvis fracture and suspecting it to be an unstable fracture? Immediately, you will put the pelvic binder. Pelvic binder. This was asked in the recent NEET PG. So what is that one important step which we do is, we, very good Dr. Max, we put the pelvic binder. And where will you put the pelvic binder? You will put on the umbilicus. You will put on the thighs. Where will you put? You will put at the level of, so you will identify patient's GT, greater trochanter, and then you will tie the pelvic binders. Or if your pelvic binder is not available in your casualty, you can just wrap a bed sheet and close the ring. So whenever you secure the ring with the pelvic binder, you can help stop the bleeding. And further, you can help patient to treat the shock. Okay, so that is about the pelvic fractures, right? And in this pelvic fractures, so certain names you have to remember. I will teach you only 1, 2, 3. First is a open book fracture. So what is the open book fracture? So whenever you see there is a fracture here, pubic symphysis, right? So there is some fracture happening anteriorly and posteriorly, and there is a disruption in the pubic symphysis. That means this symphysis has become like this. There is an opening of the pubic symphysis. This is called as pubic diastasis. That means the pelvis has opened like this. That is the open book fracture. Then you have your straddle fracture. Straddle fracture is, so whenever there is a fracture of superior pubic symphysis and inferior pubic symphysis on the both the sides, that means there is a disruption of the, what is this? Obturator foramen. So whenever there is bilateral pubic symphysis fracture, both superior and inferior, that is called as straddle's fracture. So how do you remember straddle fracture? Remember there are two O's, right? Straddle is 2D. There are two O's like this. So the obturator foramen is disturbed. That is your straddle fracture. Understood? And the third one, Malgagny's fracture. What is Malgagny's fracture? Just now we have explained. So whenever there is a fracture on the posterior and the anterior ipsilateral, that means on the same side, posterior and anterior same side, is your Malgagny. And yes, the fourth one is bucket handle. What is bucket handle fracture? So whenever you see this particular fracture on the contralateral, so posterior and anterior on the opposite sides, contralateral. So that is your bucket. Ipsilateral is on the same side, contralateral is on the opposite side. Is that fine? So those are certain few of the spine and pelvis fractures which you have to remember. Right? Open book fracture, straddle fracture, Malgagny's fracture, bucket handles fracture. Bucket handle fracture, remember it is contralateral. So like this, like the bucket. Two sides it should be. So it is contralateral. Gagny on the same side, that is ipsilateral. Straddle, so 2D, 0, 0, that is two obturator foramen are involved. That means obturator foramen ka upar is superior pubic, inferior pubic, right? So when these two fractures happen, that will result in straddle fracture. Is that fine? That is about your pelvis fractures. Okay. Now we have finished straddle, bilateral, superior and inferior pubic ramifications, and then Malgagny, which is ipsilateral, posterior and anterior fracture. Fine. So that is your straddle and Malgagny's. Then what is this dashboard fracture? Dashboard fracture is a complex. That means you're sitting in the car, driving. There is one more person sitting on the opposite side, I mean the left side. So he is just not driving, he's just sitting, and you have something called as dashboard. So whenever you sit like this and your knees are exactly in relation with your dashboard, and suddenly the person who is driving has put a brake, and this fellow who is sitting happily next to you will go and hit the dashboard, right? So what will happen, Shubham? Yes, there are certain series of injuries. So first there will be, first contact is with the patella, so there will be patella fracture. Then there could be injury to the PCL, that is your posterior cruciate ligament. And the third and most important thing which can happen is hip dislocation. So this force which is transferred to the knee goes to the hip, and now this hip goes into posterior dislocation, and the most common hip dislocation is posterior dislocation, right? Is that clear? We have done with the table. Yes. So posterior hip dislocation. So dashboard complex is, so this is only three options are there. So this could be a potential question for you because they'll put fourth option something else and they will ask you to identify which is not a part of dashboard injury. So patella fractures, direct patella fractures, PCL, remember not the ACL but the posterior cruciate ligament, and then the hip dislocation on the posterior aspect. So hip gets dislocated posteriorly. So that is your dashboard injury. Okay. Yes. Now I have to tell you there are two important fingers. One is mallet finger. The second one is your jersey finger. Okay. What I've come up with the images. So mallet finger and jersey fingers. So can you tell me what is the difference between mallet and jersey? So let me draw this finger. So just imagine this as the finger and this is your phalanx, middle, proximal. And if you remember, okay, this is dorsal aspect and this is polar aspect. Dorsal aspect, what you have? Yes, you have your extensor tendons. Extensor tendon, and on the volar side you have your flexor. So flexor, specifically flexor digitorum profundus, FDP. Very good, Shubham, very good. So whenever there is an injury, whenever there is an injury to the tendon, extensor tendon or avulsion, that is called as the mallet finger. So mallet finger mein what will happen? So there is a break in the extensor tendon, hence the finger goes like this, right? You cannot extend the only this, the distal DIP, right? You cannot extend it, but you can flex it. You can flex it, but cannot extend it because there is a problem in the extensor tendon. Remember, extensor, okay? Mallet is extensor, right? Then similarly, whenever there is an injury to the flexor tendon or avulsion of the flexor tendon here, this will result in what is called as jersey finger. Okay, this mallet finger is also called as baseball finger, not to confuse with the names. Sometimes they can just put this. Yeah, swan neck deformity is also similar like this, but there will be deformity. That means it will fix in that position, right? Is that clear? So we have two fingers. Please remember mallet finger and jersey finger. Mallet finger is for the extensor tendon injuries and jersey is for your flexor tendon injuries, right? Especially the FDP. So we have finished this. So here they have asked only about the mallet finger. So there is an extensor tendon injury at the distal intervertebral joint or the distal fan, right? Good. Now, so we have learned so much about the X-rays. Now, to diagnose these X-rays, we need to diagnose these fractures. We need X-rays. So X-ray, usually what we write is we write the anterior posterior view and the lateral view, right? So usually we write give us the AP view, give us the lateral view. But we have few views which are important for the diagnosis. So let us understand few important views, not very important for the exam, but they might ask. So what is this Broaden's view? So Broaden's view is mainly used for your calcaneum. So this calcaneum fractures, whenever there is calcaneum fracture, usually it could be intra-articular. That means extension into your subtalar joint. So to view the subtalar joint, we take this Broaden's view. Just remember, the foot is put like this and then you slowly rotate it 10 degrees, 20 degrees, 30 degrees, 40 degrees. So to identify the extension of that calcaneal fracture, we use this Broaden's view. Then what is von Rosen's view? Von Rosen's view, we use it for DDH, that is developmental displacement of the hip, where the hips are abducted 45 degrees and internally rotated. So abduction is like this, right? Moving it away. And then you rotate it internally like this. So whenever you abduct and internally rotate and take an X-ray, it is called as von Rosen view. And why do we do this? We do it for identifying the displacement or dislocation of the hip. That is DDH. Is that clear? Okay, just omit the swimmer's view, not required. Instead of that, what you have to know is mortis view. What is mortis view? I'll tell you what is swimmer's view. Swimmer's view is mainly put your hand like this and you take the X-ray like this. It is mainly to identify the C71 level of injury. But usually we don't nowadays we are not taking X-rays. We are directly sending it for and an MRIs. So swimmer's view, just omit it and write mortis view. Mortis view is very important. Where and when will you do this mortis view? Very good, Dr. Max. It is ankle joint. So whenever again 15 degrees of internal rotation of the leg, you see this clear ankle. So as we have already discussed, ankle is the fusion of tibia and talus, right? So to see this area clearly like this, the clear spaces, so you go for one view, which is called as the mortis view. So for ankle, these are series of X-ray. So whenever you want to ask for an ankle X-ray, what you do is you ask for an AP X-ray, lateral X-ray, and a mortis. Now this completes your ankle X-ray. So very, very important, mortis. And then oblique view. Oblique view, you take for the foot, you take for the hand to identify the metacarpals and the metatarsals. Why? So whenever you go for an AP view, you see this is AP view, right? You project it like this and you see the metacarpals. But if you go for a lateral view, you see there is an overlapping of the metacarpals. You can't see something like this, right? Lateral view. What do? We just turn the hand like this and we go for an oblique view. This oblique view is mainly for, yes, mainly for the foot and the hand. So hand X-ray, foot X-ray, we go for the oblique views. And what is that one more carpal bone where this oblique view is very, very important? I've given you the clue. It is a carpal bone. So whenever you're suspicious of this fracture of that particular carpal bone, you have to add this view. Very good. Excellent. F4. Please remember, if you don't remember the entire table, one thing which you have to remember is the scaphoid view or the oblique view. So now what you do, you take the AP view of the wrist, right? And then what you do, you take an oblique view of the wrist. So this oblique view of the wrist is nothing but your scaphoid view, and you can see the scaphoid fracture. Very good, Dr. Max. And then what is this Judet view? Judet view is little above the level. So scaphoid is at your level. Judet view is for your acetabulum. Acetabulum. So acetabulum, it is a very complex bone. There are certain walls, there are certain columns which you have to identify the fracture. And to identify these walls and columns, you go for this Judet views. There are two Judet views. One is the obturator and the second one is the iliac. So just remember not to, don't get too much into this. Judet view is for acetabulum. So whenever you see iliac wing, it is called iliac Judet view. Whenever you see obturator, it is called obturator Judet view. Why did I tell you? Because you have to know there are two Judet views, right? That is actually taken 45 degrees. So you turn the patient 45 degrees inside, 45 degrees outside to get these Judet views. Is that clear? And finally, let us end with one important view, that is the open mouth view. So you open the mouth and then take the X-ray. So what does you do this? So this is to identify the dens or the odontoid process. Right? So that is about the various views. So if you don't want to remember anything from this, the one thing which you have to remember is scaphoid. That is your oblique view. Is that clear? Yes. Next, we have to go for the plaster cast. So these are very, very easy plaster cast. What you have to do is you have to just identify them like this. So the first and foremost one which you have to remember is the Minerva cast. So this Minerva cast is when the head is completely enclosed. So this Minerva cast is complete head is also enclosed. This is Minerva cast or jacket. It is again used for your spine deformities. So that is called the Minerva cast. And then, yes, cervical injuries. Then what is this? So if you see the Minerva, I've told you it is entirely like your for this corona cases we put no entire shield, something from the head. So that is your Minerva cast. Remember that way. And what is this on your screen? Which cast is this? Yes, Shubham, very good. This is Research cast. This is Research cast. If you see, the Research cast is only up to chin here. Chin and the neck. Right, so the chin and the neck. So occiput is completely enclosed and it is only up to the chin. So this is your Research cast. Again for your cervical injury or scoliosis. Right? So this is the Research cast. Then what is this? So we have learned the Minerva, the Research. Then what is this? This is also used for scoliosis. This is called the Boston brace. Yes. Dr. Max, this is Boston's brace. And now this is your Milwaukee brace. Please remember, these are very, very important for you. So whenever they say Milwaukee is cervical also, cervical, thoracic and lumbar. The entire thing is enclosed here. But when I say Boston, you see Boston, it is only up the thoracic level. So this is for your thoracic and upper lumbar. Thoracic and upper lumbar. Boston. Okay, only up to the level of the breast. Remember that way. Only up to the level of the breast. That is your Boston, and Milwaukee is up to the cervix, right? And this is your Research cast. This is your Research cast. And what is this? This is very, very obsolete, very old. Just to complete, this is called as the turnbuckle cast. So if you see, they have put the complete cast and now they have given the hinge like this. So this hinge, they adjust it so that it will correct the concavity. Okay. So this is the turnbuckle cast. So if I say the word turn o buckle, what do you remember? Turn o buckle? Yes. Where has Nitin gone? Nitin Kumar, Hemant, Chiku, where are you? Bhanu, Tejaswini, Raj, Ashwin, Harsh Rawat. What is turnobuckle splint? Not to confused with this turnbuckle cast. Yes, what is turnobuckle splint? Where it is used? Faster. Turn or buckle splint, where it is used? This is a question which was asked. So this is your turn or buckle splint. No, not ulnar palsy. Or this is also called as the Workman's splint. So by now you have to tell me what is Workman's BIC. Yes, Nitin, I think this turnobuccal splint is also used for certain cases, but here I want you to remember it is mainly used for workman's ischemic contracture. Is that clear? Everybody, not to get confused. Now here I have put one more splint. What is this splint? This is your dynamic cock-up splint. This is your dynamic cock-up splint. This was given last exam, NEET exam. Most of them got confused. Don't get confused whenever you see these springs. So if you see the springs on the dorsal aspect, that means these springs for extensors. So whenever there is extensors palsy, that means it is radial nerve palsy. That means you are using your dynamic cock-up splint. And whenever you see this spring on the volar side, that means it is for flexors, and this is for your workman's ischemic contracture. Is that clear? Don't get confused with these two splints. It was been asked previously in the exam. And the students got confused between these two. So that is why I put these side by side so that you have a clear vision, which is workman's splint or turnobuccal splint, and which is your dynamic cock-up splint. Is that clear? Clear, everybody? Yes, Madhu, that is for radial nerve. That is the dynamic cock-up splint. Yes, you're right. This is used for your radial nerve palsy. Okay, very good. Dr. Max has given clearance. So now we are here. So we know the Minerva cast is the for spine. Research also for spine. Again, deformity. I think you can identify all this. Turnbuckle is also scoliosis or the spinal deformity. Right? And what is shoulder spica? What is a spica? What is a slab? What is a cast? This you have to remember. You have to know the difference between the slab, the cast, and the spica. Very, very important. They will put up the images. Right? So for the first time, let me explain you. Whenever you say something slab, it is only up to one side, so half of your hand. So this is your complete hand. Only you put the slab on the volar aspect or the on the dorsal aspect or the volar aspect, only one side. That is your slab. If you cover the entire circumference, that is the cast. And when you involve the abdomen or whenever you involve the opposite side, that is half of the body is involved, that is called as the spica. So spicas, we have shoulder spica and hip spicas. So whenever you put a shoulder spica, that means you enclose the shoulder and whole of this chest. And hip spica, whenever you enclose the hip along with the abdomen, then that is called as the hip spica. Is that clear? So now shoulder spica is usually used for shoulder fractures. Shoulder fractures. And whenever you include the chest along, so this entire thing is enclosed and the chest is enclosed. That is called the spica. And what is U-slab? U-slab is something used for fracture humerus. So this is U-slab. So no, not for clavicle. U-slab is not used for clavicle. Clavicle, there is nothing. Sometimes if at all you want, you can use for the shoulder spica because the lateral end of the clavicle with the shoulder joint, but U-slab is mainly used for humerus. Very good, Nitin. So what you do, you put the slab from here and you take it entirely like this. So this looks like a U, right? So you don't come here. You just enclose this elbow and you go like this. So this is your U-slab, right? And what is hanging cast? So I have told you cast is entire circumference. So whenever you put the entire POP from here to here, that is called as your hanging cast. This is also used for your fracture humerus. Okay. Now most important one, what is Colles cast? Colles cast is whenever there is a distal radius fracture. And one thing you have to remember, the thumb is free in case of your Colles cast. but the thumb is included in case of your scaphoid injury, right? So hip spica is again you go for DDH or you can go for Perthes, right? Here what you do, you put the slab for the hip joint and you enclose the abdomen as well. So that is your hip spica. Then what is cylinder cast? Two important cast, cylinder cast and PTB cast. PTB is patellar tendon bearing. Yes, cylinder cast is for your patella fracture. Very good. Cylinder cast is for your patella fracture. And PTB is the name given as patella tendon bearing, but is mainly used for your tibial shaft fractures. Tibial shaft fractures. Now, I know you all want to see the diagrams for this. So, I have brought the pictures. Okay. Chiku, where are you? So, which cast is this? This one? Which cast is this? You can see there is a enclosement of the thumb. No, this is cast. This is not slab. Yeah, very good. This is a scaphoid cast or a glass holding cast, right? And if you see the thumb is enclosed here, right? And this one, this is also cast. This one, yes, very good. This is your Coley's cast. So if you see the thumb is completely free. The thumb is completely free and you can do the movement like this on the thumb. This is the Coley's and this is your scaphoid cast. Don't get confused. This will be put up in the exam and they will ask you to identify which cast is this. Okay, good, you have done. What is this cast? This is A, this is B. What is A? What is B? Yes, Madhu, very good. Distal radius, handshaking, okay. Now I'm asking about A and B. What is A? What is B? Faster. We have already discussed what is A and what is B. Very good, Dr. Max. B is B. Very good. Patella tendon bearing. So it will be only up to here. So whenever there is a fracture of the tibia, you will put this patella tendon bearing cast. And A is, yes, this is your cylinder cast. If you see, this is extending from your groin and only up to the medial malleolus. And now you put the limb in extension for the patella fractures. Very good, Yogam. Is that clear? So this is your cylinder cast. This is your patella tendon base cast. This is your scaphoid. This is your Coley's cast. This is, I just don't want you to confuse. This is just a thumb spica. The thumb spica cast and the scaphoid cast are also similarly enclosing the thumb, but the difference is the position of the thumb. This is glass holding like this, the scaphoid, and the thumb spica is just enclosing the thumb. Usually used for the metacarpal fractures or your thumb, any, this first metacarpal fractures of the thumb or any phalanx fracture, you can enclose the thumb. That is the thumb spike. Okay, not to get confused. This is your, just remember the Coley's and the scaphoids. That is enough for you. Okay, are we done with the cast? Okay, now let us go to the osteochondritis. Osteochondritis. What do you mean by that? Osteochondritis or avascular necrosis. So there are certain areas in our body which may undergo avascular necrosis. That means there would be a loss of blood supply to that product or to that part, and that will result in necrosis. For example, if there is a femoral head involvement, what is that called as? No, I am asking about the femoral head avascular necrosis. Yeah, 𝐒𝐿 is lunate. Yes, very good. I'm asking femoral. Yes, Dr. Max, very good. It is Perthes disease. So whenever they say femoral head avascular necrosis, the answer is Perthes disease. So Perthes disease is a self-limiting disease. So the stages, there are stages in this particular disease. So because of there is abnormal vascular supply, especially at the age of 4 to 8 years, and especially we seen in case of females, the femoral head goes into avascular necrosis, right? And this is called as the Perthes disease. Now quickly let us answer this table. So 𝐒𝐿 is avascular necrosis of lock and key, lunate 𝐒𝐿. Okay, lunate is 𝐒𝐿. I don't know what mnemonic Nitin is using, but I remember this as lock and key. So lunate is 𝐒𝐿. What is pannus? Pannus? Dr. Max, just don't get confused between panners and panners. So this is a spelling mistake here. So panners is in rheumatoid arthritis. Okay, the red looking inflammation. Okay, that is called as pannus. Nothing to do with the avascular necrosis. Okay, and what did Dr. Max answer is your capitulum. Very good. Pannus is panner. Panners is capitulum. So how do you remember? Pan card. Pan card. Okay. Panners, capitulum. 𝐒𝐿 and lunate. Okay. Perthes is femoral head, that we all know already. Yeah. Panners is capitulum. Very good. Is my video stuck? Okay. Yeah, panners is capitulum. Okay, done. Next is sievers. How do you remember sievers? So usually for calcium supplement, there is a drug which is called as Shell-Cal. So I remember this as sievers is calcaneum. Sievers, calcaneum. Lock and key, 𝐒𝐿 and lunates. Sievers, calcaneum. Panners, capitulum. Perthes, femoral head. Iceline's is fifth metatarsal. Usually at the peroneus brevis tendon. This is traction epiphyseal. Okay, that is your Iceline's disease, right? Yeah, we have less time. Yeah. Freeberg's is metatarsal head. Freeberg's is metatarsal head. Okay. Next, what is Kohler's? Kohler's is, remember, Virat, that is navicular. So Virat Kohli. So navicular is Kohler's. What is Scheuermann's? Scheuermann is ring apophysitis. It is ring apophysitis of vertebrae. Ring apophysitis of the vertebrae is Scheuermann's. And what is Osgood-Schlatt's disease? Osgood-Schlatt's disease is again tibial tuberosity. This is also a traction apophysitis. What do you mean by traction apophysitis? That means the tendon is attached to the tibial tuberosity, and because of the overuse of tendon, the traction which is applied to that particular area, this will result in avascular necrosis. So example of that is tibial tuberosity, that is Osgood-Schlatters disease, and one more traction apophysitis is your Eisley's disease, that is your fifth metatarsal. Okay, so these two you have to remember. And now I keep asking you questions, you answer at your end. If I'm waiting for the answers, we are losing time. Okay, next, what is Blount's disease? This is very, very important. You have to remember this. This Blount's you have to remember. Osgood-Schlatters you have to remember. Perthes you have to remember. Okay, these are important ones. Blount's disease is one important proximal tibia medial physis. So at the proximal tibia on the medial side physis, whenever it undergoes avascular necrosis, right? So this is resulting in Blount's disease, where the patients present with varus deformity. So there is a genu varus deformity because of this apophysitis. Okay. Then Prezius is scaphoid. Prezius is scaphoid. Okay. Pannus is capitulum. So whenever there is P and S in it, remember it as scaphoid. Okay. Is that clear? Okay, we are done. Then these are fracture classification names. I will quickly write. Just put this table aside and you can revise it whenever you want. So Allman's fracture is for clavicle. Yes, scaphoid is Prezius, right? Campbell and Rockwood classification is for your AC joint. This is very, very important. This is important. Neer's classification is for your proximal humerus, where Neer has given your 4-part classifications, right? So Neer's is very, very important. It's a 4-part classification. Gartland is supracondylar humerus. So Gartland classification is supracondylar humerus. Then coming to the Milch and Mason's, Milch is for your lateral condyle humerus. Milch is lateral condyle humerus, and Mason's is your radial head. So Mason's is your radial head, right? So this is the fracture classification. So Allman for clavicle, Campbell for AC joint, Neer's proximal humerus, Gartland supracondylar humerus, Milch lateral condylar, Mason's is radial head. Then what is Beddoes for? This Beddoes is for Montegia. Montegia fracture dislocation. We have Beddoes, right? And then Freakman and Fernandez is for your distal radius. Freakman and Fernandez is for distal radius. And we have already discussed that is the Dennis 3-column is for your vertebral fractures. So identify the vertebral fractures. The stability and instability depends upon your Dennis 3-column. And what is, okay, this is the next. Young and Burgers is for your pelvis. So Tiles classification, Young and Burgess is for your pelvis fracture. Letournel and Judet is for your acetabulum. Then Thompson and Epstein, posterior dislocation of hip, right? This is for posterior dislocation of, right? And then Pipkins, femoral head. And this all, you know, Gordon's and Powell's is also for your IC fracture or your femoral head fracture. And Boyd and Griffith is for your IT fracture. Winquist and Hansen's is for your femoral shaft fractures, right? Chatzger's proximal tibia. Rudy and Algrover is for ankle. Hawkins is for your talons. Essex Lopresti is for calcaneum. And Sanders is also for your calcaneum. And most important is your Gastillo Anderson's and Sherini's is for open fractures. And this Sherini is mainly with soft tissue. Right, to classify the soft tissue. So this is the various names which I have given for the fracture classifications, and this has been asked in the exam. So they usually ask this Gardens and Powell's. Then is 3 column. As I've already mentioned, Neves and Gutland is also important. And then B, Hawkins, and your Gustillo Anders. So Hawkins has been asked again in the NEET page, right? So these are the various classification names which you have to remember. And then this is also a one-liner. So they will tell you the name of the fracture and they will ask you which vessel is injured in this fracture. So supracondylar fracture femur, which vessel is injured? So this is your popliteal, right? So whenever it is supracondylar or a knee dislocation, it is mainly your popliteal artery which is at the damage. Then fracture clavicle, your subclavian, right? And then fracture dislocation of the shoulder, it is the axillary artery. Supracondylar fracture humerus, very, very important, your brachial artery, right? And then anterior dislocation of the hip, femoral artery. Hope you're all writing together. So very, very important one-liner. So supracondylar and the knee, remember this is a popliteal artery, clavicle subclavian, dislocation of shoulder axillary, supracondylar. So most important thing of all this is your supracondylar fracture, that is your brachial artery. But supracondylar fracture humerus, the nerve which is involved is your anterior interosseous nerve. Okay, this we are talking about vessel here, Aman. And now the nerves. So shoulder dislocation, anterior, and what is the effect of it? So whenever there is an anterior shoulder dislocation, this results in what is called as damage to the axillary nerve, right? And what would be the effect? The effect would be the deltoid paralysis. Deltoid paralysis, right? And hip dislocation, it is the sciatic nerve. And what will happen? It will result in foot drop. Very good. Fracture humerus shaft. This is very important. This is called as, what is the name given to this? Fracture humerus shaft. And there is the involvement of the radial nerve, which will result in the wrist drop. What is the specific name given to it? Fracture humerus shaft with the radial nerve palsy resulting in wrist drop. Fat embolism. Huh? Keep thinking. What is a supracondylar fracture humerus? We have already mentioned. So this is the median nerve or the anterior interosseous nerve, and this will result in what is called as the pointing index, right? Median nerve is pointing in. And then whenever there is a knee dislocation and fracture neck of the fibula, you should be very, very careful about the common peroneal nerve, and this might also result in what is called as the foot drop, right? And then whenever there is a medial epicondyle on the medial side of the elbow, there is one important nerve. This is called as ulnar nerve, and the effect which will it result is your claw hand. Okay. So these are the various nerves, and please remember these two tables are very, very important. They are asked in the exam. Okay, vessels and the nerves. Okay. And what is the name you didn't mention still? Fracture humerus shaft. It is called the Holsten-Lewis fracture, right? Holsten-Lewis fracture. Is that clear? Okay. Now, again, one more important. This is again a very, very important one-liners tests which are used. So, anterior draws test is used for what? It is used for your ACL, anterior cruciate ligament. So, the patient will lie supine and you will test the laxity of the anterior cruciate ligament. That will, you will push the leg forward when compared to the femur, and if the leg is easily coming forward, that means there is a ACL deficient. And next, Latchman's, what is difference? This you need 90 degrees of knee flexion, but again for Latchman's it tests ACL, it is sensitive test. 15 degrees of knee flexion is enough. Right, very good, Shubham. It is anterior drawers, that is anterior drawers is both for ACL, Latchman's and anterior drawers both for ACL. But which is the most specific test for ACL? So this is the most specific test done under anesthesia. This is called as the pivot shift test. The pivot shift test is also for diagnosing ACL tear. Very, very specific test for ACL, usually done under anesthesia. Similarly, we have posterior draws test. So that is for your posterior cruciate ligament. And posterior sag test is also for your posterior cruciate ligament. So what happens in this posterior cruciate ligament? Sagging is there. So whenever you ask the patient, keep on supine position over the couch, you have to examine for this sagging. So whenever you see the sagging, that means this, if you think this is the femur, this is the tibia, as the patient sleeps on the couch, you see the leg is slightly on the posterior side without doing anything. The leg goes on the posterior aspect. So this is called as the sagging. And now sometimes you may confuse this posterior to anterior as the anterior draws, right? So for that you have to first check for the posterior sagging. So this was given by Godfrey, so hence it is called the posterior sag test of the Godfrey, which is for the posterior cruciate ligament. Right? What is Apley's grinding test? This is for your meniscus. Both the meniscus, both the medial and the lateral meniscus can be done with this Apley's grinding test. And similarly, McMurray's is also for your meniscus. And what is valgus and varus stress? So valgus and varus is for your collateral ligament. So valgus is for medial collateral ligament. Varus is for lateral collateral ligament. Very good, Shivangi. McMurray's is for meniscus. Yes. So varus and valgus, these two are for the collateral ligament. So remember, valgus is for medial collateral ligament. That means you hold the femur and the leg like this and you give the stress outway. So whenever you're giving a valgus stress, that means you're pushing the leg outside. There will be a stretch on the medial side of the knee. Hence, you will test for the medial collateral ligament. So when you're going on the opposite side, when you're going outside, when there is an opening on the medial compartment, that is called the medial opening. That means the medial collateral ligament is damaged. Similarly, when you give a varus stress, varus is already, you know, right? You see the OA knee is coming with varus, and similarly you take the knee inside like that. When you take the knee inside and you see there is a lateral opening, that is called as lateral collateral ligament damage. If there is no opening, then these two ligaments are normal. So this is about the knee. Next, coming to the empty can test. So what is this empty can test? Empty can is this. So you put the straight, you put your to 90 degrees, you put your upper limb like this, and then you completely do like this. This is the empty can, and you try to lift it up against rest. So this empty can or full can. So doing empty can is nothing but you're internally rotating the hand. Full can is external rotation. So like this is full can, that is external rotation. This is empty can, that is internal rotation. So whatever it is, 90 degrees to the shoulder level, and then you do overhead abduction. And if on the resistance you feel pain, these two are for your supraspinatus. So if you remember, supraspinatus, infraspinatus, teres minor, subscapularis. These are all the rotator cuff. Very good, Max. These are called the rotator cuffs. And you know, internal rotation is by subscapularis. Abduction is by supraspinatus, right? External rotation is by infraspinatus and teres minor. So gerbil lift off test is again you're doing the internal rotation like this and putting your hand like this in the back. So this is how you do it. So this is your, put the hand like this and you try to lift it like this. It's called the lift off test. So you're putting the internally rotated and then you're trying to lift it off. So this is testing your subscapularis. So testing your subscapularis. And then belly press. Again, belly press is also same. So you put both hands on the belly like this and you press like this. So this is also a type of internal rotation, right? So this is also for your subscapularis, right? Yes, very good. Amalam PR, very good. Amita Gaud, for what you wrote, teres minor, I didn't get. Yeah, lift up is very good, Shubhu. What is lax sign? So now I've told you the infraspinatus. The infraspinatus is for your external rotation. So this is your internal rotation, the belly press and the lift off. And now you're doing the external rotation. So whenever you're trying to do the external rotation like this, and now on the resistance, you're not able to do the external rotation. So there is some lag on external rotation. This lag sign is for your infraspinatus, right? So that lag sign is for infraspinatus. And can you now tell what is for drop arm sign? So now, as you told you, the supraspinatus is mainly for your abduction. So holding the hand straight like this. But because whenever there is a damage to the supraspinatus tendon, which is for the abduction, they will drop the hand. So this is called the drop arm sign. This is again for your supraspinatus. So nothing to mug up. Just remember, supraspinatus is for your abduction. So abduction, empty can, full can. Internal rotation, something Gerber lift off, belly press is internal rotation. Subscapular. External rotation, spinate. Okay. Nothing to worry. If you just do it for yourself for 2 or 3 times, you will remember. Again, knees impingement. Knees impingement is nothing but there is a subacromial space. There is acromion and there is some space in the subacromion. And there what you see is 2 important tendons. Again, these are the supraspinatus and the biceps. So whenever there is a problem in this supraspinatus tendon, acromial or the biceps tendon, you get pain on this knees impingement test. So this is the knees impingement test, right? So supraspinatus and the biceps we test here. And just remember, this is the subacromial space. This you like this and forward flexion, and because of the flexion, what happens is the subacromial space gets reduced and there will be pain. So the knee impingement test. Okay. Next, Job's test, apprehension test. These two are for your anterior stability of what? Of shoulder. So anterior dislocation of the shoulder is tested. So what happens is whenever there is an anterior shoulder dislocation, that means this humerus head which is there inside has come out. So whenever this is coming out, when does it come out? Whenever there is an abduction and external rotation, right? Abduction and external rotation. So this abduction and external rotation, again we do on the patient. So now the patient will not allow us to do. That is called the apprehension, right? So you do abduction and you do external rotation, their head tries to come up. That is your Job's test and apprehension. What is Hamilton ruler? Yugas. Yugas is just touching the opposite shoulder. So whenever the head is outside, you can't touch the opposite shoulder. So this is again for your shoulder dislocation. So this is very, very important test just to rule out your shoulder dislocation. That is your anterior shoulder dislocation. This is mainly by your Yugas test. That is touching the opposite shoulder, right? Hamilton ruler is also same. You put a scale from here to here, you are unable to do it properly. So that is also your Hamilton ruler. Nothing too much remember about it. Okay. Now comes the Thomas test. This is very, very important. Okay. This is for your fixed flexion deformity. So fixed flexion deformity or FFD of hip joint. So what happens is whenever there is a problem in the hip joint, for example, there is a TB, there is avascular necrosis, there is osteoarthritis, or there is rheumatoid arthritis. It doesn't affect it, but just imagine there is some problem in the hip. And what happens is because of the iliopsoas, which is useful for flexion of no, that there undergoes a contracture, and now the hip remains in the flexion deformity. That means the hip is in flexion. But do you think that we can walk when the hip is in flexion? No, right? We can't walk. We need the hip to be straight. Extend for us too, right? So what happens here is the lumbar spine nerve comes to help us. So this particular, this is called as Thomas test. This is called as the Thomas test. So what is this Thomas test? So you are identifying the fixed flexion deformity of the hip, right? So this is the Thomas test. So whenever they show you this particular image, and this is the angle which you measure between the couch and the long axis of the femur. So that angle is called as the FFD of the hip, right? So this is the Thomas test. Not to get confused with the Thomas splint. So what is this? This is your Thomas splint, right? And this is mainly for the immobilization of the fracture femur. Immobilization of the fracture femur. So what happens is you can see that there is a ring here and there are two rods here. So this is the outer ring, this is the inner ring, and this inner ring will make an angle of 120 degrees. So this inner ring makes an angle of 120 degrees, and this outer ring has an extra space for accommodating your greater trochanter, right? So this is mainly used, and you will have a bandage like this which is tied, and now you will put the limb over this splint. So this is your Thomas splint. Yes, Shubham, it was invented in the TB knee patients during World War II, but now we don't use anymore for the TB knee. What we use for the fracture, right? Okay, I'm going back to the Thomas test again. Yes. So this is Thomas test. Just remember, this is for the hip joint fixed flexion deformity, not to confuse with the Thomas splint anymore. Then Faber's test. Faber's test is figure of 4, which is used for the sacroiliac joint disruption or any problem in the sacroiliac joint. What you do is you use Faber's or the Patrick's test, right? What you do, think this is your limb. Now you fold the limb and put on the opposite knee, right? So whenever you're doing so, the sacroiliac joint is involved there, and whenever you see there is a pain on doing this maneuver, so that is called your Faber's test, mainly for your sacroiliac joint. And what is Schober's test? Schober's test is mainly for your ankylosing spondylitis to identify your lumbar flexion. Yeah, not pain in the groin positive. Not pain in the groin positive. Pain should be in the sacroiliac joint. It is not the groin which is painful, Shubham. It is the sacroiliac joint, back. Back, it should be painful. And Schober's test, lumbar flexion restriction, you can identify with the help of Schober's test. That means you first bend, and first you will mark a point on the lumbar spine, and then you bend. On bending, this whatever marking is there, it should increase, right? If it is not increase, then your lumbar spine flexion is restricted. That is your Schober's test for ankylosing spondylitis. Yes, right, Shubha. Next, SLRT, very, very important, straight leg raising test. So there are two straight raising tests. One is active and the second one is passive. So active is mainly for the hip joint. So whenever you can do a straight leg raising test like this, that is your active straight leg raising test. It is for hip joint. That means whenever the hip joint is stable, you can lift the limb. Passive is identifying your prolapse intervertebral disc. That is your PIVD, right? Prolapse intervertebral disc. So now what happens? Patient is on the couch and you're asking the patient to lift her limb with the knee straight like this. So knee straight and she's lifting the limb. So whenever she's lifting the limb with the knee straight in extension, there will be a pressure which is occurring over the sciatic nerve which is present on the posterior aspect. And when the sciatic nerve is painful, with the limb in less than 60 degrees of rise, That means she's having a disc prolapse, right? That is your SLRT, straight leg raising test. And these are certain, for spine problems to evaluate, you can take the help of this dermatomes, or you can take the help of this nerve roots, and then you can tell which area is involved. For example, for PIVD, if there is a toe extension is low, then you can tell that there is a problem in L5. When there will be a problem in L5, in L4 L5 disc, right? In L4 L5 disc, so L5 gets in. So for that you can use this particular table. So you will check for extension, toe extension, and if there is a problem in the toe extension, you will understand that there is a problem in L5. And in L4 and L5, the nerve which is involved is L5. In L5 and S1, the nerve which is involved is S1. Understood? So whenever there is a problem in the flexion of the toe, or in case of your ankle dorsiflexion, that is S1 is involved. So then you can identify that particular nerve root is. So for that you can use this. Nothing to explain. And then now this is also very, very important. What is osteoarthritis? What is rheumatoid arthritis? So in case of osteoarthritis, this is a degenerative disease, right? And rheumatoid arthritis, it is an inflammatory disease. So what I mean by inflammatory, what I mean by degenerative. So this is a degenerative. This is right. So degenerative is excessive use. So whenever there is an excessive use, it gets spoiled. Inflammatory is autoimmune. It is autoimmune. That means what you do is there are certain factors which is released by the body and they cause damage to your joint. That is why it is arthritis, inflammation of the joints, right? So what is that important things you have to remember? So osteoarthritis, radiological signs, let us see. In osteoarthritis, what you see is there will be joint space growing. And what is most important is there will be subchondral cyst. So as we use the joint, what happens? First, the cartilage is disturbed. And when the cartilage is disturbed, the bone which is just under it is the subchondral bone, right? So now what happens is this fluid which is present in the joint gets seeped into the subchondral bone, resulting in subchondral cyst. And then this reaction of the subchondral bone can also be seen, which is called as subchondral sclerosis. And most important thing is what you find is osteophytes. Very good, Shubham. Very good. The osteophytes, subchondral sclerosis, subchondral cyst. These are all the features of your osteoarthritis. Now coming to the rheumatoid arthritis. Rheumatoid arthritis is mainly known for its bilateral symmetrical involvement. It is bilateral symmetrical involvement. And what you have to remember is whenever you see the X-ray, periarticular osteopenia. Periarticular osteopenia. That means the joint, if you identify a joint, the area around the joint is lucent, that is light in color. Whereas in osteoarthritis, it is darker because it is sclerosis, more white. Here, this is darker, right? And then you see what is called as joint erosion. So the joints get eroded. So there will be bony erosions and there will be deformities. And there will be destruction. So bone destruction is more in case of the rheumatoid arthritis. Very good. And this is, yeah, it is polyarthritis. That means multiple involvement and it is associated with your morning stiffness. Associated with your morning stiffness. Yes, bones get erosive. That is erosive arthritis. Symmetrical polyarthritis. These are all synonyms for your rheumatoid arthritis. Now, if you see, the joints which are most commonly involved in osteoarthritis are mainly your, yes, very good, PIP, and mainly the first CMC and your knee, hip. These are the joints which mainly get involved, and spare are the mostly your MCP and wrist. and ankle, right? So these are mostly spared in case of your osteoarthritis. Whereas your rheumatoid arthritis, the most common ones are MCP, PIP, wrist, and spade are the DIP and spine, except cervical. So only cervical spine is involved, and spine is not usually involved in case of the rheumatoid arthritis. Yes, wrist, MCP, PIP are involved. Very good. Wrist, MCP, PIP. No, DIP is usually spared in case of your rheumatoid arthritis. And psoriatic, you usually see the DIP. Psoriatic, it is usually DIP which is involved in psoriatic along with your nails. Along with your nails. Okay, and then ankylosing spondylitis. Ankylosing spondylitis is mainly your axial skeleton which is involved, right? Your axial skeleton which is involved in ankylosing spondylitis, and what is spared is your appendicular skeleton, right? You know what is axial and appendicular? Axial skeleton is the spine, your sacroiliac joint. These two are very, very important. Very good, Shubham. Sacroiliitis is one which is very, very important in case of ankylosing spondylitis. And gout, what are the joints which are involved? Gout is mainly your, yes, MTP and knee, right? Gout is MTP and knee. Pseudo gout, it is mainly the knee. And actinomycosis, it is mainly the mandible. And Charcot's, it is mainly the ankle and foot. Hemophilia, again, it is mainly the knee. Okay, so these are the various joints. Yeah, very good. These are the various joints which gets involved in this arthritis. Hemophilia, it is mainly knee because there will be bleeding and then there will be loss of the cartilage resulting in the arthritis. Diabetic are Charcot's or neuropathic joint. Neuropathic joint is mainly the ankle and the foot joints which are in, right? Diabetic is, and actinomycosis is mainly mandible and sometimes tibia also gets in. Okay, so these are the various joints which are involved, and this is I have just made it as a table. So this is HLA-B positive. So we already know that ankylosing spondylitis is one of the disease which is associated with HLA-B27 positive, right? But there is Reiter syndrome. This is nothing but a reactive arthritis. Where there is a triad for this. That is, what is the triad for rheumatoid? This Reiter's, can't see, can't pee, can't bend the knee, right? So there will be involvement of conjunctivitis, there will be urethritis and arthritis. So that is your Reiter's syndrome, right? Reiter's syndrome, it is usually in association with your microbiology and ophthalmology, and chlamydia is one which is involved, right? Nikita, I have just told so much about the X-ray, right? Osteo and rheumatoid arthritis. In osteoarthritis, you see subchondral cysts, subchondral sclerosis, and osteophytes. And rheumatoid, you see all these, the periarticular osteopenia, you see bony erosions, deformities, bony destructions. So this can be asked like, what are the following which are, HLA-B27 positive? As we already know, ankylosing spondylitis, there is psoriatic, which is HLA-B27, Reiter's. Enteropathic is nothing but you associated with the irritable bowel syndrome or your inflammatory bowel disease. And SAPHO is again synovitis, acne, pustulosis, all these things. So there is involvement of Palmar and acne over the skin, that is a SAPHO syndrome. Okay. And what this vascular and neurogenic claudication, because I have to tell you that there will be some questions on the spine, such as your lumbar stenosis or your PIVD, right, or spondylolisthesis. So these three are diagnosed based upon your neurogenic claudication. So that we have to discuss in Okay, okay, no problem. So, no problem, Nikita. So that you have to discuss in brief with the vascular claudication. So what is actually this claudication? So whenever you have this neurological claudication, that means the patient will have sciatica. That means pain which is present over the back, and this pain increased on extension of spine and increased on walking and standing, right? Decreased walking uphill, right? So these are all the things you have to differentiate. And what is the one thing which is here? You will see peripheral vascular status abnormality. So vascular status will be abnormal and no neurological deficiency. Whereas on the neurogenic claudication, you will find there are neurological deficits. And why I am telling that this is walking uphill, it is decreased. That means the patient goes into flexion. Now, if you are flexing the spine, the pain is decreased. And if you're extending the spine, this pain is increased. So this is very, very important to diagnose all these conditions, such as your cold, that is other than your trauma of the spine, these are the core topics of the spine, like your lumbar stenosis, your PIVD, spondylolisthesis. These are all diagnosed based upon your neurological claudication. Done? And what is this generalized osteosclerosis? This I have just put up because they will put this X-ray, and sometimes they can ask you all of these are present except, and you will see lot of sclerosis. That means white, more white, right? So these are fluorosis, the Paget's disease, the renal osteodystrophy, marble bone disease, Angelman's. Angelman's disease is an sclerotic autosomal dominant because of defect in the transforming growth factor. So there is some defect in this transforming growth factor, and this is a systematic disease, right? Angelman's. And what is marble bone disease? This is osteopetrosis, right? So these are all the examples of the generalized osteosclerosis. So these are like something which you can't miss it, and they can be learned as the one-liners. Then next comes the bursitis. So there are certain names given to this. So prepatellar bursitis is housemaid's knee. So your housemates keep working, bending on the knee, which develops this prepatellar bursitis. And infrapatellar bursitis, yeah, rugged jersey is seen in renal osteodystrophy, correct. Infrapatellar is seen in, yeah, clergyman's disease. Clergyman's knee is infrapatellar. 𝐒𝐿's is weaver's bottom. Olecranon is student elbow. Trochanter is usually seen in infective. Retrocalcaneum is seen in Haglund's deformity, right? And then pes anserinus on the medial aspect of the knee, right? And then lateral malleolus, where you see tailors, right? Lateral malleolus you see in the tailors. Yes, is that clear? Next, coming to the splints. So this splint we have already discussed about the Thomas splint, right? Bowler Brown, will discuss it later. Dennis Brown is seen in CTEV. If you remember, that is the Dennis Brown splint which is used in CTEV. Then Cock-up splint is seen in the radial nerve palsy. And knuckle bender you see in ulnar nerve palsy, right? And then Workman's, we have already learned this. Workman's splint, that is Workman's ischemic contracture, that is VIC. And then four-post collar. Where do you see this four-post collar? Very, very easy. You see four posts, like you see two poles like this on the anterior aspect, two poles on the posterior aspect, mainly for your cervical pathology. So any problem in the cervical region, your cervical spine, you use this four-post collar. Aeroplane splint is used for your brachial plexus. And SOMI brace. SOMI brace is again sternum occiput mandibular brace. So sternum occiput mandibular again for your cervical pathology. Right? And then ash brace. Ash brace is for thoracic. So this ash brace, thoracic and lumbar, is nothing but it is just like this. So it is like this. This is your ash brace. Yeah. Taylor's is mainly for tuberculosis and osteoporosis. Don't forget tuberculosis because it's thoracic and lumbar support, right? Thoracic and lumbar, especially even the lower lumbar is used for your upper lumbar. Yeah, Taylor is for spine trauma also. And we have already discussed this Milwaukee and Boston. Please remember that is for your scoliosis, right? I'm sorry, I'm extending my time a bit. By 5:30, I think we are supposed to complete ortho. So next, entrapment syndromes. This entrapment syndrome is for carpal tunnel. As you all know, what is the nerve which is involved? It is the median nerve, right? It is the median nerve. Then pronata syndrome. Pronata syndrome is also for the median nerve, where you see the median nerve goes between two pronata teres, two heads of the pronata teres. That is your pronata syndrome. Then what is cubital tunnel syndrome? Cubital is for your ulnar nerve. Cubital tunnel is for your ulnar nerve. So this area on the medial aspect, what happens is there is an Osborn's fascia. Osborn's fascia, and this fascia covers, and sometimes whenever there is, yeah, very good. Cubital is ulnar, Guyans is ulnar. And then thoracic outlet, which brachial plexus is involved? It is the which trunk? It is the lower trunk, T8 and T1. There could be involvement of the subclavian vein and artery, right? Subclavian vein and subclavian artery, right? And then piriformis syndrome. Piriformis is your sciatic nerve. Then myalgia paresthetica, lateral cutaneous nerve of thigh, right? Lateral cutaneous nerve. Then tarsal tunnel, chiralgia paresthetica, it is your superficial radial nerve. It is your superficial radial nerve. Tarsal tunnel, posterior tibial nerve. These are all one-liners. There is nothing to teach about it. Just you have to remember Morton's metatarsalgia is your interdigital nerve, right? And usually seen in second and third toe, right? Yes, C8 and T1 mainly the ulnar nerve. Yeah, C8 T1 is ulnar nerve. So your thoracic outlet can also be an ulnar nerve pansy. And piriformis is very, very important. Your sciatic nerve is involved there, right? And I think this is all easy for you. Morton's metatarsalgia. And now this is the tumor. And oncology is very, very important. I have not come up with any x-rays of the oncology because in radiology, they'll exclusively deal with all the oncology x-rays. I have come up with something, what is the most common site and what is the most common name for that radiological presentation, right? So when I come to simple bone cyst, it is mostly seen in the proximal humerus. It is mostly seen in the proximal humerus. And aneurysmal bone cyst, it is mostly seen in the femur more than tibia. So this is very important. So whenever they put up an X-ray and they can ask you which tumor this is. So for that you have to remember what are the most common favorite sites for it, right? And enchondroma is mainly seen in small bones of hands and feet, right? Enchondroma is a tumor of the cartilage, right? Chondroma is cartilage. And then osteochondroma, osteoma, Ewing's, it is all the femur, right? And then adamantinoma is mainly tibia. Multiple myeloma is mainly vertebrae. Chordoma is mainly seen in sacrum. Fibrous dysplasia is again upper, right? And then chondroblastoma, again humerus, upper end of the humerus, right? Yes, vertebrae and skull is multiple myeloma. Osteoclastoma is again knee, more than knee. That means in the knee, mainly it is the distal femur more than tibia. Right? So this is how you have to remember. These are the most common size, that is GCT or osteoclastoma. And then you have to put this also. Sunray appearance and Codman's triangle is mainly seen in your osteosarcoma. Both these are seen in your osteosarcoma. So bubble appearance, osteoporosis. Most commonly osteoporosis is vertebra. So bubble appearance, GCT. Onion peel appearance is seen in Ewing's. Very good. Glass ground appearance or shepherd proof deformity, fibrous dysplasia. Yes, Ewing's is onion peel. Very good. Patchy calcification or popcorn punctate comma shaped. All these classifications is mainly seen in case of your chondrosarcoma, right? And whenever it is a homogeneous calcification, that is your osteosarcoma, right? Please bear in mind. So whenever there is patchy calcification, what is osteopetrosis? Osteoporosis, which one you want to learn, Erin? And chicken wire calcification is not a feature of your radiology. It is seen on the biopsy. It is again your chondrosarcoma, right? Fallen fragment or trapdoor sign is seen in the simple bone cyst. Simple bone cyst with the pathological fracture, right? With the pathological fracture. Yes, and then double density, this is seen in aneurysmal bone cyst. Double density fluid with the septa. Fluid is blood inside. So this is ABC, not SBC. Yeah, fallen fragment is SBC, I think, Shubham. Winking oval is metastasis. Yeah, fallen leaf is SBC. Moth-eaten bone is multiple myeloma. Right? And then polka dot, your quadri, your jailhouse, all these appearances is seen in hemangioma. Right? It is hemangioma. And these are various appearances of the, usually they will put the x-ray up and they can give you this sign. So you can see an x-ray with something like homogeneous calcification, or they can tell you fallen fragment or trapdoor sign is seen in so and so, or winking owl sign is seen in, like that. Okay, it is like again a one line. Next type of sequestra. So what is a sequestra? A sequestra is nothing but a dead bone. But there are types of sequestra by which you can identify the disease. For example, if it is a tubular type of sequestra, that means it is a pyogenic infection. That is infection of the bacteria, pyogenic infection. And then if you see a ring sequestrum, where do you see a ring sequestrum? You see it in case of amputation, or you see in case of your external fixators, right? External fixators, you see the pins are there, no? So there also you get what is called as the ring sequester, right? And then feathery is usually seen in syphilis, right? In case of syphilis, you see this sequester. And coarse sandy, fine sandy, sandy is something like sand like, but if the sand is little bit, rougher end, then you can tell this as tuberculosis. And if the sand is fine, you can tell this as viral infection, right? And kissing sequestra, Osteomyelitis is pyogenic osteomyelitis, right? So it is tubular sequester. Understood? Kissing is your TB disc. Peridiscal, that means peridiscal. Kissing sequestra. In Bombay or black, it is mainly actinomycosis. And 𝐶𝐂𝐝 is usually seen in fungal infections. You see 𝐶𝐂𝐝 sequestra. That is again black. And then buttonhole sequestra. Buttonhole sequestra is post-radiation. Post-radiation. Yeah, pot spine is kissing sequestra. Again, TB peridis. So osteomyelitis, as Shubham has asked, it is the pyogenic infection. So tubular sequestrum is seen in kiss. In TB, if it is TB, it is coarse sandy, right? If it is fungal infection, it is 𝐶𝐂𝐝-like. I mean, like black color, right? And then various angles. Which of the various angles which we see in the ortho? So carrying angle is where we see it in the elbow, right? So 11 degrees and 14 degrees in females. So this is between the angle between your upper arm, that is your humerus, and the lower arm, that is between your radius and the ulna. So that is the carrying angle. Then neck shaft angle is similarly between your angle between long axis of the femur and your long axis of the neck. So that is 130. So whenever this is there, you see what is called as varus and valgus. So this is called cubitus varus and cubitus valgus depending upon the carrying angle, and neck shaft angle you call it as the coxa vara or the coxa valgus, right? Coxa vara and the coxa valgus. Okay, and then Bowman's angle. Bowman's angle is again seen in the elbow with the humerus. Long axis of the humerus with the capitulum. So humerocapitular angle is your Bowman's angle. Q angle is your quadriceps angle. Q angle is your quadriceps. Then Kite's angle you see in CTEV where it is 0 degrees. That is between calcaneum and your talus, right? So that is your Kite's angle. So this is very important. This has been asked in the exam, right? And then Bowlers and Gisens. I think this, you know, Bowlers and Gisens is usually seen in case of your calcaneum again. Calcaneum fractures. Bowlers decreases, Gisens increases. So gains. So there is an increase in the angle. If there is an increase in the angle, that is called as fracture, right? That is your Bowlers and the Gisens. Alpha and beta, it is seen in DDH. So there is alpha and beta. Normally is alpha more than 60, beta less than 50. Right? And Bowlers and Gisens, what happens is in case of fracture, in case of calcaneum fracture, Bowlers decreases, Gisens increases. So by that you can identify the fractures of the calcaneum, right? And then we have already dealt, this is Thomas plane, this is Thomas test. And what is this? This is a pathological fracture. So I have already told you that here the bone is abnormal. I will just take more 10 minutes and they'll complete it off, okay? So bone is abnormal and what happens is the force which is acting is trivial. So trivial force when acting on the abnormal bone which will result in what is called as pathological fracture. So this is an example of a pathological fracture, and all the carcinomas or whatever we have dealt so much like metabolic diseases, your oncology, these are all will result in what is called as your pathological fractures. And what is this? This is your stress fracture. This is your stress fracture. Second metatarsal, this is your stress fracture, right? And this is normal bone, right? I've already explained this is normal bone and repetitive force. Normal bone and repetitive trauma will result in what is called as your stress fracture. So don't get confused between pathological and the stress fracture. Abnormal bone, normal bone. Understood? And then what is this? This is non-union. Non-union, you can see there is no union which is happening here, right? So the bone has not united. Okay, and if you see this, what is this? Your malunion. Malunion, what happened? The bone has united, but wrong alignment, right? Wrong alignment. I know you all know what is non-union and malunion. Non-union, what happens here is biology is abnormal. That means the bone is not able to form a new bone, but alignment is good. Okay, so whenever there is no union of the bone, this is called as a non-union, and whenever there is a union but not aligned, that is called as malunion. What are the examples of non-union? Where you see non-union? Whenever there is an abnormal vascular supply. What are the examples of non-unions? Yes, very good. Very important one is IC fracture. So intra-articular fracture, scaphoid, talus. So these are all, these three are, yes, any intra-articular fracture. So for example, your lateral condyle of humerus. So all these are examples of your non-unions whenever there is intra-articular fractures because of the synovial fluid, inhibition of the union takes place. And what are the examples of malunions? Malunions you see mainly is your Colles fracture where you see deformities. That is your dinner fork deformity we have already seen. And then your Smith's fracture where you see garden spade. And the third one is your supracondylar fracture humerus. That is what is that is called as gunstock deformity. That is your gunstock deformity. Right? So this is the examples of malunion, your distal radial, Colles, your Smiths and supracondylar, and these are the examples of the non-union. Right? So these non-unions, whenever they are not forming the bone, they may result in avascular necrosis. This is an example of avascular necrosis also, right? And what is this? We have already discussed. This is the patella tendon brace, right? And this is the hanging cast and U-slab we have already discussed. And this is then open injury. So these are two important things. Whenever there is an open injury, you have to follow the Gustello-Anderson's classification. So you follow the Gustello-Anderson's classification, and this is your external fixation, which is your rods and tubes, and this is your ring fixation. So this ring fixation is called the Ilizarov ring fixation. This is Ilizarov ring fixation, right? So this is your external fixation. You can see we have fixed with one rod and there are four pins. So this is rods, pins. Which pin we use here? We use the Schwann pins here, right? And this is your Ilizarov ring fixation. This is 360 degrees stability, which right? And then this is your BB splint. This is your BB splint where it is used for traction. So upper tibial skeletal traction, and this is your skin traction. Just remember the names, that is enough. So whenever you're giving a skeletal traction, you use a pin here, right? So you put a pin here. So that pin can be a Dunham's pin, right? This could be a Dunham's pin. Schwann's pin is usually used in the external fixation, right? So Dunham's pin is used, and this pin, Steeman's pin. The other one is your Steeman's pin. Yes, Steeman's and Dunham's. So both these pins are used, and this is used for skeletal traction. You put the pin in the tibia and use the BB splint, and this is no skeletal traction. This is the skin traction. You use the help of this, and now you put the weight here. And what is this? This is called the Gallo or Bryan's fraction for shaft of the three important things you have to remember is you put for both and then you elevate the buttocks, right? And it is used for shaft femur, gallows and Bryans and less than 2 years of age. Yes, very good, Shubham. It is less than 2 years of age with gallows and Bryans traction, right? And now these are the implants. What is an implant? What is an instrument? Implant is one which we put inside the body, right? We will leave it inside the body. So there are implants which we used, and to put this implant inside, we use the instruments. Instruments always outside, never to leave the instruments inside the body, okay? So what is this? So this is a DCP, dynamic condylar, compression, dynamic compression plate. Okay, so how do you differentiate the dynamic compression plate? And if I say one is DCP, the other one becomes the LCP. So this is your locking compression plate. So let me tell you only one difference between these two. The one difference between these two which I want to tell you is, if you see, this is the oval shape. This is the dynamic compression plate, right? And if you see here, this is the combi hole. What do you mean by combi hole? It is like this. And you see there are threads inside it. So this threaded is called the locking. So when you see threads inside the plate, you tell that is a locking compression plate. And when you just see a oval round like this, you say this as a dynamic compression plate. Understood? Only that you have to understand. These are specific plates which are there. So if you see locking, so you can see the threads, and the screw will also have the threads. So this screw threads and the plate threads will get locked. Hence, this is called as a locking mechanism. And this is a specific plate which is specifically used for your distal radius fracture, right? And then what is this? This is very, very important. Yeah, Salter Hallis. This is important for you. This is asked in the exam. What is this? This is tension band wiring. Tension band wiring is for mainly for whenever you see a bone which is involved with the tendon. For example, your patella, your olecranon, medial malleolus. These are all we can treat by tension band wiring principles. So which are the things which can we treat? Patella, medial malleolus, olecranon, and your trochanter. Yes, this is tension band wiring, TBW, right? Yeah, you use two K wires and SS wire. So this is the K wire which we have put, and this is the SS wire, right? So this small wire is the SS wire. Okay, and then what is this? Intramedullary interlocking nail. And if you see intermedullary interlocking nail, and there is a plate for fibula, right? So whenever there's a tibial fracture, you go for this intramedullary interlocking. That means the nail is inside the bone and it is locked, right? So this is intramedullary interlocking. So locking is approximally you're locking, distally you're locking. So this locking gives the rotational stability to the fracture. Okay, and this is your PFN. This is also important. So this is your EHS and this is your PFN. So proximal femoral nail and your dynamic hip screw. So these are mainly for your IT fracture. So whenever there is an IT fracture, yes, this is dynamic hip screw. Very good. So you see a screw which is present in the head and this is supported by a plate. So this is your dynamic hip screw. So this is your DHS. And this is your PFN, proximal femoral locking. You can see there is a nail. So proximal femoral nailing. This is a nail, right? And this is a dynamic hip screw. So this is a screw. And then you have two set of screws. One is the cancellous screws. This they might ask you, which is what? So cancellous, if you see this thread distance is more, right? This thread distance is more. And this is the corticular screw. So corticular screw, this is called the pitch, which is less, right? So this is the cortical screw where the pitch is less. The distance between two screws is less, and here the distance between the screw, the pitch, that means the distance between threads is more. So this is cancellous screw, this is the cortical screw. And what is this? This is the VIC, Workman's ischemic contracture, and this is your Workman's sign. I'll tell you, Salter Harris. And what is this? This is your myositis ossificans, and usually seen in the elbow and the hip, right? And this is usually by massage technique, right? Whenever you do excessive massage over there, you will find this myositis ossificans, where the muscle, myositis is muscle, will get ossified. The muscle will get ossified, right? And what is that important muscle here which is getting ossified? This is the brachialis, right? The brachialis muscle, and you can see this as myositis ossificans. And this is your avascular necrosis. I have told you, right? Non-union of scaphoid will result in what is called as AVN. What is the investigation of the choice in case of AVN? You have to go for MRI. Investigation of choice in case of avascular necrosis is MRI, and this you can see there is the avascular necrosis, very good, of the scaphoid. Now, two important things which you have to remember is, one is the Bankard's lesion, and the second one is your, what is this? Hill-Sachs lesion. Bankard's lesion and Hill-Sachs. What is Bankard's? So this is the labrum which you see, and whenever there is a tear in the labrum, that is the problem in the glenoid. So this is usually present on the anterior aspect. So anterior, inferior is your Bankard's lesion, whereas posterolateral is your Hill-Sachs, and Hill-Sachs is on the humerus. So H for H, Hill-Sachs is for humerus, Bankard's is for your labrum. That is, tear in the labrum is called your Bankard's, and tear and problem in the humeral head, that is on the posterolateral aspect, is called your Hill-Sachs lesion. Then what is this? Yes, these are recurrent shoulder dislocation, not just shoulder dislocation, Shubham. This should happen in case of recurrent shoulder dislocation. So this dislocation, if it is happening more than thrice or 4-5 times, then this results in these two problems, right? And what is this? This is a static cock-up splint. This is a static cock-up splint, right? And then we have already learned this is a dynamic cock-up splint. So static cock-up splint and a dynamic cock-up splint, both used for your, both cock-up splints is for your, yes, radial nerve. What is this? This is your wrist drop, right? This is your wrist drop, right? And then what is this? This is your gun stock deformity, and this is as a result of what? This is result of your malunion in case of supracondylar humerus, right? So this is called as your cubitus varus, where your carrying angle is furthermore, right? And this is scaphoid, we have already discussed, and this is very important, posterior dislocation of hip. This is posterior dislocation of hip, and here what is important is your attitude. Your attitude is what matters. What is your attitude? Ease of your position. So in this, what happened is there is an adduction and internal rotation. So if you see, this is the adduction and internal rotation. So this is the posterior dislocation of hip, most common, right? And the problem here is there would be a sciatic nerve problem, right? And what is this? Hemiarthroplasty. This is your hemiarthroplasty, where your head is replaced by the prosthesis. So this is not an instrument. Instrument gives this just the support. This is a replacement of an anatomical part. So this is called your prosthesis. Called your prosthesis, and this is your bipolar prosthesis. Bipolar prosthesis, right? So what is a prosthesis? Whenever there is a replacement of an anatomical part, that is called as prosthesis. Whenever which is something which is supporting, which is called as an implant, right? So this is the prosthesis. So what is this? This is your Morse. So there are two O's. If you see, this is a Morse prosthesis, right? And what is this? This is a total hip replacement. So they have asked you enough of the hemiarthroplasty. They might put up this X-ray where the acetabulum is also replaced. So acetabulum and the femoral head both are replaced. So this is called as the total hip replacement. Okay. Okay. And whenever there is a fracture, IC fracture, this is very important. So this has been asked in the INICT and the NEET also. So IC fracture can be treated either by cancellous screws, but that depends upon the age of the patient. If the age is less than 60 years, you can go for cancellous screws. If the age is more than 60 years, you have to treat with either prosthesis or your THR, right? That is hemiarthroplasty or a total knee replacement. So this is an example of cancellous screw where it is a simple fracture and fixed with 3 cancellous screw. So see, cancellous screw, if you see, I have told you that there are threads and this is plain here. There are no threads here. So if fracture is here, the threads should cross this fracture line. Hence, it gives the compression, right? Yeah, less than 60 years. Yes, because IC fracture is one such fracture which might result in non-union and it might result in avian. So this is the CC screws. You can, if avian is present, then you can go for your replacements directly, or yeah, Mayors you can still try, but now usually we go for replacements if there is any. Right, so this is a 3 screws inverted triangle fashion. This is the inverted triangle fashion, right? And then this is already done. Which one is bolus? Which one is Gissanes? So this is the bolus and this is the Gissane. So this is used for calcaneum, fracture, bolus decrease, Gissanes increase. And this is SLRT as we already discussed. It is a passive SLRT because the surgeon himself is doing the passive SLRT, and it is usually for diagnosis of PIVD, right? And then we have already told you that whenever there is a problem in the disc, so whenever there is a prolapse intervertebral disc, the traversing nerve root, so this is the traversing nerve root which gets affected. So in case of L4, so in case of L4 and L5, it is the L5 nerve which is involved, and in case of L5 and S1, it is the S1 nerve which is involved. So this should be borne in mind, that is the traversing nerve root is involved than the exiting nerve root. Understood? And this is the spondylolisthesis. So this is the example of your spondylolisthesis. So forward movement of the vertebra over the lower vertebra. So if you see there, the line which is drawn is like this. So this is called the step sign which is seen in spondylolisthesis, right? And then what is this? Very, very important, asked in the exam. This is called as the shopping cart sign. So this is called the shopping cart sign. We have discussed in detail about this. So whenever there is a flexion of the spine, the pain will be relieved in case of your lumbar canal stenosis. In case of your lumbar canal stenosis. So this is called the shopping cart sign, right? And this is which angle? Cobb's angle, which is usually seen in scoliosis. And here what we do is if it is 20 degrees of Cobb's angle, we go for observation. If it is 20 to 40, we go for bracing. And if it is more than 40, we go for. So how do you measure? You will take the most proper vertebrae and draw lines parallel to it. And then you draw again a perpendicular lines to it. And then you measure the Cobb's angle. Fine. And this Milwaukee brace, Boston brace we have done, rheumatoid we have done, and this is what is called, this is called the dagger's sign. Dagger sign is nothing but your posterior longitudinal ligament is ossified. This is seen in which condition? This is seen in condition which is called as ankylosing spondylitis. This is seen in what condition? This is ankylosing spondylitis. So what are the other things which you have to remember? We have to remember the bamboo spine, right? Wearing of the vertebrae. And then you have to remember the daggers, right? And this is your bamboo spine, right? And then this is rickets. You know, there are three important conditions, that is fraying, splaying, and cupping, usually seen at the physis because of decrease of vitamin D level, right? Okay, the most important thing is now this is the scurvy. So there are other signs and symptoms which you have to remember in scurvies. So scurvy, what you actually see is, it is because of what? It is because of vitamin C deficiency, right? But the calcium is present, but the vitamin D is present. The problem here is with the collagen. So you see sclerosis in case of scurvy, lucencies in case of your rickets. So if you see, this is your lucencies, a fraying, splaying. You can't see calcium. That is no sclerosis. But whenever you come to scurvy, what you can see, ring epiphysis, which is called a Wimberger's sign, that is a sclerosis again. So calcium is present. And extension of this is called the Pelkan spur. Again, you will see there are subperiosteal hemorrhages. So whenever you see this type of sclerosis, more of calcium, more of whiteness, it is usually scurvy. Whenever you see lucencies, more of darkness, it is usually rickets, right? And what is this? I think this is a very key thing. Wimberger's sign, and this is not a DCT. This is a Brown's tumor, which we see in case of hyperparathyroidism, right? And this could be a differential diagnosis also. And what is this? This is called the ivory vertebrae, right? Usually seen in case of your Paget's disease, right? And what is this? This is your picture frame vertebrae. This is your picture frame vertebrae. Yeah, osteoclastoma. This is your GCT, but remember, osteoclastoma is little aggressive. If you see, this is not so aggressive. So this could be a Brown's tumor, which is differential diagnosis of your osteoclastoma, which is usually seen in your hyperparathyroid. Okay. And this is ivory vertebrae. This is picture frame vertebrae, again in Paget's. And what is this? This is your DDH. So this could be DDH, where the proximal migration of this is seen, and it could, and this is your Ruger Jersey spine. Ruger Jersey spine, right? And this is usually seen in renal osteodystrophy. Okay, renal osteodystrophy, and even in your hyperparathyroidism, right? Okay. And then this is your osteogenesis imperfecta. So this is your osteogenesis imperfecta, where you see that there is a defect in what? Collagen A1 gene. So there is a defect in collagen A1 gene, OI. So you see various stages of healing, in case of your osteogenesis imperfecta. But what happens is there are multiple fractures. But healing is good. That is what you have to remember, right? Blue sclera and dentigenous imperfecta, that is involvement of the teeth, involvement of the eyes, and this is called the, yes, triad of osteogenesis imperfecta. And what is this? This is osteomyelitis infection, mainly seen in the metaphysis, right? And this is the sequestrum. So this is the acute osteomyelitis, usually changes in the end, and this is your chronic osteomyelitis. So in chronic osteomyelitis, what you see the sequestrum, see the involucrum, see the cloaca, right? Sequestrum, involucrum, and cloaca. What is sequestrum? Sequestrum is nothing but the dead bone. Involucrum is nothing but the new bone, and cloaca is the opening. And if you can see here, you can clearly see that this is the dead bone. Dead bone is more sclerotic because there is no removal of the blood no removal of the calcium there, because the blood supply is not there. Blood supply is cut off. So what you see is the dead bone is more dense, sclerotic, right? Surrounded by lucency, and a new bone, that is the involucrum. Sinus is nothing but an opening. Sinus is usually seen in what? It is seen on the skin. I am talking about the bone here. So cloaca is the opening on the bone. Is that clear, Mangal? And if you see this is nothing but Gary's osteomyelitis. So sclerosing osteomyelitis. So there is an excessive of osteomyelitis which you can see, but the infection is limited. So whenever you see excessive osteomyelitis, it is usually the Gary's sclerosing osteomyelitis. And what is this? This is Brody's abscess. Brody's abscess. These are all, this Gary's osteomyelitis and your Brody's abscess, these are subacute form, where you see the body defense mechanism is more. Okay, here when you see chronic, here the organism power is more, right? So hence it is able, and here also it can happen, Gary's osteomyelitis. Okay, so subacute osteomyelitis is usually seen in mandible also, but it can happen anywhere. So whenever there is an infection which is present inside, and the body is able to, defense it, then it is called the Brody's abscess. It is right. So tibia, you can see a center like cyst-like lesion. So it could be a differential diagnosis of others also, but usually we see the Brody's abscess at this level, and this is also a subacute condition. Subacute PSM will start. I'm sorry. And this is TB spine. I think you're all waiting for PSM. I'll just complete it off and then PSM will start. So this is the TB spine. TB spine mostly is peridiscal. That means it is around the disc, right? So this is spot spine. So peridiscal. TB is also very, very important. This is the MRI of the TB, and disc is usually involved, and then one vertebrae above, one vertebrae below gets involved. So this is because the Baston's plexus of veins, that is the supply of the blood supply, is that way. So hence the most common is paradiscal or peridiscal. Okay. This is again Perthes. So Perthes is avascular necrosis of femoral head, you usually seen in 4 to 8 years, right? And then this is your Dennis Brown splint. Dennis Brown splint. So this is usually seen in CTV. right? So CTEV, what happens is first we treat with the casing, right? And then after it is corrected, then we give this Dennis Brown splint. And once the patient starts walking, Dennis Brown is not skiffy, it is CTEV. CTEV, yes. And then once the patient start walking, what we give is the CTEV. This is CTEV, walking stage. So patient is, whenever the patient starts walking, this is CTEV. CTEV shoes, what you have to remember is three important things. So first one, what you have to remember is the inner border has to be straight. So what is CTEV? What do you remember by CTEV? So there are certain deformities which you have to be corrected. So how do you remember the deformities? You remember it as cave. So first one is cavus. Second one is adduction. Third one is varus. Fourth one is equinus. So these are all the deformities which you see in the CTEV. And now what we do? We do a technique which is called as the Ponseti's method of correction. So Ponseti's method of correction we do, and this is by casing, that we put the plaster of Paris. So once it is corrected, then we put this Dennis Brown splint. Dennis Brown splint for the, yes, I will teach you Saltaralis, then only I will leave. Then we put the Dennis Brown splint. So this splint is usually used for like 24 hours in the starting and then 12 hours, right? Then 12 hours. So this splint. Once the patient starts walking, what we do, we give him the CTV shoes. So to prevent the adduction, the equinus, the varus and all, what we do is we put the inner border straight and we raise the outer side. So outer side is raised and there is no heel. So if there is no heel, if the heel is there, the foot again goes into flexion like this. So there is no heel. And the outer eye is raised because again it may go into adduction like this. So you're raising the outer head, and inner border you're putting it straight so that again it doesn't go to adduction. So you have to remember that there is a straight inner border, raised outer border and no heel. So these are the terminologies. Again remember, these are three numbers, so it could be a question for us because fourth one will be the wrong one. Okay, and once we are done with the Perthes and CTV, we are left out with the, yeah, if CTV shoes fails, if it is not PM. Yeah, if the correction is not done properly, then we go for PMSTR. CTV shoes are usually given if the correction is done. Okay, there is no failing of CTV shoes. If the patient neglects using the CTV shoes, then again it can recur and then we can go for PMSTR. Okay, and now what is this? This is a screening of DDH. So there are two things which you have to, yeah, if Ponseti not, yeah, if not fails exactly, there's no failing. See, we just try, and if it is completely corrected, then we treat normally. See, usually PMSTR we go for people who are neglected, who are recurrent, who are resistant, right? So if it is a normal CT, if the patient has come day one with us and following our instructions, nothing to do with it. If the patient has any recurrence or if it is a resistant CT, then we go for PMST. Okay. And this is a screening of CT, DDH. Screening of DDH, you know two things, Barlow's and Otterloni. I know by this time you have put various mnemonics to remember your Barlow's and Otterloni. I don't want to confuse you. But only thing what I want to tell you is whenever you do abduction, whenever you do abduction, it sits into it. Whenever you do adduction, it goes. So abduction sits inside. How will you remember? You remember the mothers carrying, the Indian mothers carrying their babies. So whenever they carry their mothers on the hip bone, the limbs get abducted. So that is the treatment for your DDH. So remember, whenever you're abducting, it goes inside. Whenever you're adducting, it comes outside. Okay, that is the easy way. Okay, and the treatment of this is Pavlik harness. Again, I told you it is just the Indian mother holding their babies. So this is called the Pavlik harness. Pavlik harness is the treatment for newborn babies with the DDH, right? And once they cross the age, there are various treatments like hip spica. We go for hip spica if it is, like more than 2 years, and we go for closed reduction and open reduction if it is more than 6 years, right? And sometimes we can go for total hip replacement if it is more than 18 of DDH neglected. Okay, and what is this? This is exactly your Perthes. So if you see, there is an femoral head flattening is there, no? So this is your, this, I don't know how many times I have put this Perthes disease. Now Mangal and Shubham, your Salter Harris has come. So this is your Salter Harris classification. So why is this classification important? So this is mainly important for children because involvement of physis. Physis is nothing but the cartilage growth which increases the longitudinal length of the bone. So the bone is increasing like this. Okay, if it is increasing in the diameter, this is by the apophysis. If it is increasing like this in the length, it is by the physis. So this physis is seen as lucency on the x-ray. If you see, this is the physis. So this is the epiphysis, metaphysis, diaphysis, and this is the physis which is seen as a darker structure on the x-ray. Now whenever Mangala, okay, whenever there is a damage to this physis, so there are various levels in this physis, right? And the most weakest part in the physis is which part? It is zone of hypertrophy. So what happens is, now I have told you the bone is increasing its length like this, right? So now what happens is, okay, from the epiphysis, so there will be a reserve zone in the epiphysis. The reserve zone is there are stem cells or germinal layer. Then there will be zone of hypertrophy. Then the zone of provisional calcification. So these are the zones, various zones which are present. So what happens is, whenever this weakest zone of hypertrophy is damaged, there is no problem to it. Okay. But whenever this reserve damage, whenever this reserve cell is damaged, that means if the damage is towards epiphysis, then limb length disturbance will occur. So now why this Salter is important for us is to tell the patients whether this patient will have a limb length disturbance or not. For that, Salter and Harris has given us a classification. So this is Salter S, A, L, E, and R. So Salter has made it easy that we can learn the name by himself. So this is a normal physis, and if these physis is separating in a straight line, and if this is through the zone of hypertrophy, then this is type 1 Salter Harris classification. So there is a what happened is, now there is a trauma to the patient, and now there is just a slip in the physis. So the example of this is SCFE, slipped capital femoral epiphysis. The example of this type 1 Salter Harris is SCFE. Now next type 2. Type 2 is A. SA. A is above. What is above the physis? That is your metaphysis. So whenever there is an physis involving the metaphysis together, metaphysis, so that is type 2. So example here is your supracondylar fracture of humerus. Okay, हाँ टाइप 2 पर ही आता है, क्योंकि टाइप 2 में क्या है, it you have a fragment of metaphysis here. What is this fragment called? Thurston Holland fragment. So whenever you see a fragment like this is metaphysis involvement, and that is called the Thurston Holland fragment. That is type 2. Type 3 is lower. So type 3 is involving the physis and the epiphysis. So always remember there is involvement of physis plus. Okay. In Salter type 1 only physis. Type 2 physis with meta. Type 3 physis with epi. And this is through the physis. That means meta, physis, epi. 3 are involved. And this is called the crush injury. And this is type 6. So this is your Salter Harris. Now you tell me which will have the disturbances. Limb length disturbances is seen in which type? I mean, let us tell it will start in which type? It will start in type 2, type 3, type 4 or type 5. Shubham ji, answer kijiye please. Limb length disturbances will start from which type of Salter Harris classification? Type 2 may look, it is the metaphysis, right? So usually the deformities we see in type 2, but usually the limb length disturbances will start from type 3 because the epiphysis is involved from type 3, right? Okay, so that is your Salter Harris classification. Yes, type 3. Okay, Shubham, is that clear? So reserve zone or germinal cells are present towards type 3, towards the epiphysis. So metaphysis is provisional calcification. So type 2 Salter Harris, if not treated well, might result in deformities like your cubitus varus in case of supracondylar. And type 3 is epiphysis, right? It is the articular which is involved. So it is lateral condyle mainly. Example here you can take it as lateral condyle of human. Okay. So what is this? This is the green stick fracture. If you see the fracture here, so here one fracture, one cortex is broken, the other cortex is intact. So this is the green stick fracture, right? And this is what? This is claw hand. Ulnar nerve injury. This is claw hand. Very, very important image space. This is already we have spoke enough time. Saturday nerve palsy, wrist drop, and this is pointing index. I think you're all well versed with this pointing index. So this is the median nerve. This is also called as your Ochsner's clasp deformity. So you're clasping the Ochsner's clasp, and because of this median nerve, the tendon, flexor tendons is supplied. So this is called the pointing index. And what is this? This is Dupuytren's contracture. So the palmar fascia, there will be some fibrous dysplasia. So because of this fibrous dysplasia, you see a cord-like structure usually seen in ring finger, right? This is called Dupuytren's contracture. Dupuytren's contracture. Next, what is this? This is torticollis or Wryneck because of involvement of sternocleidomastoid muscle, shortening of the sternocleidomastoid muscle. Okay. And this is clipple fill already given here, low hair, short neck and fused cervical vertebrae. Again, 3 options are there. Be careful. This might be asked in the exam. Everything is given here. Clipple fill syndrome. Okay, so vertebra fused, so their fragmentation is disturbed. So vertebra will not get separated. They get fused because of the short neck, webbed neck will be there. And fused cervical vertebrae. Now instruments, very, very important. This is called periosteum elevator. So there is a periosteum, this is the bone, and there is an important layer around the bone. This is called the periosteum. So to remove this periosteum, what we use is the periosteum elevator. And what is this? These are the bone spikes. So you put the spike around the bone to hold it. So you hold the bone spikes and then you operate it. So these are the instruments which help in operation. So this is the periosteum elevator and this is the bone spike. And what is this? Your osteotome, right? There is a curved osteotome and there is a straight osteotome. This is to break the bones. Okay. And what is this? Curette. This is your bone curette. Okay. So to remove all the hematoma which is bare, and this is your bone holding forceps. Okay, bone holding forceps. So this will hold the bone for you, and this is plate holding forceps. So once you put the plate on the bone, so this can help you for plate holding over the bone. And finally, sorry, I'm extremely sorry for taking a lot of time. So this is the Jaipur foot. So this is the Jaipur foot. And this was initially designed, this wooden one. Okay, and if you see, this is the wooden keel which is present, and this is your Jaipur foot. So this is what is mainly used now. So there is 3 blocks. So this is the 3 blocks which are present. And for this 3 blocks, what we can do is you can do your dorsiflexion, you can do a plantar flexion, you can do your inversion. So all these are possible with this. So this is very comfortable, and this has been called your Jaipur foot. Okay, this is Satch foot, solid ankle cushion heel. Okay, Satch foot and Jaipur foot. The difference is this is more used for the barefoot, and this should be used with the shoe. Okay, so this is the thing. Any doubts you have, you can ask me anytime on your Telegram group, Instagram. What else you want? Sedans classification. So sedans and Sunderlands classification. Sedans classification में 3 होता है. One is neuropraxia, second one is axonotmesis, and third one is neurotemesis. So what you have to remember is neuropraxia is just, so if this is the nerve, so you have the axoplasm here. So flow of this axoplasm is stopped. So this is just a concussion. So everything is intact, only the flow is stopped. So this flow can be restored again. So because everything is intact, so that is your neuropraxia. Example, your Saturday nerve palsy. And then your axonotmesis. Axonotmesis, whenever there is damage to the axon. Okay, your axon sheath is damaged, right? And the neurotemesis, yes, neurotemesis is break in the nerve. So nerve sheaths are damaged. So if you see now your axonotmesis and neurotemesis, you don't know what is actually happening. So Sunderlands has come with 1, 2, 3, 4, and 5. So what he has told is, so first there will be axoplasm. Okay, then you have the endoneurium, then you have the perineurium, then you have the epineurium, right? So what happened is, first one is neuropraxia. So Sunderland and Sedans both are on the same terms. Second is only the axon sheath which is damaged. So this part, okay? And then third one is your endoneurium. Fourth one is your perineurium. And fifth one is your epineurium, right? So this is what, yeah, endo, peri, and epi. So this is what Sunderland has told us. So this is how we have to differentiate the complete conduction block. There is no partial conduction block. There will be complete conduction block. So that is the neuropraxia. Whenever there is a damage to the axon sheath, then it is type 2 endoneurium, type 3, type 4 peri, type 5 is epi. That is your Sunderland's classification. And whenever there is damage to axon, endo, and peri, what will have? There is a Wallerian degeneration. That means there is Wallerian degeneration is, what is Wallerian degeneration? So like inflammation of the bone. So you know stages of bone healing, right? Similarly, there are stages of nerve healing also. So this nerve gets healed by this Wallerian degeneration. But whenever there is damage to the epi, no regeneration is. Okay, so that is your stage. TB ka 4 stages. So first is always stage of synovitis. So synovitis is nothing but inflammation of your synovium. So whenever there is an inflammation of the synovium, there will be increase in the fluid. So this fluid should be, hey, Galeazzi and Monteggia only I started the class. No, first one what we started is Galeazzi and Monteggia. That is done. So whenever there is an increase in the fluid, the hip joint should accommodate that fluid. For that, always it goes in flexion and abduction. So whenever you see flexion and abduction of any joint, it is the ease of the joint to accommodate that fluid. That is first stage of synovitis. Then second stage of early arthritis. So stage of early arthritis is now the synovitis has gone and now there is a damage to the cartilage. Now what happens is it goes into flexion and adduction. So here flexion and abduction, there will be lengthening. So this is an apparent lengthening. So actually not lengthening, but it appears to be lengthened. Here it goes to apparent shortening. Apparent matlab feels like, not exactly shortening. You can just feel like shortening, right? And then what happens is in stage 3, it goes to late arthritis. Late arthritis में complete cartilage का damage हो जाता है and it will go into flexion and adduction. This is the stage of true shortening. So this is the stage of true shortening, right? And then fourth stage is advanced arthritis. Fourth stage have your advanced arthritis. So complete damage where you have your wandering acetabulum. So one of the most important thing is wandering acetabulum. So the head becomes so small and now it moves inside the acetabulum. So head acetabulum is big, head is small. So one more thing is whenever there is something like this, what is this called? Mortar and pestle. Mortar and pestle. Okay, so these are the stages of TB, stages of any TB, hip, knee, anything is same. So first is stage of synovitis, early arthritis, late arthritis, and advanced arthritis. Hope we have done. So finally, thank you so much. All the very best. Please do well. Know your rank after, know your marks after you get through the exam. Hope you will get everything from the workbook we have done. We have done so much today. And I'm extremely sorry for PSM students who are waiting for sir. I'm extremely sorry. Thank you so much. I'm not taking much of your time. You can ask me anything on Dr. Alekhya Ortho, that is the Insta. And in Telegram also you can ask me. Yeah, Mangal and Shubham, I'm waiting for your rank, your marks. Thank you so much, Anonymous XOXO. Okay, bye, guys. Bye. Thank you.
Hello students. Hope I'm audible, guys. Hope I'm audible. Fine. Good evening, guys. Okay, fine. Let's start the class. Fine. Good evening. The topic we'll start here with demography. Start with demography. I feel this is the most important topic, guys. Yes. Okay, this is the most important topic as far as your exams are concerned. Okay. So as far as subject is concerned, you know that we'll get around 30 to 35 questions. Okay. We'll try to see how much is possible from our side. What are the areas, guys? First, let us start with demographic cycle. I'll write from here itself. What are the stages of demographic cycle? Okay, so I will write lot. You just observe. High stationary, guys. Okay, high stationary. High stationary means birth rate is high. Okay, death rate is high. Fine. Let us discuss, guys. Okay, high stationary means birth rate is also high, death rate is also high. Okay, early expanding. Okay, early expanding. Early expanding means, what does it mean? Early expanding. Okay, so birth rate is still high. PR means birth rate. Death rate compared to previous stage started declining, guys. Compared to previous stage. Okay, fine. Third phase is late expanding. Late expanding. Good evening, guys. Good evening. Late expanding means, okay, both birth rate is also declining compared to previous stage. Death rate is also declining, guys. Okay, good evening, guys. Okay, fine. Now the question here is, India is in which state, guys? India is in which state? Which stage is there? India. Low station. You answer this. India is in which stage? Low birth rate and low death rate, guys. Low birth rate, low death rate. Lot of theory is there. So we will discuss and I will write. Anyway, we are sending the notes. You just listen to me. Fine. The fifth one is declining phase. Declining phase, birth rate is less than that of death rate. Okay. So India is in which phase here? Excellent. India is in late expanding phase. India is in late expanding phase. Okay, fine. Now, what is this concept called as? Countries moving from one phase to another. What is this movement is called as? Every country will move like this. What is this called as, guys? It was asked in your exam. It is called as demographic transition. Okay, based on the economic development. Okay, when the country becomes rich, okay, more educated, okay, country goes from high birth rate, death rate to low birth rate and low death rate. This concept is called as demographic transition. What is the formula for sex ratio, guys? Sex ratio is number of females to number of. Okay, what is the value for India? The last value, we are sticking to what is the last census value. There are 940 females are there per every 1000 males. What is child sex ratio? Child sex ratio. Yes, good evening, guys. What is child sex ratio? What is the age group we are including here, guys? Number of female children between 0 to 6 years to number of male children between 0 to 6 years. This is 914, guys. Okay, 914 per every 1000 male children. Okay, fine. So we have seen demographic cycle, we have seen stages, sex ratio, we have seen. Next, what is dependency ratio? Recently asked question, guys. Whom do we call as dependent? Yes. You want me to speak little fast? I think already I am speaking fast. Am I not audible, guys? Am I not audible? Am I audible? Fine. I can speak fast. Okay, let's see. Okay, dependency ratio. Okay, whom do you call as dependent? Whom do we call as dependent, guys? What is dependency ratio? Whom do we call as dependent? Okay, whom do we call as dependent? Less than 15 years, 65 years and above, guys. They are dependent. Denominator is people between 15 to 64 years multiplied by 100. This is dependency ratio, guys. This is dependency ratio. Now, can you tell me here what is, okay, demographic bonus? Okay, what is demographic burden? Based on this concept, what is demographic bonus and demographic burden? All are asked in your exams. Demographic bonus burden means if there is a increase in, okay, old age population, it's numerator. Okay, if there is an increase in numerator, that is less than 15 years, 65 years or more, means it is demographic burden. Demographic bonus means decrease in denominator. Decrease in denominator. Decrease in denominator. Okay, fine. This is demographic bonus and demographic burden. If these people are increasing, it's called as demographic bonus. Demographic bonus. Okay, fine. Burden means increase in numerator, guys. Burden means increase in numerator. Okay, fine. What is general fertility rate, guys? It's a very commonly asked question. Okay, we'll see what is general fertility rate. The formula for general fertility rate is number of live births in a particular year, for example, divided by women in reproductive age multiplied by 1000. This is general fertility rate. Number of live births by women in the reproductive age group. General fertility rate. Second one, okay. Recently asked question. What is general fertility rate? Number of live births by women in reproductive age group. Now, next, what is total fertility rate? What do you understand by the term total fertility rate? What is TFR, guys? What is TFR? TFR means average number of children born to a woman, guys. Average number of children born to a woman, that is we call it as TFR, guys. What is the average number of children born to a woman? That is TFR. What is the target for India? TFR for India is less than 2.1. What you are asking is what is denominator? Denominator means in this context, okay, this one, guys, this one, people. If there are more people between 15 to 64 years, that is demographic bonus. Okay, if there are more numerator, okay, more number of old age people are there, then it is demographic burden. Okay, fine. That is old age people or young children are more, means it is demographic burden, and the working population is more, means it is demographic bonus, guys. It is bonus. TFR, it's multiple times asked question. The target is TFR is less than 2.1. India achieved this. Okay, India has achieved this target of less than 2.1. India has achieved this. This is total fertility rate, average number of children born to a woman. What is gross reproductive rate? Again, multiple times recently also asked question. You are trying to predict number of girl children born to a woman based on current fertility rates. Assuming no mortality, guys. No mortality. You are not taking into consideration mortality. Okay, this is gross reproductive rate. Number of girl children. How many girl children a woman will have? Okay, based on current fertility and no mortality. Okay, I'm repeating again. It's a type of prediction how many girl children women will have based on current fertility rates, assuming no mortality. Keep the 3 point. No mortality means it is gross reproductive rate. Okay, fine. So multiple times repeatedly asked question. This is the most important topic out of all. Second, what is net reproductive rate? Net reproductive rate. Number of girl children born to a woman based on current fertility and mortality, guys. And mortality. You are taking into consideration both, guys. You take into consideration both. Okay, that means girl children, current fertility and mortality. If you take both means it becomes net reproductive rate. Okay, are we clear? Net reproductive rate, both. You are taking into consideration both. Okay, to achieve a NRR of 1. If you want to achieve a NRR of 1, we require a couple protection rate of 60%. Okay, all are MCQs. Okay, fine. We require a couple protection rate of 60%. That means 60% of couple should be protected. Am I clear? So girl children, current fertility, no mortality means gross reproductive rate. Girl children, current fertility and mortality. It means it is net reproductive rate. Okay, fine. Repeated concepts, guys. Next, in barrier methods, let us learn some terminologies we learn here. Barrier methods. Okay, what is this today? Okay, today this is vaginal sponge, guys. Vaginal sponge. Okay, it contains a chemical called as non-oxynyl. Vaginal sponge. Key points we will discuss. We have 3 hours of time. We will try to discuss. Vaginal sponge, non-oxynyl. Next. What about IUCD? The common IUCD what we use is copper T 380A and copper T 375 we use. Program wise what we use is copper T 380A. What is this 380 means what? 380 means, what is the 380 means? Surface area of copper in square millimeter on the. How long you can use it, guys? Copper T380A. How long you can use? Okay, you answer this question. Copper T380A. How long you can use? Copper T375. How long it can be used? Okay, fine. Why it is visible in X-rays? For X-ray visibility, what is the chemical that is added in copper T? Okay, we have added, what is this? Barium sulfate. Okay, fine. 380A, how long it can be used? Okay, start answering, guys. 380A, yes, 10 years. This is 5 years. 5 years. Excellent, excellent. Okay, you're answering, nice. Keep on answering, guys. Okay, 5 years and 10 years. What is the mechanism of action? Okay, it causes foreign body reaction. Foreign body reaction makes uterus unfavorable for implantation. Okay, how many children the women should have to have copper T, guys? 0, 1, 2, 3, 4. 0, 1, 2. How many children a woman should have for copper T? How many children a woman should have? Minimum, how many children? Women should have minimum 1 child should be there, guys. For copper T, minimum one child should be. Nulliparous women, copper T cannot be inserted. Minimum 1 child should be there. Okay, fine. Now, what is the most common side effect? Okay, you answer this. What is the most common reason for removal? Yes, guys, you answer it. Okay, what is the most common side effect? What is the most common reason for removal? So minimum 1 child should be there. The most common side effect is, yes, what is it, guys? Most common side effect is bleeding. Most common reason for removal is pain. Okay, fine. Next. This is copper T, guys. Okay, copper T. Fine. Next is OC pills. You tell me, okay, Mala D and Mala N. Which one is free, guys? Okay, out of this, one is free. Which one is free here? Okay. It contains 0.515 milligram of levonorgestrel, 0.03 milligram of ethynyl estradiol, guys. Okay. Which one is free here? Mala N is free. What is the mechanism of action? Okay, you tell me what is the mechanism of action. Okay, what is the mechanism of action? Yes. Okay, both are similar. What is the mechanism of action, guys? Yes, mechanism of action is what? It prevents ovulation. Okay, it prevents ovulation. Okay, okay. What are the some dangerous side effects? Dangerous side effects. What can happen? Okay, what can happen? What can happen? What are the dangerous side effects? Yes, it can cause MI venous thrombosis. MI and venous thrombosis. These are the dangerous side effects. Okay, fine. So mechanism of action is it prevents ovulation. Yes, it prevents ovulation. Now tell me here. Okay, what is this one? What is the chemical present in sen-chroman, guys? What is the chemical that is present in sen-chroman? What is this? Antara. What is the chemical? Yes, what is the chemical that is present in sen-chroman? What is this? Antara. Antara means what? The chemical that is present in sen-chroman is what? Ormeloxyfen. What is Antara? Antara is related with what, guys? Antara is related with what? Antara is DMPA. What is DMPA, guys? Depot medroxy progesterone acetate, guys. Yeah, this is injectable contraceptive. This is injectable contraceptive. You keep answering, guys. Okay. Depot medroxyprogesterone acetate. This is Antara. What are the emergency contraceptive methods available? One, you can use OC pills, guys. Second, OC pills with high estrogen. Yes. Okay, Antara, it has to be given 150 milligram every 3 months. Okay, OC pills with high estrogen. Third, you can use mifepristone. Fourth, you can use, okay, mifepristone. Fourth, what you can use is 0.75 milligram of levonorgestrel you can use. Okay, and the last one you can use is IUCD. Okay, all these methods has to be used within how much time, guys? All these methods, how much time? IUCD can be used up to what time? All these methods can be used up to how much time? Yes, within 72 hours. IUCD can be used within 5 days. Remaining all are 72 hours. This can be used within 5 days. Okay, 5 days. Now, this is emergency contraception. This is emergency contraception. Okay, fine. Vasectomy. What is the advice we'll provide, guys? Vasectomy. What is the advice we'll provide? They are not immediately sterile. Use other methods. For how long? Okay, you answer this. Okay, vasectomy, use other methods. Okay, what are the other methods? You have to use other methods. They are not immediately sterile. Okay, yes, for 3 months. Okay, you say 12 weeks, guys. 30 ejaculations. 30 ejaculations or 12 weeks. Okay, 12 weeks. 30 ejaculations or 12 weeks. Okay, fine. This is vasectomy. Use other methods, guys. Other methods. What is Pearl index? Okay, 2 ways we can calculate contraceptive failure rate. One is Pearl Index, second is life table analysis, guys. Okay, life table analysis. You may get a problem. What is the formula for Pearl Index? Recent trend is you are getting problems in your exams. Accidental pregnancies by total months of exposure multiplied by 1200. Accidental pregnancies by total months of exposure multiplied by 1200. 100 women we are following. Okay, out of 100 women there were, for 2 years there were 20 pregnancies. Can you tell me what is the answer? Accidental pregnancies by total months of exposure multiplied by 1200. 100 women, 2 years, 20 pregnancies, guys. Okay, now tell me what is the answer here. Numerator is 20. 2 years means what? 24. That is the only catch here. For one woman it is 24 months. For 100 women you have to multiply it with 100. This is okay. Hope this is clear, guys. Okay, accidental pregnancies by total months of exposure. Okay, fine. Are we clear, guys? Okay, shall I continue in the same context? The most important topic what I feel is demography, guys, in your exams. Okay, are you guys able to follow this? Yes, shall I continue? Fine. Now let's go into maternal and child health, guys. Okay, some other terminologies we can learn here. What is this niche? Niche is pregnancy test kit. Okay, niche is pregnancy test kit. Okay, fine. Okay, one more terminology will be there. CAP gap, that is used to find unmet needs of family planning. Unmet needs of family planning. Yes. All of you answering nicely. Just keep doing it. So you'll be actively involved. Okay, this is a CAP gap. It's a study, guys. Okay, unmet needs. FP means family planning. Antenatal period. Antenatal visits. Okay, fine. What is the minimum number of visits? Minimum according to our program is 4. Okay, what about WHO? How much it says? What is the ideal visits, guys? This and all you tell me. Minimum is 4. What about WHO says? What is the ideal number of visits? Okay. During this visit, what we will do? Okay, we will say that additionally she has to take plus 350 calories. Okay, fine. WHO says yes. WHO says 8. What about ideal number of visits, guys? Ideal number of visits will come roughly around 12 to 14 visits. Okay, around 12 to 14 will come around ideal number of visits. Okay, additional calorie of 350 calories required in pregnancy, guys. Next is what is IFA tablets? During antenatal visits we provide IFA tablets, 60 milligram of iron, elemental iron, 500 microgram of folic acid. How many days we have to provide, guys? Okay, 60 milligram of iron and 500 microgram of folic acid. How many days? Similarly, we'll provide DT vaccine 1, 2. 2 vaccine will provide. Okay, so 2 doses will provide, guys. Okay, so 2 doses will provide DT vaccine. DT vaccine, yes. You stick on to 350 calories, guys. Okay, don't get confused yourself. You stick on to 350 calories. Okay, fine. Okay, fine. So how many days we have to provide? We have to provide 180 days. 180 days. Okay, fine. You stick to what is there in your pack. Don't get confused in your exam. You keep it simple. Okay, 350 calories. Okay, fine. Next. 2 vaccines we have to provide. TD vaccines. 2 vaccines we have to provide. Okay. What is this? They are giving a tab, no? That was asked in your exam. A&M online. What is the name of the tab? Tab was given, that was asked in your exam. What is it? What is the name of it, guys? Okay, fine. You tell me the answer. Okay, these are the points we should do in the antenatal period. Okay, fine. In postnatal period, okay, in postnatal care, first 6 months additionally 600 calories, second 6 months, okay, additionally 520 calories. Excellent, all of you answering nicely. It's called as what? It's called as ANMOL. It's called as ANMOL. That was asked in your exam. First 6 months 600 calories, second 6 months 520 calories. IFA tablets again 180 days, guys. Okay, 180 days from delivery onwards. Okay, from delivery onwards you have to provide again 180 days. Okay, fine. So these are the points we should keep in the antenatal period as well as in the postnatal period. Any additional points I will discuss, guys. Okay, fine. Now, what is low birth weight? So tell me, what is low birth weight? What is low birth weight? How much weight is totally 360 days? Okay, before delivery 6 months, after delivery 6 months. Okay, fine. So what is low birth weight? Yes, what is low birth weight? What is term baby? Okay, term baby. What is very preterm? You tell me all these things. Very preterm. Okay. And for these low birth weight babies, we use an approach. What it's called as is less than 2.5 kg. Term baby is 37 to less than 42 weeks. Very preterm is 28 weeks to 32 weeks. We use an approach for this low birth weight. What is this called as? What is 𝐂𝐝𝐄𝐝 means what? What is 𝐂𝐝𝐄𝐝 means what? What is 𝐂𝐝𝐝? Yes, Kangaroo mother care. Okay, Kangaroo mother care. Okay, what you are going to do? Skin to skin positioning. Okay, skin to skin positioning, guys. Okay, skin to skin positioning. Exclusive breastfeeding, guys. Exclusive breastfeeding. Need not to give anything for these low birth weight babies. Put the baby on mother's chest. Dressers are available. As much time the mother can keep the baby. This we call it as Kangaroo mother care, skin to skin positioning. Okay, fine. Next. Indicators of malnutrition. Okay, I will write common things. I will write when height doubles. Okay, when height doubles. Okay, at which year height doubles. Okay, next is indicators of malnutrition. Wait for age. Wait for age. I'm not going each and every point, guys. What is important I'm discussing. Okay, fine. Wait for age. Second, wait for height. Okay. Third is height for age. Okay, now tell me when it doubles, guys. Early discharge. That is fine, fine. Skin to skin positioning, exclusive breastfeeding, early discharge, support in the community. Okay, fine. You're doing great. Now tell me height doubles in which month, guys? Height doubles in 4 years. Now tell me here, out of this, which one indicates acute malnutrition? Which one indicates chronic malnutrition? Okay, fine. Which one is wasting? Which one is stunting? These two indicates what? This one indicates what? Which one is wasting? Which one is stunting, guys? Yes, this is wasting. This is stunting, guys. Okay, wasting and stunting. Which one is acute, guys? Which one indicates acute malnutrition? Which one indicates chronic malnutrition? Tell me. Before that, I will write the criteria for SAM child. Severe acute malnutrition. This is asked recently also. Fine. Okay, fine. Which one indicates acute malnutrition, guys? Wait for age, wait for height. Yes, this indicates acute malnutrition. Okay, fine. This one indicates chronic malnutrition. Okay, chronic malnutrition. Fine. Now tell me here, out of this, what is the criteria for SAM child? What is the criteria for SAM child? Okay, recently also asked in your exam. Weight for height less than 3 standard deviation. 3 standard. 3 standard deviation. Weight for height less than 3 standard deviation. What else, guys? Come on, you can answer it. Yes. Mid-arm circumference. Mid-arm circumference less than 11.5 centimeters. 11.5 centimeters. Mid-arm circumference less than 11.5 centimeters. Age group between 6 months to 5 years. Okay. Presence of nutritional edema, guys. Edema, wasting. Okay, edema, wasting. If you are finding any one, then you are going to call it as SAM check. Okay, fine. All of you answering nicely. This is SAM check. Okay, SAM check. Okay, fine. Now, regarding breastfeeding, guys. Okay, I will fill it up. You tell me what it is. What is exclusive breastfeeding? How long? Last exam question. What is continued breastfeeding? This is how long? Okay, compared to breast milk, cow's milk is rich in. Cow's milk rich in what? Rich in. Okay, exclusive breastfeeding, how long, guys? You can keep on answering, guys. Okay, you can keep on answering. Exclusive breastfeeding is for 6 months. Continued breastfeeding for 2 years. Okay, 2 years, guys. Not 1 year. According to WHO, it's 2 years. Okay, cow's milk is rich in protein, energy, fat, calcium. When compared to breast milk, guys, continued breastfeeding is 2 years, guys. Okay, protein, energy, fat. Okay, fine. Okay, cow's breast milk is rich in what? Breast milk is rich in remaining all the things, guys. Remaining all things. Okay, key things: lactose, remaining everything. That is key point here is lactose, but remaining everything is rich in breast milk. Now, how many times more protein is there? Okay, protein in breast milk is 1.1 gram per 100 ml. Cow's it is 3.3 grams per 100 ml. So 3 times more protein, guys. In cow's milk contains 3 times more protein. Okay, 3 times more protein. Okay, fine. So hope this is clear. What is maternal mortality ratio? Fine. Numerator is maternal deaths. Denominator is live births. Only indicator multiplied with 1 lakh. Okay, fine. Only indicator multiplied with 1 lakh. Now tell me what is a maternal death. I'm not writing it. I'm telling you. Maternal death means a woman died during pregnancy, delivery, or within how many days of delivery? Within 42 days of delivery due to complications of pregnancy. Just keep that in mind. Last exam there was one problem was asked. Okay, and there was an RTA option was there. RTA will not be considered as a maternal. Maternal death means women died during pregnancy, delivery, or within 42 days due to complications of pregnancy. Okay, fine. Now 42 days due to complications of pregnancy. 3 most common cause. If you take direct, the most common cause is postpartum hemorrhage, sepsis. What is the most common indirect cause, guys? Okay, most common indirect cause. Indirect. What is the most common indirect cause? Direct you have written. You tell me what is the most common indirect cause. What is the target under SDG? Okay, how much is the target? Okay, excellent. All of you answering. Indirect is anemia, guys. Anemia. What is the target under SDG? Target is 70 per 1 lakh live births. Okay, 70 per 1 lakh live. This is maternal mortality ratio. Okay, fine. Okay, accidental null will not come here, guys. Accidental null will not come here. What is neonatal mortality rate? First I will write what is neonatal mortality rate. Neonatal mortality rate 0 to 28 days death. Neonate means 0 to 28 days. Denominator is live births multiplied by 1000. Remaining all the formulas is multiplied by 1000. The most common cause is low birth weight or prematurity. The most common cause is low birth weight or prematurity. Okay, is that fine? Most common cause. Okay, values and all, no need, guys. I have not seen recently what is the current value and all, they didn't ask. But what they ask is formulas, they ask with the problem. What is early neonatal mortality rate? I think again this was asked as a problem. If you are knowing the formula, then it is easy. Early neonatal deaths means what? Okay, numerator, denominator is live births. Tell me what is the numerator here. Early neonatal mortality rate. What is the late neonatal mortality rate? Okay, I am giving answer for you. Okay, work for you. Okay, late neonatal mortality rate. What comes here? Yes, what comes here? LB means live births multiplied by 1000. Yes. Early neonatal mortality, it is 0 to 7 days deaths. Okay, 0 to 7 days. What about late? Late is not 7, it's actually 8 to 28 days. 8 to 28 days. Okay, I think the early neonatal was asked as a problem for you. For early neonatal mortality rate also, the cause is low birth weight or prematurity. For late neonatal mortality, it is cause diarrhea and pneumonia, guys. For late neonatal is diarrhea and pneumonia. Late neonatal. What about infant mortality, guys? IMR means 0 to 1 year children death. Denominator is live births multiplied by 1000. This is also low birth weight or prematurity. A low birth weight or prematurity, it is considered as an indicator for what? NEET exam, it was asked, indicator for what? Come on guys, you can answer this. It's considered as an indicator for, yes, health status of the community, guys. Health status of the community. What is the current value? I have not seen in last 2-3 years. Okay, I am not writing it because time is very short. Indicator for health status of the community, guys. Okay, this is infant mortality rate, 0 to 1 years. What is perinatal deaths, guys? Perinatal deaths means it includes two things: stillbirths plus 0 to 7 days death. What is stillbirths means what, guys? Denominator is live births multiplied by 1000. What do you mean by stillbirths? What is stillbirths, guys? What is stillbirths? And it is considered as an indicator for what? Okay, it's an indicator for stillbirths means cross the period of viability. Viability is 28 weeks. Okay, 28 weeks to birth. Okay, in this time, if any deaths is happening after 28 weeks, okay, after 28 weeks, before 28 weeks means abortion. Okay, so this is an indicator for what, guys? This is an indicator for what? This is an indicator for pregnancy wastage, guys. Okay, this is an indicator for pregnancy wastage. Okay, an indicator for pregnancy wastage. This is perinatal mortality rate. Denominator is live birth. What is under 5 mortality rate? Numerator is under 5 deaths. Denominator is live births multiplied by 1000. For this also, the most common cause is low birth weight, and it is considered as an indicator for social development and well-being. Social development and well-being. Okay, you keep on answering, guys. Keep on answering. Okay, fine. Social development. Even if you know, just keep on answering so that it's easy for you to attach in the class. Okay, fine. This is under 5 mortality rate. What are the key points in school health? Key points. Maximum students. Okay, how much in a class, guys? Okay, maximum students. Space should be how much? Space should be how much? Type of desk. What is the type of desk the student should have? Doors and windows. You fill up the answers, guys. Okay, what percentage of the floor area? Doors and windows. And there should be one urinal should be there for how many students? Okay, one latrine should be there for how many students? Maximum number of students is how much, guys? 40. How much space should be there? The minimum 10 square feet space should be there. Okay, how much desk? What type of desk is? Minus desk. Doors and windows should be 25% of floor area. One urinal should be there for 60 students. One latrine should be there for 100 students. Okay, 100 students. One urinal should be there 60 students, and one latrine should be there for 100 students in the class. In the school, guys. Okay, fine. Next is ICDS. Okay, ICDS. Even if you don't know, just listen, no problem. Okay, Integrated Child Development Services. Okay, one Anganwadi will be there. One Anganwadi will be there for every 400 to 800 population. Yes, Anganwadi will be there. Main activity will happen in Anganwadi. Who are all the beneficiaries? The person who get benefits are 0 to 6 years, pregnant women, lactating women, not 0 to 4 years, 0 to 6 years, 0 to 6 years, 11 to 18 years. These are the beneficiaries, and women in reproductive age. Women in reproductive age. What are the benefits they will get? They will get supplementary nutrition, guys. Supplementary nutrition that will be provided 300 days in a year. They will provide supplementary nutrition. They should be providing food to the children. Children between 6 months to 6 years, daily 500 calories and 12 to 15 grams of protein. Calories, protein, guys. In pregnancy, in lactation and all, 600 calories, 18 to 20 grams of protein. This is supplementary nutrition. Second, immunization will happen in Anganwadi, guys. Third, what you are saying is non-formal preschool education. Non-formal preschool education for children between 3 to 6 years. That will be provided here. That will be provided here. Okay, fine. Supplementary nutrition, this will be provided for 300 days in a year, guys. 300 days in a year. Okay, fine. Growth monitoring also will happen in Anganwadi. Fine. Growth charts will happen in Anganwadi. Okay, immunization will happen in Anganwadi. Okay, let's go to the next topic, guys. Okay, hope this is clear. We completed 2 chapters. We have completed. One is demography, second is MCH. Both are important topic for your exams. Protein. What is the daily requirement, guys? Growth monitoring also will happen in Anganwadi. Okay, fine. What is the daily requirement? 0.83 per kg per day. That is the daily requirement. How will you measure the protein quantity? Protein quantity is measured by protein energy ratio, guys. How will you measure the protein quality, guys? The protein quality. Protein quality is measured by, yes, NPU. Net protein utilization. Which is the best protein quality wise? Which is the best one? Quality. Quality wise, the best one is, yes, it is eggs. Eggs are the best protein quality wise. Okay, because it has having nearly 100% level of NPU, guys. Net protein utilization. Okay, fine. What about fat? Saturated and unsaturated fat. Saturated, unsaturated. Saturated you will see in animal foods. This is plant oils. Exception is coconut oil. Next is palm oil. Which oil has the best unsaturated fatty acids? Which oil is the best one? Best oil, best. You tell me 1, 2. Okay, best oil. Okay, fine. And we have these essential fatty acids are there. Linoleic, and arachidonic. This deficiency causes a condition called as rhinoderma, guys. Rhinoderma. Which is the best oil, guys? Okay, best oil is it is safflower oil. Second is corn oil. These are the essential fatty acids. These are the essential fatty acids: linoleic, and arachidonic acid. The deficiency causes a condition called as rhinoderma, guys. Causes rhinoderma, toad skin. We call this as toad skin, guys. Toad skin. Next, what about vitamin A, guys? Vitamin A. What is the richest source? So richest, you tell me first one, second one. Okay, fine. Next is, what is the earliest symptom? Yesterday madam also probably would have said earliest sign. Yes. What is the earliest symptom, earliest sign? Okay. Next is, what is the treatment? If you are finding it, what is the treatment? Okay. So when you say that it's an important public health problem. Vitamin A is an important problem. When you use the early richest is what, guys? Nobody is writing. Yes. What is it? Yes. Cod, halibut, liver oil. Halibut, liver oil. Second is cod liver. Which is the earliest symptom? Earliest symptom is night blindness. Okay. Earliest sign is, what is the earliest sign? Conjunctival xerosis, dryness. Madam, yesterday the madam has written, I have seen that treatment is 0, 1, 14 days. Madam has written that dose and all. Madam has written. I have seen the notes also. Okay. The earliest symptom, night blindness. Earliest sign is conjunctival xerosis. Okay, fine. Okay, less than. Now tell me the answer, guys. What madam said yesterday. More than 1 year is 2 lakh international units. The question being asked in your exam. More than 1 year, less than 8 kg. What is the dose? Okay, more than 1 year child, but less than 8 kg. Okay, fine. You should do survey, guys. Survey children between 6 months to 6 year. Okay. Night blindness more than 1%. White hot spots more than 0.5%. Then it's an important public health problem. Okay. Total dose is 17 lakhs. Mukesh, that is for vaccination. We provide 9 doses, that is 17 lakh. Here I am talking here is, okay, normally more than 1 year, it's 2 lakh international units. But if the child is more than 1 year, but weight is less, child looks malnourished, then you should go with 1 lakh international units. Okay, it's there in yesterday's notes, guys. Okay, you can go through it. What about vitamin D, guys? I'll write in the top. For vitamin D, okay, again the richest source is halibut liver oil and cod liver oil. For vitamin D, its deficiency causes what? Deficiency in adults causes osteomalacia. What it causes in children, guys? What it causes in children? Okay, it causes children is rickets, guys. rickets. Okay, fine. Rickets. For vitamin D also the richest source is halibut liver oil and cod liver oil. Cod liver. B group of vitamins. Thiamine. What is the source for thiamine? Thiamine is present in rice and okay, this year it was asked in NEET exam. Okay, what is the source for thiamine? Rice and wheat, and they are given a thali. Chapati is there, rice is there, okay, curry is there. What is the source? They put an arrow mark. Okay, what is the deficiency it causes? Deficiency it causes beriberi. Second is Wernicke's encephalopathy. Wernicke's encephalopathy common in chronic alcoholics. This is thiamine, guys. Now tell me what is a deficiency? Yes, image based question only. Yes. Okay, so this is thiamine. Okay, next is what does niacin deficiency causes? What does niacin deficiency causes? What does folic acid deficiency causes? You tell me, guys. What does vitamin B12 deficiency causes? Yes, niacin deficiency causes. Yes, it causes pellagra, guys. Okay, in whom it is common? It is common in maize eating population. Okay, what is the name of the dermatitis? You will find. Okay, what is the name of the dermatitis? Okay, diarrhea, dementia, dermatitis. What is the name of the dermatitis? Yes, 4Ds will be there now. It is called as Kessel's necklace, guys. Okay, Kessel's necklace. What about folic acid, guys? Okay, what about folic acid deficiency causes? Folic acid deficiency. Okay, and what deficiency it causes? It causes is it fine now? I think it looks fine now. The source is so what is the source here and what it can cause? The source is what it can cause? Pernicious anemia, guys. Okay, this is only animal foods, guys. This is only animal foods. Okay, pernicious anemia and animal foods. Animal foods it causes. Right. What about vitamin C? Okay, what about vitamin C? Vitamin C. Okay, vitamin C it can cause. The richest source is amla, guys. Richest source is amla, and it can cause a condition called as scurvy. Okay. Bleeding gums, guys. Bleeding gums. A delayed wound healing will be bleeding gums and delayed wound healing. Delayed wound healing. So we have seen this one scurvy. We have seen vitamin C. Now tell me. Okay, fine. What is this neuroletherism? Okay, neuroletherism is due to consumption of what? Is due to consumption of kesari dal. Now tell me what is the chemical that present can cause this. Second, it comes in 5 stages. Okay, it comes in 5 stages. What is the chemical that is present? No stick stage, latent, no stick, 1 stick, 2 stick stage it can cause. Okay, now which vitamin can use for prophylaxis, guys? Which vitamin? Which vitamin for prophylaxis? Yes, you have answered nicely. BOA, beta oxalyl amino alanine, guys. Okay, BOA means beta oxalyl amino alanine. Okay, which vitamin is used, guys, in the prophylaxis? All our exam question, that is vitamin C. Okay, vitamin C used in the prophylaxis. Removal of toxin. How to remove the toxin? Removal of toxin. What are the methods available, guys, for removal of toxin? What are the methods available? This removal of toxin. What are the two methods available? Removal of toxin can be done by, one is parboiling method. Second is steeping method. Parboiling and steeping. Removal of toxin. What about iodine? For an adult, the requirement is, A means adult, 150 micrograms. Pregnancy, it is 250. Lactation, it is 280 micrograms. 280 micrograms. It causes, adults it causes goiter. Children it causes cretinism, guys. Children it causes cretinism. Okay. Iodization of salt is mandatory. Iodization of salt. How much iodine should be there in the salt? How much iodine? Iodine, how much should be there at production level? Okay. Second is how much it should be there at consumer level. Okay, fine. How much should be there at production level? How much should be there at consumer level? Okay. What is the symbol of iodization? Symbol of iodization. Okay, you tell me answers for this. Okay, fine. All of you are writing good. That is 30 ppm at production level and 15 ppm should be there at consumer level. What is the symbol of iodization, guys? What is the symbol of iodization? The symbol is smiling sun symbol, guys. Okay, symbol is smiling sun symbol. Okay, symbol is smiling sun symbol. Iodization. What about fluorine? The fluorine RDA is 0.5 to 0.8, 0.5 to 0.8 milligram, guys. 0.5 to 0.8 milligram per liter of water. Okay, if it is more than 1.5 milligram, it affects dental fluorosis. Which teeth will be commonly affected, guys? Which teeth will be commonly affected? 3 to 6 milligram, it can cause skeletal fluorosis. Okay, more than 10 milligram, it can cause crippling fluorosis. Now tell me which teeth will be commonly affected, guys. Which teeth? Okay, the teeth that is commonly affected is upper incisors. Okay, when the exposure is required? Exposure is required during exposure in the first 7 years to get fluorosis. If we go and drink water, we won't get now. Okay, exposure is required during the first 7 years of life. Now, what is the name of the technique that removes the fluorine, guys? What is the name of the technique? Yes, the technique that removes the fluorine is called as, what is the chemical that is added? Okay, what is the chemical that is added in the water to remove the fluorine? Alum plus lime. Okay, alum plus lime. Next. What are the food toxicants, guys? The first one is aflatoxicosis. Aflatoxicosis because of groundnuts, guys. Groundnuts, this infested with this fungi called as Aspergillus flavus and parasitic. Flavus and parasitic. These are the fungus. What type of fungus is this, guys? Okay, is it a field fungus? Okay, and is it a storage fungus? The second one is ergotism, commonly affected in bajra plant. Bajra is a fungus is common affected called as claviceps. Which one out of this is a field fungus? Which one is actually a storage fungus? This one is storage, guys. Storage. This one is field fungus. How will you remove these infested grains of this bajra? Okay, it can be removed by infested grains removed by floating in 20% of salt water. Infested grains we can remove it, guys. Okay, by floating in 20% of salt water. Okay, these all are your exam questions, guys. Okay, I'm not talking anything beyond that. Okay, it's needed for your level. Not even INCT, I'm not going there. What is epidemic dropsy? Epidemic dropsy. What is the contamination happens? What is the name of the chemical, guys? You tell me the name of the chemical. Mustard oil with arginamone oil. There is a chemical comes here, guys. What is the name of the chemical? The name of the chemical is toxin. Sanguinary, guys. Sanguinary. This is epidemic dropsy. Okay. Patient will have glaucoma, diarrhea, okay, pedal edema, cardiac failure. Okay, what is the test that can identify it? Test. One is nitric acid test. Second is paper chromatography. Out of this, which is the best one, guys? This year it was asked in NEET exam. Okay, this year it was asked NEET exam. Which is the best one out of these two? Nitric acid and paper chromatography. Which is the best one? Fourth one. The fourth one is epidemic dropsy. We have seen. Next is endemic ascites, guys. Endemic ascites. Okay, this one is the best one, guys. Paper chromatography is the most sensitive test. Endemic ascites happens because of what? Endemic ascites happens because of pyrrolizidine alkaloids. Pyrrolizidine alkaloids. Endemic ascites because of pyrrolizidine alkaloids. What about midday meals? 1/3 of energy, whatever food they are providing, half of protein requirement. How many days? ICDS we said 300 days, guys. Okay. How many days midday meal should be provided? Midday meal should be provided. How many days? Number of days, guys. Midday meal should be 250 days. ICDS should be there for 300 days. Midday meal should be there for 250 days. We'll go to the next topic, guys. Okay, we'll go to the next topic. Concept of health and disease. This was a question this year NEET exam. Okay, what comes in PQ alignment? ILL1. Infant mortality rate, literacy rate, life expectancy at 1 year. Scale 0 to 100. This is PQL, I guess. This is PQL. Physical quality of life index. So according to this, no income, guys. What about HDA? Now tell me what comes in HDA. HDA, life expectancy at birth. Second, per capita income. Third is knowledge. Knowledge in terms of mean years of schooling, guys. Mean years of schooling, expected years of schooling. Now tell me, these are the things. Human Development Index. Which country is taken as standards for this one, guys? Which is taken as standards for life expectancy at birth? Per capita, okay, which is taken as standard. Scale is between, yes, answer it, guys, 0 to 1. India comes in medium, guys. India comes in medium. Okay, fine. Which country is taken as standards in HDA, life expectancy? Yes, life expectancy, it is what? Japan. What about per capita income, guys? Okay, income per person, not check one, not check. Okay, per capita income per person. Who is the richest country? Okay, fine. Qatar. Okay, Qatar. Okay, Qatar is the in per capita income is considered as the richest one. Okay, fine. India comes in medium, guys. India medium with a value of 0.645. Just stick on to what is there in the textbook of PARC, guys. Okay, for you that's okay. PARC. I'm telling what is there in PARC. What is DALI? DALI means disability adjusted life years. It indicates disease burden, indicates years of life lost plus years of life lived with disability. I'm not writing the full form, guys. Years of life lost plus years of life lived with disability. Okay, so it include both. Okay, fine. This is called as, it measures both premature death as well as how many years they lived with disability. This concept was asked multiple times. One DALI corresponds to 1 year of healthy life lost, guys. Okay, fine. Healthy life lost. These are morbidity indicators. Yes. As you are saying, these are morbidity indicators. One DALI corresponds to 1 year of healthy life lost. What is QALY means what? Quality adjusted life years. Quality adjusted life years. Okay, quality adjusted life years. This is number of years of life added by intervention. Okay, added by intervention. Okay, how many years the person was able to live extra because of your treatment? How many years? Okay, how many years the person was able to live extra because of your treatment? Then it becomes QALY. Okay, QALY. So because of your treatment they live more, 10 years more, then it becomes QALY. Okay, number of years of life added by intervention, guys. Okay, fine. Disease causation theory. Who gave germ theory, guys? One is germ theory. Next is, who gave the concept of germ theory? Next is epidemiological triad. Okay, germ theory, who gave the concept? Epidemiological triad means 3 things are required: agent, host, environment. Germ theory is given by Louis Pasteur, guys. Okay, microinvasive study. Germ theory is given by Louis Pasteur. Germ theory is also called as biomedical concept of health. Germ theory is also called as biomedical concept of health. So third one. What is advanced triangle of epidemiology? A advanced triangle of epidemiology. In advanced triangle, 3 things are required, guys. Okay, fine. In advanced, not triangle, time also you have added. Okay, what comes here? Instead of agent factors, they say it as causative factors. Instead of host, they say that group or population characteristics. A group or population characteristic, not just physical environment, even social factors, cultural factors all contribute. Okay, recently asked only. This is causative factor, not agent. It is causative factors. Causative factors. This we call it as advanced triangle of epidemiology. Advanced triangle of epidemiology. Okay, fine. Now tell me what is primordial prevention, what is primary prevention, guys. Okay, what is primordial, what is primary? Before risk factors, before onset of disease. Okay, fine. Tell me which one is primordial, which one is primary here, guys. Okay, which one is primordial, which one is primary? Before risk factors, this is primordial prevention. Before the onset of disease, this is primary prevention. Okay, fine. Give me examples of primary prevention. Give me examples of primary prevention. Examples, guys. Okay. Examples. Give me examples. Vaccination. Okay, fine. What else? Vaccination can come. What else? Health education. Okay, health education. Before weight reduction. Before disease comes, if you do. Okay, that comes in. Okay, so primary prevention. Primary prevention. Next is a vaccination, chemoprophylaxis, condom. All are examples for primary prevention. Okay, before the disease onset, we are doing that. Maybe risk factors may be there, but disease is not there. What about secondary prevention? What is secondary prevention? What is secondary prevention? Secondary prevention is, okay, action that halts progression. That means disease have started, you are trying to stop the disease at an early stage. Give me examples. Give me examples, guys. Okay, give me action that halts the progression. Any screening tool, guys. Any screening will come here. Pap smear. Okay, acid fast bacilli, fasting blood sugar, any screening, any checkups, any check. Excellent comes in secondary prevention. Okay, fine. Tertiary prevention, I'll write here, guys. Okay, tertiary prevention, I'll write here. Okay, tertiary prevention, you can focus like this. Tertiary prevention. What is tertiary prevention? Tertiary prevention, disease, impairment, disability, handicap. Okay, fine. Now tell me here, what is impairment means what here, guys? What is impairment means what? Just listen to me, guys. Okay, I'll give you a lot of content. I will give you. Breast self-examination comes in secondary prevention. What is impairment means what? Maybe loss of anatomical structure or physiological or psychological. It may be anything, guys. Okay, the person lost foot, not able to hear, okay, or maybe psychological problem. What is disability? Okay, not able to do a normal activity, guys. Not able to fulfill social role, guys. Here it needs normal activity, here it's social role, here it may be anything, guys. Okay, anatomical, physiological or psychological. Okay, so somebody lost leg, what it becomes, guys? Lost leg is what? Is it anatomical, physiological or psychological? Okay, fine. Not able to walk, and unemployed, guys. Okay, unemployed. Okay, fine. That is impairment. It's anatomical, guys. Okay, going to job is a social norm which the person was not able to do it, guys. Okay, all these things comes in tertiary prevention, guys. Okay, all these things comes in tertiary prevention. What is the difference between elimination and eradication? What is elimination? What is eradication? Come on, tell me. What is the disease we have eradicated? Extermination of infectious agent. Okay, extermination of infectious agent. Okay, it is at a global level. Only disease we have eradicated. What is that? Okay, yes, smallpox. Global level, smallpox. Okay, what is elimination? Elimination means prevention of chain of transmission. Prevention of chain of transmission. We can say that India has recently, what India has eliminated? Guinea worm, leprosy, yaws, guinea worm, leprosy, neonatal tetanus. Recently we have said that we have eliminated trachoma, guys. Potential question for you guys. Okay, trachoma. TB elimination is the goal, which may not happen, but recently we have eliminated trachoma, guys. Trachoma. Okay, keep that in mind. This is elimination, eradication, guys. This is elimination and eradication. Okay, what is this ICD? International Classification of Disease Level. How many chapters it has? Okay, ICD 11 has 26 chapters, guys. The previous version, ICD 10, has 21 chapters. Okay, the type of coding which we use is called as alphanumerical coding. Alphanumerical coding. Okay, fine. Conditions not showing iceberg phenomena. Tell me conditions. No iceberg phenomena. Come on, guys. Recently asked in NEET exam. Which conditions? No iceberg phenomena. That means whenever they are coming, that is always symptomatic, guys. Okay, always symptomatic. Which conditions? You can remember like this, guys. Measles, MTR. Measles, tetanus and rabies. Okay, they are always symptomatic. Okay, always symptomatic. Okay, iceberg phenomena means, okay, that means there is huge amount of asymptomatic cases in the community. Okay, like for example, take influenza. Influenza has lot of asymptomatic cases will be there. Like COVID, you would have seen. Okay, lot of asymptomatic cases. Okay, fine. But these conditions, no iceberg phenomena. That means, okay, that means whenever the disease comes, it's always symptomatic. Always symptomatic. Are we clear, guys? Able to follow? Fine. We'll continue, guys. Okay, fine. What is crude death rate? Formulas we will see. Okay, crude death rate formula is number of deaths. Probably hope total my time is 3 hours, guys. 3 hours. I don't know how much time. Yeah, I should finish before 3 hours. This is my target. Let's see. Number of deaths. Okay, number of deaths a particular year. For example, 2023 by mid-year population. Mid-year population. This corresponds to which time, guys? Mid-year population. Mid-year population corresponds to 1st of July. 1st of July. Mid-year population corresponds to 1st of July. Okay, fine. Census population. Census population corresponds to what? Second one is, what is proportional mortality rate? Okay, recently asked in your exam. Proportional mortality rate is, for example, we will take cholera. Number of cholera deaths in a particular year, time period, by, okay, total deaths multiplied by 100. This is proportional mortality rate, guys. This is proportional mortality. Census date corresponds to census date corresponds to 1st of March. Proportional mortality rate, number of cholera deaths by total deaths. Okay, fine. This is proportional mortality rate. This one indicates disease burden, guys. One more we have seen as disease burden just now. What is it, the other one? Before this, we have seen one more as disease burden. Can you remember and tell me what is the other one, guys? Disease burden. What is case fatality rate? COVID we will take, for example, number of COVID deaths by total cases of COVID, guys. Total COVID cases multiplied by 100. This is case fatality rate. Expect problems in your exams, okay? Okay, what does this indicate? This indicates virulence or killing power, guys. Killing power. Tell me a condition which is having 100% case fatality rate. 100%. Disease burden, what we previously discussed is DALI. Okay, killing power, which one is having 100%? 100% case fatality rate. Which one indicates 100% case fatality rate? Thousand cases and 100 deaths are reported, guys. What is the case fatality rate, guys? Okay, 1000 cases and 100 deaths were reported. What is this? 100% death is seen in which one? That is rabies. 100% that is rabies, guys. Can you tell me here? Okay, 1000 cases and 100 deaths. 100 divided by 1000 multiplied by 100. That is 10%. Is 10%. Okay, small problems you expect it. I think they are giving calculator also. Just be ready for it. Okay, so 100 by 1000. Fine. What is standardized mortality ratio? SMR, guys. You read the ratio. What is standardized mortality ratio? SMR. Okay, this problem was also asked. Okay, it is formula is observed deaths by expected deaths multiplied by 100. This is an indirect standardization. This is a method for indirect standardization. Okay, indirect standardization. Okay, indirect standardization. Now tell me here, indirect standardization. Okay, observed deaths is expected deaths is around 4 per 1000. Observed is around 6 per 1000. Okay, can you calculate and tell me, guys, how much is the SMR, standardized mortality ratio? How much it is? How much is the standardized mortality ratio? Yes, 6 by 4 multiplied by 100. That is 150%, guys. 150%. I think it's 150 only, I think. Okay, 150%. 150%. So I make clear, this we call it as SMR. Similar problem was asked in your exams. Similar problems. Standardized mortality ratio. What is secondary attack rate? Secondary attack rate is a measure of communicability. Look here, what is secondary attack rate? Number of new cases developing within one incubation period of exposure. Denominator is total number of susceptible cases among exposed multiplied by 100. Okay, so number of new cases developing within one incubation period of exposure. Denominator is total number of susceptible cases among exposed. For example, you take one particular class, there are 51 children are there. Out of these 51 children, 10 were vaccinated for measles. Among them, one child developed measles. Okay. Following exposure to this child, 10 more children developed. Now tell me what comes in numerator, what comes in denominator. Okay, fine. There are totally 51 children are there, 10 were vaccinated. Okay, one child developed measles. Measles. Following exposure to that child, 10 more children develop measles. Can you tell me what comes in numerator, what comes in denominator? Come on, I need answers, guys. I need answers. Yes. Okay. Because it's a problem. Since I'm seeing problem in your exam, I'm just putting some effort. So this, out of these 51 children, 10 are vaccinated, guys. Okay, they are not susceptible. Okay, fine. So how many new cases developed? 10. Okay, how many were susceptible? Total number of susceptible out of 51 children. Okay, already 10 has vaccinated. That means remaining 41. Out of 41, one child has already developed measles. So total number of susceptible children is how much? 40 multiplied by 100, 25%. Are you guys able to follow? Suddenly answers are not coming. What happened? Okay, went for dinner. So 51 children. One child is 10 children are vaccinated, remaining 41 children. Out of them, one child developed measles. Okay. So the primary case we have to exclude both from numerator as well as from denominator, guys. Okay, fine. 10 by 40. What is incidence and what is prevalence, guys? What is incidence and prevalence? Incidence means number of new cases in a particular time period. Denominator is total number of susceptible population. Population at risk, you write, not susceptible. Population at risk. Population at risk multiplied by. Which study will give you incidence, guys? Which study will give you incidence? A cohort study, longitudinal study. Cohort and longitudinal study will give you incidence. Now what about prevalence, guys? Now tell me prevalence. Prevalence means which study, which one will give you prevalence? Prevalence means number of old plus new cases divided by population multiplied by 100. This is given by which study? Cross-sectional study. Cross-sectional study. Prevalence, okay. Prevalence is, okay, old plus new cases, cross-sectional study. Okay, fine. Not case control, guys. Cross-sectional study. Okay. Now, what is the relationship between prevalence and incidence? Prevalence is equal to incidence into duration. Okay, more the duration, more the prevalence. Less the duration, less the prevalence. Less the prevalence. Prevalence means both old and new case. But what happens between incidence and duration? Incidence is not affected by duration. Incidence not affected. Incidence not affected. Not affected. Okay? The relationship between prevalence and duration is that more the duration, more the prevalence. And incidence is not affected by duration, number of new cases. Okay, fine. Next, let us go into case control study, guys. Okay, are you guys able to follow this epidemiology little bit more concept oriented? Yes or no? Cohort for incidence, that is fine. Are you guys able to follow this? Yes or no? Fine. I think you are following. What about case control study, guys? Okay, case control study, from where to where it goes? It goes from case control study outcome to exposure, guys. Okay, outcome to exposure. Fine, fine. Okay, you want to go slowly. We are going slowly only. Okay, fine. So outcome to exposure. Case control study. Okay, it starts from outcome to exposure. Okay, so I want to do a study between smoking and lung cancer. Okay, I will start from people with lung cancer. There I will check whether they are exposed or not. Smoking. This is called as case control study. Okay, fine. What is this? Population, select cases, controls, then you ask their exposure, exposed, not exposed, exposed, not exposed. Okay, fine. So population, you select cases and controls, then you ask the exposure. Okay, so who is a case? Case means people with disease. Okay, people with disease. Who's a control? Control means people without this. At least one question is coming, guys. Study design, at least you are going to get one question. From the population, you select cases and controls. Then you are going to ask the exposure. Okay, cases means people with disease. Controls means people without disease. What will you find here? You will find here odds ratio. Okay, the formula for odds ratio is AD by B. AD by BC. Okay, what is the interpretation of odds ratio? What is the interpretation? Odds ratio equal to 1 means no association between exposure and the outcome, guys. Odds ratio. Okay, odds ratio more than 1, positive association between exposure and the outcome. Okay, odds ratio less than 1 means negative association. Negative association. So this is the formula. Okay, what is the other name for odds ratio, guys? Asked in the NEET exam. Equal to other name. Odds ratio is also called as what? Equal to 1, no association. More than 1 positive, less than 1 negative. Okay, that means it starts from outcome to exposure. Okay, outcome to exposure. The other name for odds ratio is cross product ratio, guys. Okay, cross product ratio. Okay, fine. Cross product ratio. What about cohort study, guys? Cohort study starts from exposure to outcome. Okay, this is the population. You select people without disease. Then you identify exposed people. For smoking and lung cancer, you select people who are smokers and non-smokers. You follow them over a period of time. Some will develop disease, no disease. D means disease, ND means no disease. Okay, some will develop disease, others no disease. Population, people without disease. Okay, fine. Okay, you are starting from smoking to lung cancer. It takes lot of time. What is the advantage? It's also called as prospective study. What is the advantage? Okay, prospective study. What is the advantage is you can find incidence. Okay, you can find incidence can be found. Incidence means number of new cases. Okay, incidence can be found. You can find incidence. Incidence means number of new cases. This is prospective study. This is prospective study. Next. Okay. By doing the prospective study, we can find incidence. Incidence we can find, guys. That is the biggest advantage. We cannot find in a case control study. We cannot find. Now, based on incidence, we can calculate certain things. One is, what is the relative risk? Relative risk, what is the time is the disadvantage, guys. Okay. Some famous cohort studies are there. First one is Framingham Heart Study. a Framingham heart study. Second is Dolls and Hill study. These are two famous cohort studies. These are two famous cohort studies. Okay, fine. Now, what is the relative risk? What is the formula for relative risk? Relative risk is, I will write in short form, guys. Okay, incidence among exposed divided by incidence among non-exposed. Non-exposed. Incidence among exposed by incidence among non-exposed. What is the interpretation? It is same as odds ratio. Okay, what do you mean by that? Equal to 1, no association, more than 1, positive association, less than 1 means negative. As interpretation was asked in the last exam, guys. Okay, I think relative risk was asked, okay, in the last exam. Okay, fine. Equal to 1, no association, more than 1 positive, less than 1 negative association. Okay, fine. Okay, then what does it mean? Smoking lung cancer 5. What does it mean? Positive association. Smokers are 5 times more likely to develop lung cancer. Lung cancer. Fine. Next is attributable risk. AR I will write. The formula is incidence among exposed minus incidence among non-exposed by incidence among exposed multiplied by 100. Short form I have written. It comes in percentage. It comes in percentage. What does it mean? It tells you how much percentage of disease, okay, percentage of disease attributed to the exposure among exposed. Okay, how much percentage of disease attributed to the exposure among exposed. Suppose smoking and lung cancer comes as 90%. What does it mean? It means 90% of lung cancer among smokers is because of smoking. Am I clear? 90% of lung cancer among smokers because of smoking. This is attributable risk. Formulas are important. Next. What are the points? Okay, so we have these clinical trials are there. What is the use of phase 1? Tell me, guys. What is phase 3 is what? What is phase 4 is what? Okay, answer it, guys. Answer it. Okay, answer it. Phase 1. Phase 1 indicates what? Phase 3 and phase 4. Okay, fine. Yes, you can answer. Phase 1. Use of in clinical phase 1 is safety. Maximal tolerable dose. Safety and maximal tolerable dose. Phase 3 is RCT. After RCT, the drug will come into market. In market, you will do the phase 4, that is called as post-marketing surveillance. Okay, post-marketing surveillance. Fine. Phase 1, safety of the drug. Phase 3 is RCT. RCT means randomized control trial. After RCT will come into market. Okay. Then in the market, you will do the post-marketing surveillance case. Okay, fine. So this is clear, right? Now, the most important part in RCT is this randomization. Okay, what is the advantage of randomization? Eliminates selection bias. It eliminates selection bias. What is double-blinded study? Double-blinded RCT means, okay, patient, doctor, both does not, okay, who belong to treatment group, who belong to control group. Triple-blinded study means what? Triple-blinded means patient, doctor, and analyzer. All three does not know. Now can you tell me out of this which is the best one, which is the most commonly used one, guys? Which is the best one, which is the most commonly used one? Best one is triple is the best. Double blinding is the most commonly used, guys. Most commonly used. Triple blinding is the best one, and double blinding is the most commonly used, guys. Okay, most commonly used. What is epidemic? What is endemic, guys? Endemic means constant presence of disease. That is endemic. What is epidemic means unusual increase in number of cases, guys. Unusual increase in number of cases. That is epidemic, guys. Constant presence of disease is endemic, guys. Endemic. What is pandemic? Pandemic means, what is pandemic, guys? Pandemic means what? Two or more than two. More than two WHO regions are affected, guys. More than two WHO regions. Okay, Asia, Europe, okay, North America, South America, like that we have. Okay, so if two or more than two WHO regions are affected, we are going to call it as pandemic. What was the last pandemic? COVID. What was the previous one before COVID? Okay, which one comes before COVID? Two or more. Okay, two or more. Okay, which one is before COVID, guys? Before COVID, what we had is H1N1, guys. H1N1 was the pandemic. What is isolation and how long we do the isolation? Isolation we do in the patients. Isolation is done during the period of communicability. Communicability. Okay, period of communicability. Okay, for measles, the period of communicability is 4 days before the rash, 4 days after the rash. At that time, you have to do the isolation for the patients. Quarantine. Okay, quarantine. This year it was asked in the NEET exam. Exposed, guys. Exposed people, you will do quarantine. Now tell me how long will you do the quarantine? How long will you do the quarantine? That was asked in the NEET exam this year. How long? Quarantine is maximum incubation period. They given a condition having 5 to 15 days is the incubation period. Now tell me how long the quarantine will be done. Similar examples was given, guys. Okay, how long the quarantine will be done? Quarantine we should do it for 15 days. 15 days. Okay, fine. Maximum incubation period. What is a index case and what is a primary case? During an epidemic, the first case in the community, a first case in the community is called as primary case. Okay, during outbreak is happening, whichever the first case that has come to this community is called as primary case. What is index case? First case came to the health provider, guys. First case, that we call it as index case. The first case that came to the health provider. Sometimes primary case can also be what? An index case. Can also be an index case. What is generation time? Generation time. This year asked in NEET exam. What is generation time? Generation time. Generation time is the time between entry of agent to maximum infectivity. Suppose the organism is entering into me today. After how many days I will be maximum infectious to others? This we call it as generation time, and it was asked this year NEET exam. Okay, the organism is entering into me. After how many days I will be maximum infectious to others? That is generation time. What is serial interval? The time between first case, the second case. This time is called as serial interval. Okay, this time is called as serial interval. All look smaller, but these are potential questions are commonly asked in your exams. Okay, fine. Next, what is this one, guys? What is median incubation period? Okay, the time between agent entry to 50% of cases to happen. 50% of cases to happen during an outbreak, guys. Okay, during an outbreak. The time between the agent entry to 50% of cases to happen, guys. 50% of cases to happen. This we call it as, this time is called as median incubation period. Median incubation period. The time between agent entry to 50% of cases to happen, guys. 50% of cases. Are we clear, guys? Now 2 booklets. You have not even completed the first one. Now, what are the key points here? Okay, what are the key points here? We'll go with chicken pox, guys. Go with chicken pox. Okay, what are the key points in chicken pox? Let alone we will. Okay, I will write this key point. POC means period of communicability. Period of communicability. 1 to 2 days before, 4 to 5 days after, guys. What is the type of rash you will find here, guys? Rash. Okay, what is very characteristic? Okay, what is very characteristic? Very characteristic, 2 points you tell me. One is dewdrop appearance will be there. What is the other very characteristic features of chickenpox rash, guys? Okay, fine. That is your answer. Next is, what is a late complication? Late complication is herpes zoster, guys. Late complication is herpes zoster. And avoids, we have a vaccine available. Vaccine is 𝐒𝐿KA strain, guys. 𝐒𝐿KA strain. Okay, why we should avoid salicylates, guys? Okay, avoid salicylates following the vaccine. Avoid salicylates for 6 weeks. Why? What it can cause, guys? Okay, what it can cause? Okay, avoid salicylates. Why? I will answer that. Yes, what you are answering, right? Excellent. It causes pleomorphism. Pleomorphism. Avoid salicylates for 6 weeks. Okay, why? What it causes? It causes a condition called as Ray's syndrome. It causes a condition called as Ray's syndrome. Ray's syndrome. Measles. Measles. What is period of communicability? Anyone, if you know, answer it. What is the feature? Okay, what is the feature? Okay, what is the pathognomonic feature? What is that pathognomonic feature? There you will find. What is the most common complication? Okay, what is the most dangerous complication? Okay, you will find here. Okay, fine. What is the most common complication? The period of communicability, I said, already told you, 4 days before. Okay, 4 days after. What is the pathognomonic feature, guys? What is the pathognomonic feature you will find in measles? Okay, fine. Pathognomonic feature, what you will find is Koplik spots, guys. Koplik spots. Okay, Koplik spots you will see in the buccal mucosa. Okay, buccal mucosa. When will you find? You will find 1 to 2 days before rash, guys. Before rash. What type of rash you will get? Maculopapular rash. What is the most common complication? Yes, it is otitis media. What is the most dangerous complication? pneumonia, guys. What is the vaccine strain, guys? What is the name of the vaccine strain which we use for measles? Okay, 9 months will provide. What is the name of the vaccine strain? The name of the vaccine strain is what? Edmonston Zagreb strain, guys. Edmonston Zagreb strain. Fine, next. Rubella, what is the strain? MR vaccine will provide. What is the name of the strain for rubella? RA27/3. As such, we are not worried about rubella. Why we are worried about rubella? CRS, guys. A congenital rubella syndrome. Okay, what are the components of congenital rubella syndrome? You tell me. I think yesterday classes are over. What are the components of congenital rubella syndrome? Mother is in which trimester? Gestation period. A gestation period. Okay, 0 to 16 weeks. What happens? 16 to 20 weeks means what happens? More than 20 weeks. Okay, fine. Now, congenital rubella syndrome, let us see here. Congenital rubella syndrome is sensory neural hearing loss, cataract. Third is PDA, guys, patent ductus arteriosus. 0 to 16 weeks. 0 to 16 weeks. Okay, fine. Can you tell me 0 to 16 weeks? 0 to 16 weeks means the baby has the chance of CRS. 16 to 20 weeks, only deafness, guys. Mother more than 20 weeks means no abnormality. Mother gestation period of more than 20 weeks means no abnormality. Okay, fine. More than 20 weeks, no abnormality. What about influenza? Influenza, the main reservoir, birds and pigs, guys. Main reservoir, that is birds and pigs. We have this H1N1, hemagglutinin, and N means neuraminidase. Okay, N means neuraminidase. Okay, main. Okay, asymptomatic disease is common, guys. Asymptomatics common. What is the drug of choice, guys? What is the drug of choice for this condition? What is the drug of choice? Influenza means what is the drug you will provide? Okay, and for this condition, vaccine prepared every year based on new strain, guys. New strain. It causes a condition called as antigenic shift. Okay, and suddenly you will get outbreaks, suddenly you will get pandemics, and all you will get. What is the drug of choice? Yes, the drug of choice is oseltamivir. Okay, oseltamivir, vaccine prepared every year based on new strain, guys. Okay, what about bird flu, guys? Bird flu. Bird flu, avian influenza, it is H5N1 or H7N9. Again, treatment is oseltamivir. For humans, it is again oseltamivir. What you are writing is correct. That is Tamiflu. Tamiflu is a trade name. Oseltamivir is the drug, guys. Okay, fine. Diphtheria. Corynebacterium diphtheria is the agent. Okay, what is the source for it? Source is a carriers, guys. Source is a carriers. First time I am saying carriers. And immunization does not prevent carrier status. Okay, because what we are giving is toxoid. Toxoid only we are giving. That acts only on the toxin. Immunization does not prevent carrier. Okay, fine. Patient with the membrane and the bull neck appearance. What is the treatment, guys? Patient with membrane in the tonsil area plus bull neck appearance. Bull neck appearance. What is the treatment, guys? What is the treatment? Okay, if you are seeing this, you should start them with penicillin, penicillin plus antitoxin. What is the treatment for caries? For caries, what is the drug of choice, guys? Okay, for caries, the drug of choice is erythromycin, guys. Caries, the drug of choice is erythromycin. Vaccine will not be useful, guys. Okay, you have to start with for penicillin plus antitoxin. Penicillin plus antitoxin. Caries, the drug of choice is erythromycin. Erythromycin. We'll continue, guys. Next condition. We'll go into TB. Try to finish in 1 hour, guys. Go into the second book. TB. TB is what we should know. Okay, we have this program is NTP, National TB Elimination Program. Goal is to eliminate by 2025. Remaining all are 2030, but this is 2025. We have this 𝐒𝐿𝐻 is there. Online portal, guys. Online portal, that is 𝐒𝐿𝐻. Okay, what is the investigation you want to do? Okay, anybody is having cough, fever, what is the investigation you will do? We'll do 2 sputum plus chest x-ray. It is inconclusive, go for what is the investigation you want to go, guys, here? Okay, patient having 2 sputum chest x-ray, inconclusive. Okay, what is the investigation you want to do? If it is positive, the treatment is, what is the treatment? What is the treatment, guys? What is the treatment? If it is inconclusive, we should go for CB NAT. CB NAT, fine. What is the treatment, guys? What is the treatment? If you are seeing a case of TB, what is the treatment? 2HRZE plus 4HRE. That is the treatment, guys. Okay, fine. And we have this 99 dots for monitoring. 99 dots is associated with TB. And we have this 𝐒𝐿𝐻 portion Yojana. 𝐒𝐿𝐻 portion Yojana. 𝐒𝐿𝐻 portion Yojana. They are providing recently 1,000 rupees per month during treatment time. 1,000 rupees per month they are providing during treatment time. Okay, during treatment. Recently they are giving MDR TB. What is MDR TB? What is pre-XDR TB? MDR means HR resistance. Pre-XDR means HR plus fluoroquinolone resistance. Fluoroquinolone resistance. Okay, HR resistance. Pre-XDR means HR plus fluoroquinolone resistance. MDR, recently they are given the drug treatment called as BPOM. Pre-XDR it is BPOL. This is the regimen that is recently given, guys. Okay, recently it's given. Okay, B means what? Didaquilin, retomanid, dinizolid. This one is moxifloxacin. MOXIE guys. B-PAL means MOXIE will not come. Bedaquiline, Pretomanid, okay, linezolid or MOXIE. Recently, last 2 months it's there. Okay, for MDR, pre-XDR is B-PAL. Okay, may be asked. Okay, a worst case scenario guys. Worst case scenario may be asked in your exam. So just remember MDR means B-PAL. At least you remember MDR, B-PAL. B-PAL. B-PAL it's okay. At least you remember MDR, B-PAL you remember. Polio. Tablet strength and all not needed, man. Okay, don't complicate yourself. Keep it simple. Keep it simple. Okay, fine. Now, polio, what it can cause? Type 1 wild virus. Okay, wild virus. Type 2 is associated with VDPVs. Type 3 is VDPVs means what? Vaccine derived polio virus. VAP means vaccine associated paralytic polio. Vaccine associated paralytic polio. So VDPV is vaccine derived, vaccine associated paralytic polio. Now, here, what is the max pulse polio? What is the pulse polio? Polio immunization. Okay, up to 5 years guys. Pulse polio immunization and AFP surveillance. Acute flaccid paralysis surveillance. Which age group we do guys? Acute flaccid paralysis surveillance. PPI means pulse polio immunization up to 5 years. AFP surveillance, what age we will do? That is one question. Second question is, nowadays we are giving bivalent OPV, that is 1 and 3 plus IPV. IPV will provide all 3 strains. This is called as what? This is one question. This is the second question. Okay, fine. AFP surveillance we will do up to what age? Less than 15. Less than 15. Yes. And what is this called as? Bivalent OPV plus IPV. This we call it as the switch, guys. The switch. This we call it as the switch. Okay, fine. Next. What about malaria? Okay, malaria. What is the most common one? Now, most common and most dangerous is falciparum. Falciparum. Most common as well as most dangerous. Both are falciparum. Falciparum. What is the investigation you do? Peripheral smear. Second investigation what you can do is that rapid diagnostic test. This is used at field level guys. Field level. This INACT, this was asked. Okay, fine. Okay, field level. Field level, which test will you use? Rapid diagnostic test. Okay, in hilly areas and all, they can go and check the blood, check the blood and get the results quickly. A peripheral smear means you require microscope and all. Okay, fine. Vivax treat with chloroquine plus primaquine guys. Primaquine or Vivax. What about falciparum guys? Come on, you can tell me the treatment. Falciparum, what is the treatment? Falciparum in northeastern states. Northeastern states, what is the treatment? Okay, falciparum in northeastern states. Falciparum is ACT therapy. Artesunate, sulfadoxine plus pyrimethamine. Pyrimethamine. What about this one guys? Falciparum in northeastern states. Northeastern states. Okay, northeastern states it is artemether plus Lumefantrine. Okay, artemether plus lumefantrine. Okay, fine. We have various indicators will be there for malaria. Okay. The most important one is annual parasite incidence. This is the most important one, guys. Okay, annual parasite incidence. Okay, this is the most important one. Second is, okay, annual blood examination rate. Annual blood examination rate. This indicates operational efficiency. This indicates operational efficiency. The best one is annual parasite incidence. Annual blood examination rate indicates operational efficiency. Okay, fine. Too much content. Dengue, how many serotypes? Let me reduce the content. We'll make it easy. Fine. Okay, dengue, how many serotypes are there, guys? Okay, dengue, we have 4 serotypes, guys. Okay, we'll start dengue. And dengue, what is the vector for dengue? Aedes aegypti, guys. Okay, Aedes aegypti. Fine. Aedes aegypti. Aedes aegypti. You are unable to find this video. Are you guys able to follow or not able to follow, guys? Yes or no? Are you guys able to follow? Okay, so four serotypes are there. Aedes aegypti. Why dengue hemorrhagic fever happens? Okay, fine. Dengue hemorrhagic fever, the patient will have thrombocytopenia. Okay, thrombocytopenia, raising hematocrit, guys. Raising hematocrit. Third is positive tourniquet test. Okay, this question was asked in your exam. Why dengue hemorrhagic fever happens? Dengue hemorrhagic fever happens because of reinfection. Reinfection. Okay, reinfection. The patient is already infected with one serotype and reinfected with another serotype, guys. Okay, reinfected with another serotype. Now it's coming or lagging? Some form of fine. Reinfection, guys. Okay, the patient is already infected with one serotype, reinfected by another serotype, guys. Reinfected by another serotype. Okay, so this we call it as reinfection, guys. Reinfection. Okay, fine. Now works now. Fine. Now, and what is the treatment? No specific drug of choice, guys. No specific drug of choice. Fluids. Okay, plenty of fluids, guys. Plenty of fluids. Plenty of fluids. What I will do is that we'll come back to the diseases after some time. It's very monotonous for me also. Fine, fine. Fine. Now, we'll come back to disease. Okay, what is this answer, guys? What is this called as? What is this time? Time between first possible point and usual time, guys. What is this called, guys? Okay, what is this called as? We'll come back to that. We'll go back to the disease again. You tell me now. First possible point and usual time of diagnosis. What is this called as, guys? Okay, what is this called as? Excellent, man. This is called as lead time. This we call it as lead time. The time between first possible point and final critical point. What is this called as, guys? Okay, what is this called as? The time between first possible point and final critical point. Final critical point. This we call it as, yes, screening time. This we call it as screening time. First possible point and usual time of diagnosis. Okay, first possible point and final critical point. This we call it as screening time. Screening time. Screening people for their own benefit. What is this called as, guys? Okay, screening people for their own benefit. This is called as prescriptive screening. Screening people for their own benefit. This we call it as prescriptive screening. Screening people for others' benefit. This we call it as prospective screening. This we call it as prospective screening. Example is immigrant screening. Okay? Example is immigrant screening. You are screening people for others' benefit. Okay, so people coming from outside India, they are being screened for diseases. Okay, so for whose benefit they are being screened? Okay, they are being screened so that they will not come and transmit disease to us. That we call it as others' benefit. That we call it as prospective screening. Screening for their own benefit is called as prescriptive screening. Own benefit. What is sensitivity means what? You should know the formula and statement, guys. Sensitivity means ability of the test to identify true positives. Okay, that is sensitive. Ability of the test to identify true positives. What is the formula? True positives. Denominator is true positives plus false negatives multiplied by 100. Just keeping it simple, guys. Okay, fine. This itself is enough for you. Okay, so sensitivity means ability of the test to identify true positives, that is diseased people. Okay, fine. What is specificity? Specificity means ability of the test to identify true negatives. True negatives. Who is true negatives? True negatives means they are non-diseased people. Non-diseased people. Okay, sensitivity means ability. Your exam, don't make it complicated, keep it simple. Okay, especially these concept based topics. Okay, you need not to go very deep to the level of INICT and all. Okay, stick on to NEET. Less than NEET is enough for you. Okay, the ability of the test to identify true negatives. This true negatives means non-diseased people. What is the formula for that? What is the formula? True negatives by true negatives plus false positives multiplied by 100. Okay, true negatives by true negatives plus false positives. Okay, fine. This we call it as specificity. Specificity. What is positive predictive value? Positive predictive value means probability a person with a positive test having the disease. The probability a person with a positive test. Suppose you are getting 10 results positive. Okay, the positive predictive value is 50%. What does it mean? That means out of 10 results, really 5 are positive. You are getting 10 results positive. So out of this, 50% means only 5 are really positive. The formula is true positives, denominator are all are positives. True positives by true positives plus false positives multiplied by 100. This is positive predictive value. What is negative predictive value? Negative predictive value means probability a person with a negative test not having the disease. Probability a person with a negative test not having the disease. So true negatives, denominator is true negatives plus false negatives multiplied by 100. Denominator all are negatives, guys. All are negatives. Okay, fine. So we have seen sensitivity, specificity, positive predictive value, negative predictive value. Now what is the relationship between prevalence key point? Okay, so prevalence is directly proportional to positive predictive value. These 5-6 things, if you are remembering from this topic, that is enough. One is that what is lead time, prescriptive screening, prospective screening. Then okay, you have to tell me what is sensitivity, that is true positives, specificity, true negatives, positive predictive value, denominator all are positives, negative predictive value, denominator all are negatives. What is the relationship between prevalence and positive predictive value is they are directly proportional. Directly proportional. What is this Janani Suraksha Yojana? Okay, let's see that. What is JSY? JSY, okay. What is this program is related with what? Now tell me what is this program. Under this program we have ASHA is there. ASHA will be there for every 1,000 population. Janani Suraksha Yojana, you tell me what is the purpose? What is the purpose? Okay, fine. She will be between 25 to 45 years. 25 to 45 years. 10 standard. What is the program? What is this program? This program is related with promoting institutional delivery. Institutional delivery. Okay, promoting institutional delivery by providing cash incentive for the mother. Okay, promoting institutional delivery, okay, by providing cash incentive to mother, guys. What program, what purpose, we should know, guys. Promoting institutional delivery, a cash incentive we are giving for mothers. Okay, ASHA will be there for every 1,000 population, 25 to 45 years, 10 standard. Okay, and she will be resident of the village, guys. Resident of village. Okay, she is the resident of the particular village. Okay, fine. What is the role of ASHA? ASHA will be, okay, escorting the mother, guys. Escorting mother during delivery, guys. Okay, delivery. She will have studied up to 10 standard. She will be escorting the mother, and this is the role of ASHA. And ASHA will be given, okay, performance based incentive. There is no fixed salary for ASHA. ASHA is multiple times asked question, guys. Multiple times asked questions, appointed by panchayat and all, that is fine. What is this JSSK? What is this program? The beneficiaries are pregnant mothers, sick infants. What they will get benefit? They will get free treatment, that is free OPD, free lab. They come to hospital, free food, free transport, free blood. Everything is free, guys. This we call it as JSSK, Janani Sishu Suraksha Karyakram, for pregnant mothers and sick infants, guys. For pregnant mothers and sick infants. Okay, fine. Next. What is this NSSK, guys? Now just Sishu Suraksha Karyakram. I think it was asked last exam, I think. NSSK. NSSK is related with what? In rural areas, we don't have enough pediatricians. So what is this is related with? Train doctors and health workers. In what? This is related with what? NSSK. Now just Sishu Suraksha Karyakram. Train doctors and health workers. Yes, in newborn care. Newborn care and resuscitation. Resuscitation and prevention of Hypothermia. It was asked, guys. Okay, it was asked in your, okay, I think last exam. Okay, newborn care and resuscitation, prevention of hypothermia, NSSK, Navjat Sishu Suraksha Karyakram. What about IMNCA? IMNCA, what is the age group we include, guys? What is the age group? Age group we include. Okay, what we do, we train health workers. We train health workers managing a sick child, guys. Okay, we are training community level health workers and managing a sick child. Age group we will screen is 0 to 5 years, guys. 0 to 5 years. That is the age group we will screen, 0 to 5 years. Whenever a child comes, what they are supposed to do? Assess the child, classify illness. Third is identify treatment, guys. Identify treatment. Whenever a child, sick child is brought to you, the health workers, they will do assess, classify and identify treatment. When you are identifying, they will be going for 3 color coded mechanisms. They will go. What are the 3 color coded mechanisms? Okay, one is that, okay, if it is home treatment, if it is OPD treatment, pre-referral treatment and referral, guys. Third one is pre-referral treatment and referral. What is the color coding, guys? Can you tell me pre-referral treatment and referral? What is the color coding? Can you tell me what is the color coding, guys? Home treatment means it's green, guys. Green. Yellow means, okay, OPD. Pre-referral treatment and referral is pink color, not green, not red, guys. It is pink color, pink color. This is IMNC. Recently also we got a question from this. Okay, so home means green, yellow means OPD, pre-referral treatment is referral. What is this RBSK? Rashtriya Bal Swasthya Karyakram. So this is child screening and early intervention. We are going to screen the children and early intervention. Okay, which age group we are going to screen? 0 to 18 years. 0 to 18 years. Okay, who is going to screen? What are the things we'll screen? We'll screen for 4 Ds. Okay, defects at birth, deficiency disorders. Third is developmental delay, guys. Deficiency disorders, developmental delay, and fourth is diseases. Where multiple time asked question, whose responsibility is this? Is it subcenter, PHC? Whose responsibility? RBSK is the responsibility of primary health centers responsible. Multiple times recently asked. PHC is responsible. Okay, child screening and early intervention, 0 to 18 years, defects at birth, deficiency disorders, developmental delay and diseases. Ujjwala scheme is related with what, guys? Come on, this you should know. Okay, Ujjwala scheme is related with prevention of women and child trafficking. Prevention of women and child trafficking. Prevention of women and child trafficking. This is Ujjwala scheme. Ujjwala scheme. Lakshya. What is Lakshya is related with what? Lakshya. Lakshya is related with Lakshya. Labor room quality initiative. Labor room. All the labor room, they should maintain some standards. That we call it as Lakshya. Labor room quality initiative. What about this Ayushman Bharat? Okay, Ayushman Bharat. We have the component of health insurance was there. How much coverage was given, guys, in this health insurance? How much coverage? A coverage of 5 lakhs per family per year. 5 lakhs. Okay. Secondary and tertiary level of care. Okay. 5 lakhs per family per year. This is health insurance. This is health insurance. 5 lakhs family per year. Ayushman Bharat. What is this PMSMA? Pradhan Mantri Surakshit Matrita Abhiyan. Okay. This is free antenatal clinics on 9th of every month to identify high risk pregnancy. Identify high risk pregnancy. A free antenatal clinic on 9th of every month to identify high risk pregnancy. What about Anemia Mukt Bharat? Okay, what about Anemia Mukt Bharat? What is this 6 into 6 into 6 matrix? Okay, multiple times recently asked. What is this 6 into 6 into 6 strategy? Okay, 6 beneficiaries are there. Okay, 6 interventions are there. Iron folic acid tablets we provide now, that is interventions. 6 institutional mechanisms are there. 6 beneficiaries are there, 6 interventions are there, 6 institutional mechanisms. This is Anemia Mukt Bharat, guys. This is Anemia Mukt Bharat. Health systems in India, guys. Okay, fine. What is the health systems in India in rural areas and urban areas? We will see. In rural areas, we'll see one by one. We'll come back here. Subcenter. Okay, so we'll see subcenter. Subcenter will be there normally in a rural area for every 5,000 population. Hilly areas means 3,000 population. Hilly areas means 3,000 population. And what is the type A and type B? Okay, that was asked in your exams. Type A subcenter means no deliveries. Okay. Type B means deliveries conducted. Okay. Deliveries conducted. What is the difference here? Okay. We have male and female health worker. Male and female health worker. Male health worker, female health worker will do most of the jobs. Male health worker, they will be extra work is malarial surveillance. The commonly asked concept. Okay. Malarial surveillance, that is done by male health worker. Type A and type B, guys. Okay. Type A means no deliveries. PHC. Normally 30,000 population. Hilly areas means 20,000 population. Okay, fine. Hilly areas means 20,000 population. Here also type A and type B. Type A means less than 20 deliveries. Less than 20 deliveries. Type B means 20 or more than 20. Type B. Type B means 20 or more than 20 deliveries. 6 subcenters it will come under it. 6 subcenters. 6 beds will be there. We got doctor we have. This is the first place of doctor between contact between doctor and the community. First place. We are talking about rural area, guys. Rural areas. Okay, fine. Community health center. Community health center. We have this 80,000 to 1.2 lakh population. 80,000 to 1.2 lakh. 30 beds will be there. 30 beds. 4 PHCs will come under it. 4 primary health centers will come under it. Specialist will be there. Community CHC. So we have specialist will be there. Specialist, physician, surgeon, OGIan, pediatrician, like that. We have a specialist will be there. So this is CHC, guys, community health centers, community health centers. This is in rural areas. Now what about urban areas, guys? In urban areas, okay, this is the infrastructure that was launched, okay, initially. For every 1000 to 2500 population, one ASHA. For every 10,000 population, ANM. ASHA only, man. Follow ASHA. ANM, auxiliary nurse midwife. For every 50,000 population, urban PHC, urban primary health center. For every 2.5 lakh population to 5 lakhs in metros, guys, metros. Okay, we should have a urban CHC, urban C. Okay, so this is every 2.5 lakhs to 5 lakhs. Okay, urban CHC. Okay, fine. So am I clear? Recently, under this what we have is called, okay, under Ayushman Bharat, all the sub-centers, okay, under Ayushman Bharat, all the sub-centers are converted into health and wellness centers. Okay, in this context, in urban areas also, previously there is no sub-center, but in urban areas, they created a health and wellness center sub-center. That was created for 15,000 to 20,000 population. With one doctor should be there. This is newly created. This is newly created. Okay, HWC means Health and Wellness Center, Sub-Center for 15,000 to 20,000 population with one doctor should be. This is newly created. Remaining structures are same. Okay, and also they created polyclinics, leave polyclinics. At least we should know this one, guys. Okay? The Health and Wellness Sub-Centers in urban areas also they created. Previously, it was not there. Okay, fine. Yes, Arogya Mandir, fine. Arogya Mandir. We'll go into biostatistics. Okay, fine. What is data? Data, we are going to divide them into quantitative. Quantitative means measurable, guys. Height, BP and all. Okay, fine. Second is qualitative, not measurable. Be countable. Be countable. Example is not measurable, only countable. Example is sex, religion, how many males are there, how many females. This we call it as qualitative data. Okay, we have to understand this. Okay, fine. Now, what is mean? Mean means average. What is mean? Mean means average. You add all the numbers divided by total numbers. It is affected by outliers. Outliers or extreme value. Suppose you have 10 numbers are there. You add all the 10 numbers given by that gives the mean. But if there is an extreme value is there, mean will be affected. Okay, this concept was added. Now in a data, if there is an extreme value is there, we should go for median. What is median means? Middle value. Arrange data in either ascending or descending order. Arrange the data in either ascending or descending order. Used in outliers. Whenever the data has an outlier, better we should go for this one, guys. Better we should go for this one. If there is outlier is there, we should go for median. Okay, fine. What is mode? Mode means most repeated value in the database. Okay, what is mode? Mode means most repeated value in the data. The one which come again and again, most repeated value in data. which number comes again and again, that we call it as mode, most repeated value in the data. What is range? Maximum value minus minimum value. This looks simple, but this is asked in this topics. Okay, maximum value to minimum value, that we call it as range. Okay, fine. What is standard deviation? What is standard deviation? Standard deviation is, formula is square root of summation x minus x bar the whole square by n. N means number of people. If n is more than 30, this is the formula is used. N is more than 30, equal to or more than 30, this is the formula should be used. Summation x minus x bar the whole square n minus 1 if n is less than 30. This is the second formula. The second formula, when n is less than 30, n minus 1 we should go for. If n is more than 30, this is the formula we should use. What are the properties of normal distribution? This is a normal distribution curve. Okay, fine. What are the properties of this? What are the properties? Okay, this is multiple times asked concept. What are the properties? I'm not going very deep here. One is, okay, maximum area is equal to 1. Mean, median, mode, all should be same. Mean plus or minus 1 standard deviation corresponds to 68% of the area. Mean plus or minus 2 standard deviation 95% of area. Mean plus or minus 3 standard deviation 99%. Commonly asked one is 1 standard deviation how much percentage, 2 means how much, 3 means how much percent. So commonly asked question. Okay, 1 standard deviation. Okay, fine. Next. The images are asked sometimes. What is this image, guys? First is, this is a simple bar diagram. A simple bar diagram. Okay, fine. Simple bar diagram. This is all are used for qualitative data, guys. Qualitative data. Those are countable, guys. Countable. Okay, education, illiterate. Okay, fine. What is this one, guys? What is the second one? It was asked as image based question. What is this one? Second one. What is this one and what is this one? Second one is what? This is multiple bar diagram. Multiple bar diagram. Okay, multiple bar diagram. Side by side, you are comparing, guys. Two things are side by side, you are comparing. Okay, fine. This we call it as component bar diagram. Component bar diagram. This is pie chart. Pie chart. This is pie chart. So you are saying histogram. Histogram will be like this. There is no space between the bars. Histogram will be like this. The histogram. The difference between bar chart and pie chart is that in bar chart there will be space will be there. In histogram there is no space will not be there. Okay. One more diagram is there. Line diagram. What is the use of line diagram? Line diagram will tell you trend of the event over a period of time. Trend of the event over a period of time. That is line diagram. It will be like this. What is the trend of cases reported? Like this. Okay, it goes like this. This we call it as line diagram. Line diagram. This will tell you trend. Time will be there here. Time will be there in the x-axis. What is the trend of COVID cases? What is the trend of cholera cases? What is the trend of your marks? Okay, that also we can create it, guys. Okay, fine. Next, we'll go into environment, guys. Okay, we'll try to finish it. Okay. environment. Okay, water. We'll start with water. Okay, how will you find? Okay, you want to do chlorination. Okay, slow sand filter. What is the name of the layer that is formed? That is called as biological layer, guys. Biological layer or layer of Schmutzdeck. That is a layer form. That is biological layer or layer of Schmutzdeck. Schmutzdeck. This is slow sand filter. Okay, next water comes for chlorination. So the main chlorination, the main disinfecting action. The main disinfecting action is hypochlorous acid, guys. Hypochlorous acid. Main disinfecting action is hypochlorous acid. Okay, how much should be the contact point? Okay, the chlorine demand. Okay, this is done by Horex apparatus. This is done by Horex apparatus. Okay, chlorine demand. So minimum contact should be, all are MCQ. Minimum contact should be 60 minutes. The residual chlorine should be, how much should be the residual chlorine? Should be 0.5 milligram per liter, guys. Okay, drinking water. Okay, there is should be 0.5 milligram per liter. What is the name of the test? Test is orthotolidine test. Orthotolidine arsenite test. Okay, they will turn into yellow color. If chlorine is there, they will turn into yellow color. They will turn into yellow color. Orthotolidine test and orthotolidine arsenate test. Excellent. Solid waste disposal. Okay, fine. Which is the most insanitary method? Okay, which is the most insanitary method? Second, which is the most sanitary method? Okay, fine. Third, how will you dispose it in a for camps? The most insanitary method is for solid waste disposal is dumping. Dumping. Most sanitary method is controlled tipping. Is controlled tipping. Okay, fine. Now tell me which is the method used for camping. For camping purpose, which method is used? For camping, we can go for deep burial. Okay, deep burial. Okay, solid. For camping, we can go for deep burial. Deep burial. What is sewage? What is sullage, guys? What is sewage and what is sullage? Sewage means wastewater with excreta. What is sullage? Wastewater without excreta. Without excreta, that is sullage. All the waste should go to sewage treatment plant. Okay, sewage treatment plant. Again, this year the question was asked, which is considered as the heart of the aeration tank. Okay, which is considered as the heart of the aeration tank. Okay, sullage, which is considered as the heart of the aeration tank. That is activated sludge process. Okay, fine. Okay, this year question is activated sludge process, which is considered as the heart of the aeration tank. That is activated sludge process. Okay, fine. Yes. What are the indices of thermal comfort? Humidity is measured by a psychrometer, hygrometer. A cooling power of air. How will you measure the cooling power of air? Cooling power of air is measured by cooling power of air. How will you measure, guys? Carter's thermometer. It also measures low air velocity. Low air velocity. Carter's thermometer. And we have this cooling power of air, low air velocity. And we also have these images we have. This is Horrocks apparatus. This is Horrocks apparatus. Horrocks apparatus. What about this one? This is globe thermometer. Globe thermometer, it measures mean radiant heat. It measures mean radiant heat. Globe thermometer measures mean radiant heat. Mean radiant heat. Okay, fine. This is globe thermometer. What about this one? This you can keep it in hand. You will rotate like this. You will rotate like this. This was asked in your exam. This we call it as sling psychrometer. This we call it as, this is asked in NEET exam. This is Carter's thermometer. This year NEET exam it was asked. Carter's thermometer. In NEET exam it was asked. Sling psychrometer, and this one is Carter's thermometer. Carter's thermometer. Okay, fine. Okay, another 20 minutes, guys. 20 minutes. By 10 o'clock we should be able to finish. What is cost benefit analysis? A cost benefit analysis. Cost is compared with economic benefits. Not useful. This is not much useful to us. Okay, not much useful. A cost is compared with the economic benefits. Cost effective analysis means cost is compared with effectiveness in terms of disease, deaths prevented. This is more useful in medical field. More useful. This is more useful in medical field. This is cost benefit and cost effective analysis. What is these 2-3 things? You can tell me what is this ABC analysis, DD analysis. Both are used for inventory management. Okay, both are used for inventory management. Okay, I saw one question. Okay, ABC inventory means, suppose what are the stocks I have. Suppose I have machines I have, means okay, how to maintain it. That is ABC analysis and inventory and VED analysis. Methods of group communication. Okay, fine. I will use demonstration, guys. Demonstration. Okay, suppose I want to, when will I use demonstration? Whenever I want to use, okay, I want to teach a skill, guys. I will use demonstration. How to make ORS. Okay, how to do percussion. I will use demonstration. Second is group discussion. Group discussion. 6 to 12 members they will discuss, guys. Okay, I'm trying to cover every topic here. Group discussion, 6 to 12 members they will sit and discuss. There will be a leader will be there. Note taker will be there. Very effective method, guys. Very effective method of communication. Third, panel discussion. Panel discussion means 4 to 8 experts they will discuss on a particular topic. That is panel discussion. Next is symposium. Symposium means series of lectures by experts. Okay, one person will come and talk on etiology, another person will come and talk on clinical features, another person will come and talk on treatment. That is called a symposium. Panel discussion means 4 to 5 people they will sit and discuss on a particular topic. As an audience we can raise questions. Fifth one, what is workshop? Workshop means series of small meetings. Series of small meeting with hands-on training. Okay, basic life support workshop, advanced life support workshop, suturing workshop. Okay, once you become intern you will know that those things. These are workshop, series of small meetings. What are the different approaches in health education? One is regulatory approach. Okay, even though it's a good thing, government is forcing us to do it. Example, helmets. Okay, not much useful, guys. Second is service approach. Providing services at doorstep. For example, toilets in rural areas. Providing services at doorstep. People are giving constructed toilets. Government they construct toilet in rural areas. Even though if you provide services at doorstep, people may not use. Third is health education approach. This is based on planned learning experience. Planned learning experience. Okay? So as a student, you will prepare some charts, you will prepare the content, you make people assemble and you will sit and explain. This we call it as health education approach. The last one is primary care approach. Primary care approach. Okay? This is planning for themselves. Okay? For themselves. This is the best one, guys. The best one. Okay, propaganda means you will instill on the minds of people. Okay, you will not let them to think for themselves. Okay, propaganda. Okay, you will say, okay, just follow this. This propaganda means anything. Okay, anything can be done. Health education means you will tell what are the pros, what are the benefits. Let them take themselves a decision. But propaganda means can be done. Okay, nowadays what? YouTubers they will say review the movie is not good, not good, not good, or otherwise also they will say it's good, it's good, it's good. That is propaganda. Okay, fine. They are instilling something. This is the best one, guys. Primary care approach, this is the best one. It was asked in your exam, guys. Which is the best one here? Primary care approach is the best one. Pushpa 2, I don't know, man. I have not seen. Okay, fine. What are the stages of disaster? Okay, disaster impact will be there, then response, relief phase, rehabilitation. Okay. Third is and next is disaster mitigation. Okay, mitigation, preparedness, finally impact, guys. Okay, fine. So these are the stages of disaster, guys. Impact is there, then people will respond to it, relief phase will come, rehabilitation. Okay, these 4 things are done after disaster. Okay, after disaster, these 2 are done before disaster. These 2 are done before disaster. Okay, fine. Now, triage means what are the color coding we will be doing? Triage. You will be doing at the site, guys. Site. Red means high priority. Red means high priority. Yellow means medium priority. Green means ambulatory. Black means it is dead person. Okay, fine. Dead. Recently asked, guys. Okay, fine. Red means high priority, yellow medium, green means ambulatory, black means it's dead persons. Okay, fine. Cancers. Okay, what is the most common cancer in males? Males overall. Most common cancer in male is oral. Female is breast. Overall, it is breast. Okay, fine, breast. What is the most common occupation? No, oral cancer is the most common cancer. Okay, among males. Most common occupational cancer is 75% of them are skin cancer. Okay, most common occupational cancer is skin cancer, but overall most common cancer in India is breast cancer. Okay, fine, breast cancer. Hypertension, what we should know? Okay, one is rule of halves, guys. Rule of halves. You would have seen the image. Okay, like this, it will be there now. Okay, like that. Okay, this is rule of halves. Okay, what does it mean? Hypertension is highly asymptomatic disease. Only 50% of them will know that they are having hypertension. Among them, 50% will be on treatment like that. Second is tracking. What is tracking mean? Just know the terminology. Identifying children at risk of hypertension. Okay, identifying at children at risk of hypertension in future days. Okay, fine. Those children having low blood pressure, definitely in adult also they will have high. Those children having high blood pressure, definitely adult also they will become high blood pressure. So you can identify them and you can treat them early. Okay, fine. Third is we can use a diet called as DASH diet. Okay, for hypertension you can use a diet called as DASH diet. Dietary approaches to stop hypertension. That is DASH diet. You can. Okay, fine. So again, what is used is steps. I have seen in your papers also. Okay, this is NCD risk factor survey, guys. The steps is NCD risk factor survey. Okay, fine. It is also asked in your exam. Okay, what is steps approach? You write it as steps approach. NCD risk factor survey, guys. Okay, fine. What is biomedical waste categories? Okay, yellow color bin. What are the things you will put? Human waste, animal waste. Okay, common things I will ask: blood bags. Okay, human waste, animal waste, blood bags is asked. Okay, discarded medicines. Okay, linen with contaminated linen. Okay, live vaccines are there. Okay, live vaccines are there. Okay, culture media. Okay, culture media. All these should go to yellow color bin. What about red color? Commonly asked things I will show. Commonly asked. Okay, fine. Gloves. Okay, syringes. Okay, gloves is being asked. Syringes are being asked. Okay, fine. Then what we have is Rails tube. Catheter. Fine. Syringes without needle only. White needles and blades. Okay, white needle and blades. What else we have? We have is that blue. Okay, needles and blade. Okay, sharps. This one is blue is vials. ampules, and metallic implants. Okay, what was asked is pacemaker. Pacemaker was asked. Metallic implants, pacemaker. Okay, pacemaker was asked. So this is biomedical waste management categories. Next is international health. What is asked? Let me focus here. Okay, who contributed to Applied Nutrition Program of India? Which international agency? Okay, SIDA contributed to what? Danida contributed to what? Rural toilets. Which international agency contributed? Cobalt plant development. Cobalt plant development. Who contributed this? Okay, fine. Applied Nutrition Program, UNICEF, SIDA TB program, they contributed. Danida blindness program, guys. Okay, rural toilets is Ford Foundation. Cobalt plant development, it is Colombo plant. Last 5 years, probably this was as last 3 years. This is international health, guys. This is international health. Some topics we left, communicable disease, we'll finish it, guys. Okay. Very monotonous, that's why I changed there at the time. "15 minutes, just bear with me." What about rabies, guys? Rabies is, what is rabies? What is the rabies free area? Free area means no case for 2 years. That is rabies free area. What we should do following any bite? 15 minutes wash with soap. Okay, no suturing, guys. Okay, no suturing immediately. Just wait for 24 to 48 hours. You wait it, guys. Okay, just wait for 24 to 48 hours. 15 minutes. Okay, then you have to categorize it. Okay, category 3 means bleeding is there. Bleeding is there, then it becomes category 3, guys. Category 2 means abrasions. Okay, is there. Okay, category 3 means you have to provide vaccine plus immunoglobulin. Category 2, there is no bleeding. Okay, there is abrasion is there. Okay, no bleeding, you have to provide vaccine, guys. Okay, you have to provide vaccine alone is enough. We have various regimens are there. The first one is Essence regimen, 0, 3, 7, 14 and 28 days. IM regimen, 0.5 ml we are going to provide. IM regimen, Essence. Second is updated Thai regimen, 0, 3, 7 and 28 days. How many days we are going to provide is intradermally, 0.1 ml. This is what we give in the hospitals and all. Suppose you are worried that you have a chance of dog bite. Pre-exposure prophylaxis, you want to take 0, 7, 21 or 28 days. Okay, fine. 0, 7, 21 or 28 days. Post-exposure already vaccinated. Post-exposure already vaccinated is 0, 3 days. 0 and 3 days. Okay. Essence regimen, updated Thai regimen, pre-exposure, post-exposure, already vaccinated. Now, we can provide immunoglobulins. Immunoglobulins as early as possible. IG not later than 7 days. Not later than 7 days. Immunoglobulins you can provide not later than 7 days. Just don't worry, guys. Okay, updates and all for your exams. You just focus what is in your hands. That is enough. We said that BPALM, okay, 𝐒𝐿, those things are important. Okay, fine. 𝐒𝐿 portion, Ambian, okay, 1,000 rupees we are providing. Okay. Leprosy is one of the disease we have eliminated. What is the treatment for leprosy? Possibacillary 5 or less than 5 lesions. Okay, you will provide rifampicin. Rifampicin monthly, dapsone daily. As of now, this is the treatment, guys. Unless they say WHO guidelines. Okay, as of now, this is the treatment. This you will provide it for 6 months. Multibacillary. Okay, 5 or more than 6 lesions. Okay, you will provide rifampicin, dapsone. Third one is clofazimine you will provide. Okay, daily. This is for 12 months. Okay, 12 months. 5 or less than 5 lesions, this passibacillary. 6 or more than 6 lesions, then we call it as multibacillary, guys. Okay, for 12 months. This year they added one more questions. Logo, please find it, guys. Okay, I didn't add images. NLEP logo. It was asked National Leprosy Eradication Program. And we have a campaign is there called as Sparsh campaign, guys. Sparsh campaign. Awareness campaign. Okay, awareness campaign for leprosy. And what is the girl name? She creates awareness on leprosy. Her image also was as girl name. Awareness. Awareness creating girl. School girl. Okay, okay. Sapna, guys. Update में दोनों का same duration था. Update. Listen. Update is, understand, the update is WHO. WHO guidelines. According to WHO guidelines, possibacillary 3 drugs is given, multibacillary 3 drugs is given. Okay, but possibacillary for 6 months, multibacillary for 12 months. India will follow the guidelines from April 2025, guys. Your exam is now. Okay, the April 2025 only India will follow the WHO guidelines. Okay? WHO guidelines says that 3 drugs for 6 months. Okay, which we are not following as of now. What is the name of this? This is called as 𝐒𝐿, guys. Online portal for leprosy. Okay, online portal for leprosy. Okay, fine. This is 𝐒𝐿. HIV and STD. HIV, if you see, okay, HIV. What is the current guidelines for HIV? HIV, we need to know what is 90-90-90. 90-90-90 means, okay, out of the estimated cases, okay, 90% should know their status. Among them, 90% should be on treatment. Among them, what you have 𝐒𝐿, guys. I don't know what is 𝐒𝐿. 𝐒𝐿 is related with TB, guys. 𝐒𝐿 is related with TB. Online portal for TB. Rajput, that Prashant, that is online portal for TB is 𝐒𝐿. This 𝐒𝐿 is related with leprosy. 90-90-90 is associated with HIV. Okay, if anybody is HIV positive, immediately start. Yes. 𝐒𝐿 is for TB. Yes. Immediately start lifelong ART. Lifelong ART you should start immediately. What is the drug we are going to provide? Okay, drug we are going to TLD, guys. TLD. What is TLD? That is 𝐒𝐿, guys. That is 𝐒𝐿. NI. What you are asking is 𝐒𝐿. 𝐒𝐿. This is 𝐒𝐿, guys. Pregnancy kit is for 𝐒𝐿. Yes. Next is HIV positive, immediately start lifelong ART. What are the drugs we are going to provide? 3 drugs, guys. Tenofovir, lamivudine plus dolutegravir. Pregnancy is also HIV positive. Then same drug is given, guys. Tenofovir, lamivudine plus dolutegravir. Immediately start. Okay. For the baby, plus additionally what you do for the baby is that nevirapine syrup you will be providing. Nevirapine syrup for 6 weeks. Okay, nevirapine syrup you will provide for 6 weeks. What is this? STD clinic has been renamed as what? STD clinic is renamed as Suraksha Clinic. Okay, Suraksha Clinic, guys. Okay, so the logo also you go through it. STD clinic is Suraksha Clinic, guys. Okay, Suraksha Clinic. Last few, guys. What is this one, guys? Image based question. It was asked in your exams, man. Come on. What is this one? This is Anopheles, guys. Anopheles transmits malaria. It was asked in your exam. What about this one? This exhibits hunchback. Hunchback plus no stripes. What is this one? No stripes. This is 𝐒𝐿𝐿𝐿𝐿. Breeds in dirty water, guys. It breeds in dirty water. Example is 𝐒𝐿𝐿𝐿. It breeds in dirty water, guys. What disease it transmits? Filariasis and 𝐒𝐿, guys. Filariasis and 𝐒𝐿. 𝐒𝐿𝐿 breeds in dirty water. Filariasis and 𝐒𝐿. This exhibits hunchback with stripes. Back plus stripes. This, what is this one? This is AIDS. This is AIDS. What disease it transmits? Dengue, yellow fever, chikungunya, Zika virus. Zika virus. Dengue, yellow fever, chikungunya, and Zika virus. What is this one, guys? This looks hairy. Smaller than mosquito. This is hairy. Okay, hairy. What disease it transmits? This is sandfly. Sandfly. What disease it transmits? Kala azar. This is Kala azar. No, that is not mosquito. Sandfly. This is Kala azar. What is the investigation you will do for Kala azar? RK39 kit. If anybody is found to be positive, the treatment is liposomal amphotericin B, guys. The treatment is liposomal amphotericin B. Smaller than mosquito, the hairy insect. Okay, so RK39 kit, liposomal amphotericin B. Okay, fine. What about yellow fever? Okay, what are the key points related with yellow fever? Yellow fever is, we have a vaccine available, 17D strain, guys. Vaccine is 17D strain, and once you have taken the vaccine, they will provide certificate. Certificate validity is 10 days to lifelong. Certificate validity is 10 days to lifelong. That is yellow fever. We follow one strategy called as I strategy. What is I strategy is, okay, elimination of yellow fever epidemic strategy. Elimination of yellow fever epidemic strategy. This is I strategy. Okay, fine. So we have completed, guys. So we have taken what? Okay, 17 minutes more we have taken. Okay, any questions, guys? Any questions? So just keep it simple, guys. Okay, my suggestion is that try to keep it simple. Okay, just all the best. Okay, this question, this subject gives you more marks. Weightage is more. Okay, and it's not complicated questions and all will not come. My suggestion is that any formulas, okay, just write small notes and all. Okay, go through it. At least what we have discussed, problems, expect problems, demography, MCH, nutrition. Okay, those things you prioritize. All small topics you prioritize. Okay, whatever time that was available to me, I was able to cover certain things. Okay, all of you will clear the exams. So believe strongly. Okay, study well. Okay, all the best for your exams. Okay, we'll see you again. Okay, during PG preparation. Okay, fine. Thank you. Thank you, guys. Thank you. Any queries means you can post it. I will send the PDF. PDF I will send.